Morning, Pradeep.
Morning, sir. Am I audible?
Welcome to all the delegates, my colleagues, for the 68th annual conference of Indian Society of Anesthesiologists. We're into the third day already, and sorry, second day. And It is my humble honor and, of course, pleasure to be chairing this session, to the next session for the next couple of hours with Dr. Anshul Jain. So I think we'll be starting with the e-presentations, right? Okay, all right. So we have the first speaker, Dr. Priyanka Jaiswal. I believe she has already joined. Dr. Priyanka, you got to unmute
Yes,
yourself.
sir. I'm here. Yes, sir.
Okay. So morning, Priyanka.
Good morning,
So
sir.
all rolling there. Yeah. Let's start. Over to you. So sorry for those who don't know me. I am Dr. Charu Saklecha. Right.
Okay.
Priyanka, you can start.
Good
Yeah.
morning.
Mic is all yours.
Yes.
You good, Priyanka?
Yes, sir.
Okay. So I can't hear anything. Is there a problem on my side?
Actually, sir, these are the recorded video they already asked, sir. So that was running the problem from that side.
Just not speaking.
Hello.
Can you turn on the volume?
Sir, actually recorded video sir हमने पहले से ऑफ किया था sir, तो all they already running sir, so I problem from that side.
Yeah.
Hello.
Protocol. Group R receive valid to UC get a tab lock with 0.375% rupee working, and Group RD receive valid to UC get a tab lock with 0.375
Is
rupee
Dr. Anshu around? Certainly, yes.
What is particularly myself, Dr. Priyanka Jaiswal from Department of Anesthesiology, Shamsha Medical College, Regua. I am going to present a comparative study of ropivacaine and ropivacaine with dexmedetomidine ultrasound guided tap block for post-operative anesthesia, laparoscopy, cholecystectomy. Introduction. Conquering pain is one of the greatest achievements of science. Without this surgery, we never have achieved the status it is enjoyed today. Inadequate control of post-operative pain lead to severe untoward adverse events such as stress and discomfort, prolonged immobilization, ascent hospital stay, thromboembolism, and pulmonary complications. Pain after laparoscopic cholecystectomy arises from proper insertion site, pneumoperitoneum, abdominal stress, and hepatic bed disturbance due to cholecystectomy. Various modalities have been used to alleviate the pain after laparoscopic cholecystectomy, which include non-steroidal anti-inflammatory opioid, thoracic epidural block, and multimodal analgesia. The TAP block is a peripheral nerve block designed to anesthetize the nerve supplying the anterior abdominal block. The block first described it in 2001. With increasing utilization of ultrasound guidance for more accurate and needed localization, the TAP block is now a safe and effective technique for elevating post-operative pain following abdominal surgery. Duration of TAP block is limited to the effect of administered local anesthetic. Recently, adjuvant medication were added to LA to prolong the effect of TAP block. So, in pursuit of multimodal analgesia for laparoscopic procedure, our study was designed to compare the efficacy of ropivacaine alone and ropivacaine with dexmedetomidine USC-guided TAP block following laparoscopic cholecystectomy for post-operative analgesia in first 24 hours post-operatively. Aims and objective to study and compare the mean versus per duration of analgesia and total dose of rescue analgesia required in first 24 hours post-operative to assess the patient satisfaction for post-operative analgesia to determine the safety of UC guided tap block for assessing the incidence of any adverse effect. Our study was a prospective randomized and controlled study which was conducted in Department of Anesthesiology, Shamsha Medical College and associated GMH and CMS Hospital, Riga. Our study period was April 19 to March 20. Material method. We included patient with executive ownership between 18 to 65 year age group, while patient with significant systemic disease, psychological disorder, pregnant women, patient with executive CN4, patient who refused to give consent for the study, allergic to alien coagulopathy were excluded from our study. After getting clearance from institutional ethics committee, 90 adult patients posted for laparoscopic cholecystectomy were randomized equally into group C received analgesia on institutional protocol, group R received bilateral UC guided tap block with 0.375% ropivacaine, and group RD received bilateral UC guided tap block with 0.375 ropivacaine plus 50 microgram dexmedetomidine. Under all accepted precaution with the standard monitoring, patient taken under general anesthesia. At the end of surgery, before extubation, after assuming full asepsis, UC guided tap block was performed using a mid-axillary represented real-time guidance with high-frequency ultrasound probe. A bilateral tap block was performed using implant technique by using insulated 20-70 bevel locoproc needle of length 50 mm. This was a sonographic image of a tap block. After condition of surgical procedure block, patient was transferred to the PACO. Pain severity was assessed using a behavioral analog scale, which was recorded at 0, 2, 4, 8, 12, 18, and 24 after block. If at any point of time was more than 4, ibuprofen at an incremental dose of 2 mg per kg was given as rescue analgesia. The duration of analgesia and total traumatic consumption was 24 hours by duly noted. Patient satisfaction score was assessed using 5-point scale, which was classified as highly satisfied to highly dissatisfied. The study ended 24 hours after surgery. Statistical analysis. All the measurement data were presented as mean plus standard deviation. A statistical process was performed using a species version 20. The categorical data analyzed by using task pattern, while quantitative data by 1 by ANOVA and student t-test. The data with p-value less than 0.05 was considered as statistically significant. In result and observation, the mean versus score was least in group RD, while maximum in group RC. Duration of analgesia was maximum in group RD, which was 7.7 hours in group RD, while 4.5 hours in group R and 2.7 hours in group C. Total opioid requirements was maximum in group C, which was 223 milligram and 160 milligram group R, and least in 116.6 milligram in group RD. Patient satisfaction score. Highly dissatisfied patient was a maximum in group C, which was a 16.7%, while none in group R and RD, while highly satisfied patient was maximum in group RD, which was 76.70%, and 40.0% in group R, while none in group C. Adverse event was statistically insignificant in all groups. Discussion. In our study, duration of analgesia was 2.7 hours in group C, 4.5 hours in group R, 7.7 hours in group RD. The difference was statistically highly significant. T-grown also between group R and RD. Similar results only Bansal Suna and Natal in their study. The total opioid requirement for 24-hour post-operative was less in group RD compared to group R and group C, which was statistically significant among three groups, also between group R and RD. Similar results were by surveys and et al. In their study. We found that average of mean was score first 24 hours was 4.59 in group C, 3.45 in group R, 3.33 in group RD, while when we compare group R and RD, was significantly low in group RD at 4, 8 and 12 hours after birth. Similarly, Lilly and et al. In their study. And the incidence of adverse event like bradycardia hypertension was 3.3% group RD that was easily manageable by patient of group R and C and no such episode. Similarly, surveys and et al. Also found in their study. A conclusion: the TAP block is a better modality for post-operative anesthesia and laparoscopic cholecystectomy surgery. The addition of daxamethasone to ropivac in a bilateral UC guided TAP block achieve prolonged post-operative anesthesia and reduce opioid congestion compared to ropivac alone without any major adverse effects. These are my references. Thank you.
In the research paper category, I'm going to present evaluation of QCON and QNOX indices in pediatric surgery under general anesthesia. It is essential for an anesthesiologist to monitor the depth of anesthesia to deliver an optimal dose of general anesthetic drug in order to avoid adverse effects of GA drugs. The EEG-based devices like bispectral index have been used for more than 2 decades to monitor the depth of anesthesia. They generally measure only the hypnotic effect and not the nociception. It still remains a challenge to measure the nociception as an individual component of depth of anesthesia. The CONAX monitoring system by Fresenius Kabi displays 2 parameters, namely QCON and QNOX. The QCON is an index of hypnotic effect and the QNOX is an index of pain or nociception, which generates the output on a 0 to 99 scale, similar to BIS. Both the values are extracted from raw EEG using an adaptive neurophysiology inference system. The primary aim of our study is to clinically evaluate the QCON and QNOX indices in pediatric surgery under general anesthesia. And our primary objective is to establish the relation of QCON with the anesthesia induction and recovery and the QNOX indices with the noxious stimulus in pediatric population. The secondary objective is to study the relation of QCON and QNOX indices with the MAC value of sevoflurane and its relation to clinical responses. After approval of the Hospital Ethical Committee, this prospective observational study was conducted at Army Hospital Research and Referral, New Delhi, the study population being pediatric patients undergoing elective surgery under general anesthesia. The study was also registered under CTRI. The pediatric patients of age group 1 to 12 years of both the sexes belonging to AAC grade 1 and 2 undergoing surgeries under general anesthesia using sevoflurane were included in the study. The patients with the severe systemic diseases, any syndromic child, emergency cases, and difficult anticipated airway were excluded from the study. The effect size was calculated by taking the difference between mean value of QCon before and after loss of consciousness under general anesthesia from the previous literature, and taking the alpha value as 0.05 and the power of the study as 90%. The sample size was calculated as 46, including 10% for loss of compounding. This study was conducted in pediatric patients of either sex in age group of 1 to 12 years undergoing elective surgery under general anesthesia. The anesthetic technique was balanced general anesthesia with or without regional analgesia. All patients underwent inhalational induction and maintenance using sevoflurane. The regional anesthesia was given either as epidural or caudal block using bupivacaine as per Armitage formula. The QCon and QNOX values were recorded intra-op during awake, induction, loss of eyelash reflex, intubation, before and after regional analgesia, surgical incision, cessation of anesthesia, emergence, extubation, and eye opening. All the pediatric patients admitted for surgeries were enrolled from 1st July 2020 to 31st June 2021. Total 72 patients underwent surgery under general anesthesia, out of which 46 patients were enrolled for the study. The remaining 26 patients were excluded from the study due to various reasons listed in the exclusion criteria. Most of the patients underwent urogenital surgery, followed by gastrointestinal, musculoskeletal, and other surgeries. Coming to the patient demographic details, total 46 pediatric patients with a mean age of 5.6 were enrolled for the study, and most of the patients were belonging to ASA category 1 and 2. And use of IGEL when compared to endotracheal tube was statistically significant with a p-value of 0.03. This table shows the value of QCon and QNOX recorded intraoperatively. Here we can see there was a significant difference in QCon before and after loss of eyelash reflex, and there at the same time there was a statistically significant difference in QCon value before and after in the extubation with a p-value of less than 0.01 noted. And there was a significant difference in QNOX as well as noted before and after giving regional analgesia with a p-value of 0.04. In this graph, we can see there was even though there was a significant drop and rise of QCon, QNOX upon induction and recovery respectively, there was no statistically significant correlation between the MAC value and the QCon, QNOX values with a p-value of more than 0.05 for both the values, QCon and QNOX. Here, this table shows the effect of regional anesthesia with the various parameters recorded intra-op. Here we can see there was a significant drop in heart rate with a p-value of 0.01 after giving regional anesthesia. At the same time, there was a significant drop in QNOX value were also noted with a p-value of 0.04. In this graph, we can clearly see there was a significant fall. The previous studies established that QCon is a better predictor of loss of consciousness, similar to BIS in adults. In our study, there was a simultaneous fall in both QCon and QNOX upon induction and rise while recovery. A difference of about 15 noted during loss of eyelash reflex and 32 during recovery from general anesthesia in QCon value noted with a significant p-value. At the same time, there was no change in QCon values noted in response to surgical incision, irrespective of regional anesthesia, which implies that QCon is a better predictor of hypnotic effect, but not a better predictor of nociception. There was early rise of QNOX value, then QCon noted during recovery, and there was also a significant fall in QNOX following regional anesthesia with a significant p-value was noted. There was a rise in QNOX with a surgical incision, irrespective of regional anesthesia was noted. However, there was a greater rise in QNOX following surgical incision in those who did not receive regional anesthesia was noted. And there was no significant correlation with the MAC values for both QCon and QNOX were noted. To conclude, the QCon was able to reliably detect either loss of consciousness or recovery during general anesthesia in pediatric population. At the same time, QNOX was also a reliable indicator of adequacy of analgesia and noxious response during general anesthesia. There were few limitations in our study. The use of intra-op electrocautery influenced the QCon and the QNOX values intra-op. There were frequent displacement of forehead sensor, especially in younger children, due to constant movement during induction as well as during emergence that lead to erratic reading of QCon and QNOX. However, data with a signal quality index less than 50 were rejected. And we also did not compare this QNOX and QCon value with the bispectral index, which is a gold standard for depth of anesthesia. Thank you.
Hi. Sorry, I missed
Good
a
morning,
little
sir.
bit of this presentation, unfortunately, because of this IT glitch again.
Sir.
So if I heard it correctly, I mean the MAC values. Sorry, I have just one question. MAC values did not correlate well with the INOX.
Yes, sir. QCon and QNOX. MAC value did not correlate with both the values, QCon and QNOX, sir, actually.
It doesn't correlate, and still, I mean, even with or without a decent MAC value, I mean, we are getting desired anesthetic response. Is that correct?
Sorry, sir. I'm not. Pardon, sir.
So I understand. I mean, the MAC
Sir.
values are not correlating well with the measured indices, right?
Yes,
But
sir. Yes, sir.
even with or without a desired MAC, you are getting the desired
Yes, sir.
anesthetic output, isn't it? Which is the depth of anesthesia. You're getting a reasonable depth of anesthesia.
Yes, yes, sir. Yes, sir.
Okay, right. Is that correct? I mean,
sir,
you understand
actually,
my
sir,
question, right?
upon induction, sir, actually, the MAC value rises. The MAC value rises very fast, sir, actually. But the QCon and QNOX doesn't correlate with the MAC value. The initial stages at
Right.
even as well as during extubation, actually. But it correlates with the loss of eyelash reflex and at the time of extubation, sir, actually.
So, I mean, we are measuring with regards to the loss of reflexes.
Yes, yes, sir, yes, sir. Our primary objective is to correlate with the clinical responses, basically loss of eyelash reflex and at the time of extubation and at the time of giving a regional epidural caudal. Yes, sir.
Yeah, yeah.
Yes, sir.
Okay. Right. All right. Okay. Fair enough. Okay.
Yes, sir.
I mean, we can move on to the next presentation. I mean, if there are no other questions here. Yeah.
Good afternoon, everyone. I'm Dr. Chavi Goel. My topic is an observational study to determine the utility of ultrasound in predicting endotracheal tube size in pediatric population. As we all know, routinely we are using age-based formulas to calculate the correct size of diameter and length of endotracheal tube, but many times it is not helpful. So our study was planned to find the utility of ultrasound in predicting endotracheal tube size in pediatric population. Compare the age-based formula with ultrasound method. We chose children less than 6 years of age who were receiving general anesthesia through endotracheal tube and were recruited after taking consent. We compared the age-based Coley's formula with the ultrasound method. For these patients, we measured the subclotic diameter using ultrasound, and in our study, we also compared the endotracheal tube length, which was derived from age-based formula, which was compared with actual length of tube at the angle of mouth when black line of ET tube is at the vocal cords. It was a prospective observational study carried on in KCGMC Karnal from January 2021 to August 2021. So we included children who were less than 6 years of age, posted for elective surgery, and who went GA with endotracheal tube intubation. Our sample size was 66 children with 90% power and 5% level of significance. So after taking consent and calculating the diameter of tube using age-based formula and length of tube using age-based formula, for children less than 2 years of age, this chart was used. We noted it down in the patient performer, and then a senior professor in anesthesia measured the transverse diameter of cricoid cartilage at air mucosa surface. 3 readings were taken and a mean was calculated. All the images were saved in flashcard and were analyzed by the radiologist. So we carried out a pilot analysis also in 15 patients for the same technique and used a frequency probe of 6 to 12 hertz. After giving GA, USG imaging was done to determine the subglottic diameter after stopping mask ventilation for less than 20 seconds. With head in neutral position and slight extension, We placed the linear probe on middle of anterior region of the neck. The hyoid bone was visualized, which appeared as an inverted U-shaped hyperechoic curvilinear line. After seeing the vocal cords, we saw the cricoid arch and measured the subglottic diameter, which was defined as diameter at the transverse air column at the cricoid cartilage level, which was measured between the margins of cricoid cartilage at highest possible resolution at the air mucosa interface. We took 3 readings and a mean was calculated. This is a diagram showing the subglottic diameter. So we use this table to choose the endotracheal tube size, and we did a leak test to check the correct size of the tube. And we compared these two methods using McNemer's test, and we had 47 boys and 19 girls, and around 21 children were less than 1 years of age and 45 were between 1 to 5 years of age. And most of them were ASA grade 1, and around 44 children were more than 10 kgs and 18 were between 5 to 10 kgs. So when we calculated the size of endotracheal tube using age-based formula, the mean was 4.3 mm, and by ultrasound the mean was 4.6 mm. The correct size mean was 4.7 mm. So this proves that ultrasound is a superior method than age-based formula. This is a pie diagram which shows that in 67% of children we could predict the correct ETT size using ultrasound method, and we could only predict correct size in 32% of children using age-based formulas. For calculating the length of the tube using age-based formula was 12.6, and by using black line at vocal cords it was 12.3. So this was also significant. So we can say that ultrasound is better method than age-based method for predicting the endotracheal tube size, especially in children. There were some limitations in our study. The leak test was assessed by individual observer, which can have variability. USG cannot view the posterior wall of trachea, and randomized control study is better, but we could not do it because of ethical issues. These are my references. Thank you.
So Chabi, hi, this is Charu again. Chari, if I understood it correctly again, I mean, you said, I mean, there are about 43% chances of us detecting the right size by of endotracheal tube by the calculations that we use. Is that correct?
Yes, sir. Yes, sir.
In pediatric population, isn't it?
Hello? Yes, sir.
Okay, right. And this is reference from where? I mean, if you can remember that.
Sir, actually, when we did the study, at that time we observed that the age-based formulas which we are routinely using are also very accurate. Like in 43%, the correct size can be calculated.
Right.
But if we use ultrasound, then the accuracy can be improved upon. Like in 67% of cases, we can calculate the correct size.
Yeah, I just need to understand, where does this reference of 43% comes from?
Sir, we when we did the study, we found out.
Yeah.
It was not from any book. This was
Yeah,
we
do you remember the
compared these
reference?
two methods. So this is
Right. Okay. All right. That's fine. We can move on to the next one, please.
thank you, sir.
Good morning, respected faculties and dear participants of Isacon 2021. I am Dr. Navdeep Sokol, additional professor in the Department of Neuroscience, Anesthesiology and Critical Care. So, I will be presenting a comparative study of efficacy and safety of endogenous goggles with fan versus standard goggles in healthcare workers in COVID ICU. As we all know that CDC has recommended PPE and 95 mask along with eye protection in the form of goggles or eye shield and as necessary tool for healthcare workers managing COVID-19 patient. But fogging of goggles and spectacles is very disabling for the healthcare workers. This not only hampers vision but effective patient care also. So we developed indigenous goggles with fan, which here the goggles are fitted with battery powered small fan, and which could possibly won't allow water vapors from the exhaled air to condense and settle on the inner surface of the goggles due to continuous movement of the exhaled air. And the same thing has been applied for the patent also. So we planned a pilot randomized clinical trial. CTRI number is given here. So we enrolled 30 healthcare workers and divided them into two groups. In the group A, healthcare workers wore standard goggles, and group B, healthcare workers wore standard with fan. In group A, participants used antifogging agents of their choice on goggles before wearing it, while in group B, the participant didn't use any antifogging agents, but the fan was started immediately after donning goggles via connection with provided battery. So objective of our study was to compare indigenous goggles with fan versus standard goggles in healthcare workers in COVID ICU in the terms of efficacy and safety. Efficacy was seen in the terms of visibility for far and near fields. So if I tell that what is the meaning of near field means reading and writing patient notes, and far vision means reading vital parameters on the stationed patient monitor. And visibility was further categorized as unacceptable or acceptable. Unacceptable means if there was thick fogging on the goggles, nothing was readable, or one means there was thin fogging or the things were readable with difficulty. Acceptable vision was when there was manual fogging, but the things was easily readable, or there was no fogging and absolutely clear vision. And safety was measured in the terms of symptomatic and RT-PCR positive COVID infection till 15 days of participation into the study. So we use various stats, and chi-square and Fisher exact tests were used to establish association between outcome and exposure. Quantitative variables were tested by t-test and Wilcoxon rank sum test, and p-value less than 0.05 was considered significant. The results were very encouraging. There was no demographic difference between the groups. None of the healthcare worker in any group developed symptoms suggestive of COVID within 15 days of follow-up after participation into the study. And as you can see here in the graph, that none of the healthcare worker in group B had poor vision, while at the same time, the 40% healthcare workers and 40% healthcare workers had poor or unacceptable vision for the far vision and near vision respectively. And at the same time, the participants in the group B had acceptable vision for the maximum duration, that is 5 to 6 hours for the entire shift. As you know, that various other authors had told that suffocation, breathing difficulty, headache, brain thermoregulation, and poor vision may affect the overall performance of a healthcare worker when they are wearing PPE and goggles. And Y. Bentos told that 63% surgeons reported visual impairment, while in our study this was 47% and 40% when wearing normal goggles. Who at all told that 25.6% healthcare workers said only this number of healthcare workers had clear vision after wearing PAPR. And Feng Jing reported variable efficacy of 4 anti-fogging methods, and fogging increased after prolonged use, while in our study there was no fogging even after prolonged use when the healthcare workers used goggles with fan. And Wu et al. Reported that presence of positive ocular signs like conjunctive hyperemia, chemosis, and increased eye secretion in the 1/3 of clinically proven COVID-19 patients. That's why we checked all these signs and symptoms in our study for the eye signs. So I want to conclude that Goggles with fan had highly significant better visibility and less fogging, and that too for longer duration, and were found equally safe when compared to standard goggles in healthcare workers in COVID ICU. So these are few references for our study. Thank you.
So I like the concept very much, but I just have one question, Dr. Nadeep. How easier
Yes,
was
sir.
it to wear the fan with the whole equipment thing?
Sir, can you please repeat, question?
How easier was it to carry the fan?
No,
Along.
sir. It was actually it was very lightweighted, and we checked for. We took the feedback of all the participants.
Yeah.
So the feedback was not. This feedback was very much encouraging, and they
Okay.
told that they found no difficulty, and the fan was very small and it was lightweight. So, and even you will feel that it was noise free also.
Uh-huh.
So they feel just little bit more movement of air because that was a work of fan. Otherwise, they did not complain any other. So, and in a short time, we will be giving this our article to journals, and there you can have all the details. Thank you, sir.
Okay, we can move on to the next one, please.
Thank you.
Very good morning to the judges, teachers, teachers, and my colleagues. Today I am going to present a paper on the topic Efficacy of Bilateral Intranasal Sphenopalatine Ganglion Block for the Management of Post-Dural Puncture Headache after Lower Segment Cesarean Section. Spinal anesthesia is one of the most commonly used anesthesia techniques for lower abdominal and lower extremities surgeries. Post-dural puncture headache is a common and distressing complication of spinal anesthesia, leading to functional impairment and brief duration of hospital stay for the patient. Various modalities have been tried for the management of PDPH with differential success rates. These include bed rest, analgesics, caffeine, epidural blood patch. Intranasal sphenopalatine ganglion block is a non-invasive intervention which we studied in our patients for reducing the severity of pain and improving patient outcome. Through this study, we aim to determine the efficacy of the intranasal sphenopalatine ganglion block for the management of PDPH against conservative treatment in terms of VAS in sitting position. We also wanted to determine any adverse effect, block failure, or return of headache, if any. Here is the methodology for the study. After ethical committee's approval and written informed consent of the patients, we conducted a randomized prospective study on 120 female patients presenting with PTPH after LSCS under spinal anesthesia at Nehru Hospital, BRD Medical College, Gorakhpur. Out of the 120 patients, 20 patients were excluded due to various reasons. The inclusion criteria was post-operative patients of LSCS aged 18 to 45 years, ASA physical stated 1 and 2, PDPH confirmed cases within 7 days of subarachnoid block. Exclusion criteria was patient refusal, ASA greater than 2, local infection at site, bleeding disorder, sensitivity to local anesthetics, history of chronic pain, history of daily use of CNS medication, past history of other headaches, nasal septum deviation, and history of nasal bleeding. The 100 patients were randomly divided into two groups of 50 patients each. First group, that is the group S, received bilateral intranasal sphenopalatine ganglion block with 1 ml 4% lignocaine in each nostril. Other patients, 50 patients, were allocated to group C, that is the conservative group, and they received bed rest, fluids, tablet paracetamol 500 mg TDS, tablet caffeine 100 mg TDS, and tablet diclofenac 75 mg BD. We also oversaw that if the VAS of the patient was greater than 4, conservative management will be added and block will be repeated if VAS was greater than 4 even after 24 hours. No patients were lost to follow-up and all 100 patients were analyzed for the study. For calculating the sample size, we use the formula n equal to 2 sigma square into z alpha plus z beta whole square divided by delta square. Here we assume alpha to be 1.96 for 95% confidence level, beta to be 1.28 For 90% power of study, delta to be the change in VAS and sigma to be the standard deviation. Student t-test was used for comparing the VAS scores documented at pre-decided time intervals. P-value less than 0.05 was considered statistically significant, and p-value less than 0.001 was considered highly statistically significant. Analysis of the data was done using SPSS version 2.23. Here are the results of the study plotted in a line graph. Mean VAS scores and sitting position on both groups were determined. The basal VAS scores in group C, that is the conservative, was 8, and group S, that is the block group, was 9. After performance of the block and starting the treatment, the VAS scores were compared at 30 minutes interval, which were 1 in the group S, which is the block group, and 5 in the group C, which is the conservative group. Thereafter, we can see at different time intervals, that is 4 hours, 12 hours, 24 hours, 48 hours, 72 hours, and 96 hours, the VAS scores in both the groups kept on decreasing, but there was a significantly higher decrease in the VAS scores in S group, that is the block group. Mean VAS scores in group S, that is the block group, was significantly lower than group C, that is the conservative group, at all time intervals, with p-value being less than 0.00001. The analgesic efficacy of sphenoparenteral ganglion block is objectively visible on analysis of the VAS scores. 3 patients out of the 50 in group S required addition of the conservative treatment because their VAS value was greater than 4. No patient in group S needed repeated blocks. Nasal congestion, dizziness, and throat uneasiness was seen in group S but was self-limiting. On statistical analysis, it was found that VAS scores at 30 minutes was 0.94 plus minus 1.12 and 4.58 plus minus 0.7 for S and C groups respectively, which is statistically very significant. Afterwards, at different time intervals, VAS scores were excellent in group S as compared to group C. A similar study by Puthenvittel et al. Found that block provided quick and better relief than conservative treatment. In this study, the VAS scores slightly increased towards the end of the study, but always remained below 4, while in our study, VAS score steadily decreased till the end of the study period. A similar study by Anjali Kochar et al. Showed immediate pain relief with the block after with headache relief in 75% with single block. However, in this study, conservative treatment was also administered to the patients receiving the block. The limitations of our study included limited sample size and further research on confirming optimal dose and volume of local anesthetic to be instilled is to be done. Thereafter, we can conclude that sphenopalatine ganglion block has superior analgesic efficacy than conservative treatment alone. It is quick, easy, relatively faster onset of analgesia as seen with the block, and there is minimal complications. Here are the references we use for the study. Thank you.
I think we can move on to the next presentation, please.
A very good morning to respected judges. I myself Dr. B.D. Balan from BRD Medical College, Gorakhpur. Title of my study: to study the efficacy of ultrasound guided peripheral nerve blocks in patients with trigeminal neuralgia receiving combination drug therapy. Trigeminal neuralgia is a sudden onset of intense stabbing pain which is paroxysmal in nature within the distribution of ophthalmic, maxillary, and mandibular branches of trigeminal nerve. The common trigger factors include chewing, speaking, brushing of teeth, exposure to wind, cold water, etc. Medical and surgical interventions are available, but standalone treatment is not satisfactory. Combination drug therapy along with the USG guided peripheral nerve block would provide satisfactory pain relief. Aim of the study to study the efficacy of ultrasound-guided peripheral nerve blocks in patients with trigeminal neuralgia receiving combination drug therapy. The primary objective include to observe the patient-reported pain score after peripheral nerve block in patients receiving free drug regimen using numerical rating scale. Secondary objective include to observe the satisfaction score of the patient and to observe any side effect of the drugs and or any complication after giving peripheral nerve block. This is the illustration showing the division of a trigeminal nerve. Ophthalmic branch block, how to give. This is the diagram showing linear transducer placed in supraorbital notch over medial 1/3 of supraorbital margin. Needle introduced from lateral edge of targeting supraorbital notch and the drug is introduced. 2 ml of drug injected for the block. Maxillary and mandibular branch block is shown here. Curvilinear transducer placed below and palato-zygomatic arch in between condylar and coronal process of mandible. Lateral pterygoid plate also visualized by this one. By this approach, needle inserted anterior to lateral pterygoid for V2 block and posterior to lateral pterygoid plate for V3 block. 4 ml of drug is used for each. Materials and methods. Written informed consent was taken from all patients along with the permission for the study. Exclusion criteria included patients with bilateral trigeminal neuralgia, secondary and hand having association with any other etiological factor. Patients who had received a radiofrequency ablation with other peripheral nerve blocks and surgery treatment within 6 months. Patients with controlled systemic diseases, neuromuscular diseases, local infection, bleeding disorder, history of allergy or sensitivity to any of the study drugs. This is a prospective observational study. Total number of patients enrolled are 33. Patients included is number 0. Number of patients, 33 patients are given the 3-drug regimen and the drugs used were carbamazepine, amitriptyline and baclofen. After 2 weeks, the patients pain relieved and regimen continued are number 25 patients, and pain not relieved after 15 days. So the block given are given number of patients which are the block was given is number is 8. Patient followed up after 15 days is 8 and pain relieved after 15 days. And pain not relieved are when patient excluded is number is 0. And total patients analyzed of the medians or IQRs for continuous variables, frequencies and percentages for categorical variables. Statistical significance was kept at p-value less than 0.05 and program SPSS V23 was used for data analysis. This is the diagram showing observation results. Change in the first one is a change in NRS over time. The red block shows patients who received block and the blue shows patients who received 3-drug regimen only. All patients were given TDR, 3-drug regimen at the beginning of the study, and after 15 days, one group of people, this red group of people, were left without any significant result. So they were chosen for giving blocks, and after 15 days, they had a excellent pain relief. Next one is the satisfaction score of patients after therapy. After giving the 3-drug regimen, 24.2% of patients didn't have any result, much of pain relief, and they had given the blocks and they had excellent result, and there was no patients left without any significant pain relief. Drug therapy is the primary choice of treatment. Considering the side effects, patients can get immediate pain relief from minimally invasive peripheral nerve block. UST intervention allows precise targeting of the affected nerves without damage to nearby structures. The limitation study included UST guided block is user dependent. Possibility of inter-individual variations in the extent of block is there, always present. Conclusion, efficacy of combined drug therapy is reiterated and should be used as first line of therapy. USG guided peripheral, ultrasound guided peripheral nerve block improve patient report pain relief in patients who had higher pain scores even after receiving combination drug regimen therapy. USG provided a safe option for giving peripheral nerve blocks. We propose multi-modal therapy for pain relief. Thank you.
Start video.
We can move on to the next presentation, please.
Harshita, a postgraduate student from Karnataka Institute of Medical Sciences, Hubli. I'll be presenting my paper on comparison of normal saline versus 1.5% lidocaine for epidural volume expansion following combined spinal epidural anesthesia with a low dose of intrathecal 0.5% hyperbaric bupivacaine for lower limb surgeries in elderly patients, a prospective randomized double-blind study. For lower abdominal and lower limb surgeries, regional anesthetic techniques are preferred over general anesthesia as they provide us the added benefit of a communicating patient. And one such technique which has gained popularity in the recent years for orthopedic and cesarean surgeries is that of combined spinal epidural anesthesia. A modification of this technique is epidural volume expansion, which augments the sensory analgesic level of the subarachnoid block when a small dose of normal saline or local anesthetic is given through the epidural catheter by causing thecal compression leading to the ascent of drug by volume effect. When this is performed immediately after spinal anesthesia, it provides us with a higher dermatomal level with early onset of sensory and motor blockade. My aim of the study was to evaluate the effectiveness of normal saline versus 1.5% lidocaine for epidural volume expansion and combined spinal epidural anesthesia using low dose of intrathecal 0.5% hyperbaric bupivacaine for lower limb surgeries in the geriatric population. My primary objective was to assess the time required to achieve maximum motor blockade, and secondary objective was to assess level of maximum sensory block, hemodynamic changes, epidural top-up requirements, two-segment regression time of sensory block, time to recover from motor block, and the requirement of rescue analgesia. So after an institutional ethical committee approval, a prospective randomized controlled double-blinded trial was conducted on 70 patients of ASA 1 and 2, aged between 65 to 90 years, posted for elective lower limb surgeries in the months of December 2019 to September 2021. And randomization was performed by computer-generated numbers into two equal groups of 35 each. Sample size calculation was based on a previous study done by Yoon et al., and we considered the mean time for maximum motor block to be our primary outcome. And assuming a difference of 4 minutes between the two groups and a power of 0.8 and a type 1 error probability of 0.05, sample size was calculated to be 58, and considering all the dropouts, the final sample size was made to 70 with 35 in each group. My inclusion criteria was that of age between 65 to 90 years and ASA 1 and 2 posted for elective lower limb surgeries, and we excluded patients who had intrinsic or idiopathic coagulopathies, any skin or soft tissue infections at the site of needle insertion, any pre-existing neurological diseases, patients with spinal deformities, any severe hypovolemia or emergency lower limb surgeries. They were put into two groups, and each of the group received a 7.5 mg of 0.5% hyperbaric bupivacaine intrathecally, which was followed up by 10 ml of normal saline as epidural volume expansion in group A and 10 ml of 1.5% lidocaine in group B. A combined spinal epidural anesthesia was performed through needle technique in L3, L4 or L4, L5 levels, and spinal drug was deposited over 10 seconds and the patient was made to lie supine. And an epidural volume expansion was performed with 10 ml of normal saline or lidocaine immediately within 1 minute, and the time required for maximum motor blockade was assessed at 2, 4, 6, 8 up to the 15th minute. And the data which was collected was entered into Microsoft Excel datasheet and analyzed using Stata statistical software. And all the demographic data were described using frequency, percentage, means, and standard deviation. And the other data used were analyzed using unpaired t-test, chi-square test, and Wilcoxon rank sum test. And a p-value of less than 0.05 was considered to be statistically significant. This provides us a comparison between the time required to achieve maximum motor blockade, and it was found to be significantly lower in the local anesthetic group with a p-value of less than 0.001. And the time required to achieve maximum sensory blockade was also found to be significantly lower in the local anesthetic group with a p-value of less than 0.001. And the sensory level at the 10th minute was found to be statistically higher in the local anesthetic group with a p-value of 0.001. And the time required for two-segment regression and the time required for recovery of motor blockade was found to be significantly higher in the local anesthetic group with a p-value of less than 0.001. And hemodynamic stability was found to be better with the normal saline group with a p-value of 0.006. And epidural top-up requirement was found to be more in the normal saline group with a p-value of 0.017. So epidural volume expansion is known to exert its effect through various mechanisms. However, it is largely due to the volume effect. And most of the clinical trials that have been conducted in non-obstetric patients have used 10 ml as the volume. And Tyagi et al. Has shown that the minimal epidural volume which is required to cause a two-segment ascent would be 7.4 ml. Hence, we have used a 10 ml. And the Trotman et al. Has found that epidural lidocaine can prolong the sensory block. And Yoon et al. Has also found that using an intermediately acting lidocaine in high concentration can provide us with adequate surgical anesthesia while also providing faster motor recovery. Hence, we have used 1.5% lidocaine for epidural volume expansion. Maderasov has showed that this expansion to be effective has to be performed within 5 minutes after completing spinal, and Trotman has shown that it is ineffective, it is performed after the 20th minute. Hence, we have performed it within a minute. And both our groups had comparable demographics of age, weight, gender distribution, and ASA status. And the mean time for complete motor blockade and maximum sensory blockade was significantly lower in the local anesthetic group. And the maximum sensory level achieved at 10th minute was higher. And the time which was required for two-segment regression and epidural top-ups were found to be lower in the local anesthetic group, whereas the motor blockade recovery took a longer time in the local anesthetic group. These effects can be explained as that the epidurally administered local anesthetic could be going through diffusion through the sleeves of dura mater, or it could be transferred directly through the hole which has been formed in the dura mater by the spinal needle. We also observed that there was a drop in the mean arterial pressure and there was a requirement for vasopressor in the local anesthetic group. And this can be explained as there is autonomic denervation, there can be peripheral sympathetic blockade, which can cause vascular dilatation leading to hypotension. So in conclusion, when we give 1.5% lidocaine of 10 ml for epidural volume expansion, it provides us with a faster onset and prolonged sensory and motor blockade compared with 10 ml of normal saline. However, this motor blockade reverses early, so we can provide mobilization and also maintain an adequate level of analgesia in the post-anesthesia care unit when we use lidocaine. The limitations of my study was that ultrasound was not used to locate the epidural space, and since we were using a higher volume of 10 ml, we achieved a higher level up to T4, which is not needed for low valence surgeries, especially so in the geriatric age group. So using a low volume may help. And we were not able to assess the patient satisfaction as most of our patients were elderly patients and they could not understand or recall the quality of anesthesia or the level of pain that they experienced during the surgery. So further studies can evaluate the different local anesthetics which can be used at lower volumes for epidural volume expansion, which can provide us with better hemodynamic stability and early motor block recovery, especially in the geriatric age group. These are my references. Thank you. Hello, sir.
Yeah,
Hello.
hi, Dr. Bini. Dr. Bini, just one question. Any particular reason to choose this age group 65 to 80?
Yes, sir. Because most of the geriatric age group, they'll be having a lot of comorbidities, especially with IHD and cardiac disorders. We cannot afford to have a lot of differences in the hemodynamics. We have to maintain a stable hemodynamic, and with the spinal anesthesia, we might not be able to achieve this. So we chose this age group to see if we can provide them a better level of analgesia, whereas keeping the hemodynamics stable, sir.
So unfortunately, one of the biases that can happen is, the epidural space, the volume of epidural space changes with age. So I'm sure you would have looked into it, isn't it? I mean, how is just choosing one particular age group gonna, we won't be able to generalize the effects, the results of the study in that case. Am I correct?
Yes, sir. But in the younger age group, the epidural space will be comparatively more than in the older age group, sir. So we could have used a lower volume because since we used 10 ml, we had a lot of hemodynamic disturbances actually. So maybe a lower volume would have helped our studies.
Okay. Can you move on to the next one, please? Thanks, Vinny.
Thank you, sir.
A very good morning to respected jury. Myself, Dr. Bilasha Bardwal, Junior Resident in the Department of Anesthesiology and Critical Care Medicine, BRD Medical College, Gorakhpur. My topic is post-operative analgesic efficacy of direct vision serratus anterior plane block in modified radical mastectomy. The aim of this study to observe post-operative analgesic efficacy of serratus anterior plane block done under direct vision in modified radical mastectomy. Objectives: the primary objective to observe analgesic efficacy of serratus anterior plane block done under direct vision in modified radical mastectomy in the form of vasoscored rest and abduction of arm in first 24-hour post-operatively. Secondary objectives: to observe total systemic analgesic consumption in the patient receiving serratus anterior plane block done under direct vision in first 24-hour post-operative. To observe hemodynamic changes in these patients to observe complication during and after the procedure. Serratus anterior plane block administered under ESG guidance, PNS guidance, and under direct vision. Serratus anterior plane block under direct vision was administered in our study. Comparison, we will compare VAS at rest and abduction of arm, total analgesic consumption in the first 24-hour post-operatively after block. Methodology, it is a prospective observational study. Admission for breast cancer in BRD Medical College. Assessed for eligibility, total 70 patients was taken. After approval from ethical committee of institution and informed consent from patient, total cases available for the study was 60. 10 patients was excluded. We allocated these 60 patients to Group G and Group S. Group G received general anesthesia plus 20 ml of NS deposited deep to serratus anterior plane under direct vision. Group S received general anesthesia plus 20 ml of 0.375% of levobupivacaine deposited deep to serratus anterior plane under direct vision. We follow up both groups and analyzed. Injection BCM 1 gram IV TDS was given to both groups, and if the PASS score was 4 or more than 4, IV fentanyl 1 microgram per kg given as rescue analgesia. Inclusion criteria: female patient posted for elective unilateral MRM, ASA grade 1 and 2, aged 18 to 65, randomly allocated into 2 groups. Exclusion criteria, that is first patient refusal, breathing disorder, local site infection, pregnancy, localized tumor, emphysema, and drug allergy. SAB block under direct vision. Drug is injected deep to serratus anterior muscles above the fourth rib, that is between 52 to 56, under direct vision after surgical resection of the primary tumor and axillary dissection. Statistical analysis, G power used for sample size measurement, assuming alpha is 0.05. Power of study at 0.90. Quantitative variable compared using unpaired t-test. P-value if less than 0.05, statistically significant. P-value if less than 0.001, highly statistically significant. Analyzing using SPSS version of 23.0. Result, as we can see in first graph, PASS was at rest was significantly lower in group S at all time intervals in first 24 hours. As you can see in second graph, VAS on movement was significantly lower in group S at all time intervals in first 24 hours. In graph 3, we can see time for first rescue analgesia consumption in both group in first 24 hours. Group G required first rescue analgesia after 3.7 hours, while in group S, it required first rescue analgesia after 18.5 hours. The last graph, we can see amount of fentanyl in microgram. We can see the group G required 235.7 microgram of fentanyl, while in group S required only 8.67 microgram of fentanyl. Discussion, VAS at rest and abduction of arm. First 24-hour post-operatively lower in group S than group G. Time for first rescue analgesia in group S more than group G. Total post-op fentanyl consumption lower in group S than group G. Limitation is limited sample size. Conclusion, SAB block under direct vision is a quick, easy, almost no complication. Accuracy of injection is targeted drug deep to serratus anterior. Post-primary tumor and axillary dissection, preserving surgical plane by preventing it becoming blocked. Serratus anterior plane block decreases post-operative pain, fentanyl consumption, and delay requirement for first rescue analgesia. Thank you.
Yeah, Doctor, that was a nice presentation. I have got one query because in one group you have used local anesthetic, in the other group you have used the saline. Okay, you are getting me now?
Yes, sir.
Hello,
Yes, sir.
you are
Yes, sir.
getting me now? In one
Yes,
group
sir.
you have used normal saline, and another group you have used local. So, and
Yes, sir.
the other thing is serratus anterior block is already a very good modality for this breast surgery. So means एक ग्रुप में तो आपने पेशेंट को पेन के लिए एक्सपोज कर ही दिया दैट इज एज पर एज योर स्टडी आई कैन थिंक दैट इट वुड बी बेटर इफ यू कंपेयर दिस डायरेक्ट insertion of local anesthetic and ultrasound or PNS guided local anesthetic insertion injection. Okay, you are getting my point now.
Yes, sir. Yes, sir. I'm getting that.
And your study is also looking like that, because in one group you haven't provided any kind of block, rather when a block is available. And second point is, whenever you do any intervention study, it's better to register that study in a clinical trial registry of India. There's a message to everyone sitting over there. And this is a basic problem. We never used to register our trials or study in the clinical trial registry. Okay, you must have heard of that.
Yes, sir.
You ever heard or about it or not?
Yes, sir. Yes, sir.
CTRI. That
Yes,
is
sir.
now mandatory for any sort of thesis work or any research work. Whenever you are conducting, you have to get it registered. Okay. Thank you.
Thank you, sir.
Uh,
उन्होंने पढ़ाया बताया
yeah, no.
Greetings to all. Myself, Dr. Neha, Junior Resident from the Department of Anesthesiology and CCM from BRD Medical College, Gorakhpur. Today I am going to present my topic on to compare the ARB assessment scoring of modified Mallampati versus Cormack-Lahani grading by video laryngoscope. A complete evaluation of airway with grading and knowledge of difficult airway can alert the anesthesiologist to predict the potential for difficulty with airway management and follow the appropriate planning. The aim of our study was to compare the modified Mallampati score with Cormack and Lahani scoring done by the video laryngoscope. The objective of our study was to find out the correlation of modified Mallampati scoring and with Cormack and Lahani scoring, and to seek whether the preoperative airway assessment by modified Mallampati classification correlates with the Cormack and Lahani grading by video laryngoscope. Our study was prospective observational study. Patients admitted in BRD Medical College for elective procedures, they are assessed for eligibility, and written informed consent was taken from all the patients along with the permission of ethical committee. In inclusion criteria, ASA grade 1, grade 2, patient age between 18 to 65 years of age of either sex, patients posted for elective procedure from all the surgical specialties requiring endotracheal intubation. In the exclusion criteria, it was patient refusal, emergency surgical procedure, patient age less than 18 years and more than 65 years, pregnant patients, patient with unstable cervical spine, patient with tumor of larynx, patient with apparent restriction of mouth opening due to pain, patient with apparent restriction of neck movement. In our study, a total of 100 cases were taken. No patient was excluded from our study. In the pre-anesthetic checkup, airway was assessed by modified Mallampati score, Cormack and Lahani grading done using the video laryngoscope after giving sedatives and analgesics. In the statistical analysis, categorical data was summarized as in proportion and in percentages. Quantitative, that is discrete data, was summarized as in mean and in standard deviation. Statistical significance was kept at p less than 0.05. Program SPSS version 23 IBM Corporation was used for data analysis. In the result, we will see the correlation between the modified Mallampati classes and Cormack and Lahani grading. A maximum of 54 cases matched between class 1 grade 1, 8 cases for class 1 grade 2, 3 cases for class 1 grade 3, 0 case for class 1 grade 4. A maximum of 13 cases matched between class 2 grade 2, 6 cases for class 2 grade 1, 5 cases for class 2 grade 3, 1 case for class 2 grade 4. A maximum of 3 cases matched between class 3 grade 3, 0 case for class 3 grade 1, 3 cases for class 3 grade 2, 2 cases for class 3 grade 4. A maximum of 1 case matched between class 4 grade 4, 0 case for class 4 grade 1, 0 case for class 4 grade 2, 1 case for class 4 grade 3, 1 case for class 4 grade 4. The grade-wise distribution of correlation between the modified Mallampati score and Cormack and Lahani score showed MPS Class 1 showed 83% correlation with CL grade 1. MPS class 2 showed 52% correlation with CL grade 2. MPS class 3 showed 37.5% correlation with CL grade 3. MPS class 4 showed 50% correlation with CL grade 4. The limitations of our study was the limited sample size, as the less number of cases were there for class 3 and class 4. In the conclusion, we have seen that the modified Mallampati scoring and Cormack and Lahani grading are good predictors for the tracheal intubation. A study showed that despite of video laryngoscopy done by the expert, the modified Mallampati classification did correlate with the Cormack and Lahani grading in lower grades, that is 83%, as compared to the higher grades, that is 37%. Thank you so much.
Doctor, can you have taken only Mallampati grade 1 and 2 patients now?
Hello.
Hello. Yeah, doctor, you have taken Mallampati grade 1 and 2. What was your inclusion? You have taken only Mallampati grade 1 and 2 patient now?
I can't hear you properly.
आपका inclusion criteria क्या था?
Inclusion criteria, sir, age 18 to 65 years of age.
जो MPG grade था. Dr. Neha?
Yes.
What was your Mallampati grading in inclusion criteria? The patient who you included in your study, उनका MPG grade क्या था?
Grade 1 and grade 2.
Yeah, that's what I am asking. और आपने जो कंक्लूजन में ये मेंशन किया है कि जो हायर ग्रेड का मल्लमपट्टी ग्रेडिंग है वो कोरिलेट करता है लिहानी स्कोर से 37%, ये कंक्लूजन कैसे ड्राइव हुआ?
सर वो सर उनका जो डाटा मैच कर रहा था उसके अकॉर्डिंग हमने कोरिलेशन निकाला था सर.
नहीं यार, once you are taking only MPG grade 1 and 2 patient, then means how are you compared the Lihane score with the higher MPG grade? Is you in your conclusion you have said na कि in case of higher grading the correlation was up to 37% only.
Sir, we compare both the groups, Mallampati and the Cormack Lahane, and in the first we see the Mallampati score.
आपने केवल जो मल्लपट्टी ग्रेड 1 और 2 पेशेंट था वो इंक्लूड किया अपनी स्टडी में,
yes sir.
उसके बाद आपने कंपेयर किया मल्लपट्टी स्कोर को और लिहाने स्कोर को, राइट, वीडियो लारिंगोस्कोप
yes.
पर.
यस सर.
उसके बाद जो आपने कंक्लूजन ड्राइव किया कि जो लो मल्लपट्टी ग्रेडिंग में तो लिहाने स्कोर वेल कोरिलेट करता है, नहीं अप टू 83%, राइट, यही मेंशन किया ना आपने कंक्लूजन में?
यस सर. यस सर.
और हायर मल्लपट्टी ग्रेड में जो कोरिलेशन है वो 37% है केवल, यही मेंशन किया?
यस सर.
तो जो हायर मल्लपट्टी ग्रेड है इसका मींस आई वांट टू नो कि इसका क्या कोरिलेशन है, बिकॉज़ you haven't include any case with higher Mallampati grade in your study.
Sir, this was an observational study, sir.
Yeah, it was a observational study. आपने जैसे जो 100 के आपने 70 केस लिए वो सारे मल्लमपट्टी ग्रेड 1 और 2 के थे ना?
100 केसेस लिए थे, उसमें सर सारे केसेस 1 एंड ग्रेड 2.
हाँ, ग्रेड 2 के थे. तो जो आपने कंक्लूजन में एक लाइन लास्ट में लिखा है ना कि हायर एमपीजी ग्रेड में ये जो कोरिलेशन है,
फिर उसमें हमने कोरिलेशन में निकाला था सर. एंड पहले हमने सर फर्स्ट ग्रेड 1 और ग्रेड 2 का केसेस लिए थे, उसके बाद सर उन्हीं केसेस को हमने सर मतलब उनका सर कॉर्मेक एंड लायनिक ग्रेडिंग देखा था और वो देखा था उस पर कोरिलेशन देखा था कि अगर हमें कोई मलहम पट्टी स्कोरिंग 1 और 2 मिल रहा है तो ये जरूरी नहीं है कि ये इजी इंट्यूबेशन ही हो। तो वो जो था, जो ग्रेड 1 ग्रेड 2 के जो पेशेंट थे वो हायर ग्रेड पे भी जा सकते हैं।
ओके, तो उसको थोड़ा सा आप रिफॉर्म कर देने मेरा सेशन कंक्लूजन को रिफॉर्म कर देना चाहिए था। ईसीजी अगर लिहाने स्कोर हायर है तो that is not necessarily that correlates well with MPG grade.
Okay.
I'll pass it over to Charu madam if she want to ask anything.
Yeah, sorry, unfortunately I happen to be sir. Yeah, so but anyways, I mean, again, that's okay, that's fine. I get it all the time. But again, the question is, I mean, is generalizing, as sir very rightly pointed out. You know, I mean, you can't generalize it to the higher grades, CL grades. You know, with Malam Patti. I can understand the sample size being a little less, especially for the higher grades of CL.
Yes, sir.
But unfortunately, the scientific value doesn't comes out then.
Okay, sir.
I mean, if you are done, we can move on to the next one, please.
Okay. Thank you, sir.
No worries.
Hello everyone, my name is Chaitra S and I'm from King George Medical University. I'm going to present a free paper on comparison of efficacy of dexmedetomidine and ketamine intravenous versus nebulization for awake fiber optic intubation. Coming to introduction. Fiber optic intubation is a standard technique in securing the airway in predicted difficult intubation scenarios. Since fiber optic intubation needs awake and cooperative patients, some sort of sedation and anxiolytic drug should be used. Hence, in this study, we have utilized dexmedetomidine and ketamine, known for their worldwide usage in fiber optic, and try to compare the efficacy between the combination of both the drugs given through intravenous and nebulization. The primary objective of the free paper was the time required for intubation between the group receiving dexmedetomidine and ketamine through intravenous versus nebulization. Along with the primary, we have compared whether secondary objectives like the sedation level, cough severity, patient tolerance, ease of intubation, hemodynamic changes during intubation, the recall of events during intubation in the post-operative period, and any adverse event that is associated with the intubation. The study setting, it was conducted in the Department of Anesthesiology, King George Medical University, after the written informed consent obtained by all the patient or the guardian. Study design is actually a randomized controlled double-blind study, which is conducted within 1 year period. Sample size, according to Mathur et al., 64 patients were required to have a 90% chance of detecting as significant at the file level, a decrease in the time required for intubation between the two groups by dividing the 64 patients into 32 into each. The inclusion criteria includes the ASA physiologic state 1 and 2, the age between 18 and 60 years, patients giving written and informed consent. But the exclusion criteria includes any heart disease like AV block on electrocardiogram, heart failure, coronary heart disease, severe bradycardia, liver cirrhosis, thrombocytopenia, coagulopathies. Current psychiatric disorders like history of seizures are present, or any respiratory disorders, or history of epistaxis, nasal pathology, known drug allergy to the study drugs, or SA 3 and 4 with the pregnant female. Coming to first, we have prepared the patient with adequate NPO along with the pre-anesthetic checkup. The patient was taken into the OT where routine monitoring devices such as ECG, heart rate, non-invasive blood pressure monitoring, and oxygen saturation were attached and recorded. 2 drops of vasoconstrictor, that is xylometazoline 0.1% was introduced into both of the nostrils. Injection glycopyrrolate 0.2 mg IV and ondansetron 4 mg IV was given as pre-medication. In randomization, it was divided into 2 groups, Group I and Group N. Group I received dexmedetomidine 1 mg per kg, 1 microgram per kg, and ketamine 0.5 mg per kg through intravenous route in 20 ml syringe with nebulization with 5 ml of NS over 10 minutes. Where Group N, that is receiving dexmedetomidine 1 microgram per kg and ketamine 0.5 mg per kg through nebulization route with a normal intravenous saline, that is 20 ml through over 10 minutes. Where coming to assessment, we have assessed the modified sedation, modified assessment of alertness or sedation score, which if it's equal or less than 3, we are attempting the awake nasal fiber optic intubation. If it is more than 3, injection propofol was given, and the dose that is required to bring the sedation of score 3 was noted. And now coming to the procedure, while doing the procedure, the ease of intubation, the intubation time, that is the passing the flexible fibro bronchoscope tip through the nostril to the first reading obtained by the capnography, where you have the patient tolerance was noted, and later the patient was induced with fentanyl, propofol, and deuterium. Coming to post-operative period, in the post-operative period, the level of recall of fibroscopy by the patient and the discomfort during the procedure and any adverse event that is associated with them was asked by the patients. In the results, the primary outcome was the mean time for intubation, which was found less in group I compared to the group N, which in group I it was 49.19 seconds. In group N, it was 75.69 plus or minus 10.83 seconds, with a p-value of less than 0.001. But between the group, between comparing the OAAS score, the group I was found better than that group N with before the propofol given with a p-value of less than 0.001. Then other scores like facial grimace score between the two groups, it was found better in the group I with a p-value less than 0.001, and a cough severity was also found better in the group I compared to group N with a p-value less than 0.001, and the ease of intubation was also better in group I compared to group N with a p-value equal to 0.001. The hemodynamic variables, the heart rate, systolic blood pressure, diastolic blood pressure, mean blood pressure were all decreasing trend in group 1, and they were statistically significant between group 1 compared to the group N after the 6 minutes. Majority of the patients of group I, that is 68.8%, and group 2, 81.3%, did not have any discomfort during the procedure. None of the patients of group I and 12.5% of the group 2 patients had moderate level of discomfort and rest. At rest had mild and partial discomfort. So difference between the level of discomfort between the two groups was not statistically significant. Coming to discussion, in our study, there was no failure of intubation in either group. Gupta et al. Reported a mean intubation time of 200.4 seconds in the nebulization group, where Shakal et al. Reported a mean duration of 58.9 plus or minus 6.1 seconds for a combination of dexmedetomidine and ketamine given through the intravenous route. But in our study, we found that the time required for the intubation was significantly less in group I compared to that of the group N with a p-value of less than 0.001. The cough severity was less in group I compared to the group N because during nebulization, unpredictable deposition of the drug can lead to patchy, less effective anesthesia. Gupta et al. Observed significant coughing in the nebulization group. Dexmedetomidine being an alpha-2 agonist acts on locus coeruleus involved in the physiological response of stress and anxiety, which is the principal site for norepinephrine synthesis. Literature supports the tropical effect of ketamine, while it's NMDA antagonist with a primary site of action in the CNS and parts of the limbic system based on the animal mode. The facial grimace were better in group I compared to that of the group N during the intubation. Coming to conclusion, in our study, we conclude that dexmedetomidine is a useful agent for awake fiber optic intubation, allowing good sedation, and adding ketamine further enhances the hemodynamic stability because of the opposite action on the cardiovascular system. Thus, we conclude that the efficacy of dexmedetomidine and ketamine through intravenous is better than the nebulization for achieving better intubating conditions and hemodynamic variables. Thank you.
Yeah, doctor, you have compared this nebulization route with the IV route. Can you please brief that is a nebulization route or not? Hello.
I think we lost Abby.
I think she's not here.
Yeah, my
She's
only
not
feedback
here.
to this. Yeah, sorry, go on.
Yeah, please.
Yeah,
please continue.
I mean, I would be a little skeptical about the uniformity of absorption, and because combining an inhalational route, I mean, it can certainly be an additive thing, but the uniformity in general population, I don't know how. It's a very small sample size to infer anything, isn't it?
Yeah. I think we can proceed to other one if she's not here.
No, we can proceed to the next one, please.
Hello everyone, myself Dr. Niveta. My title for e-research paper is Comparative Study of Facial Iliaca Compartment Block and 3-in-1 Nerve Block for Postoperative Analgesia after Hip Hemiarthroplasty. Introduction. Pain after hip hemiarthroplasty surgery may potentially hinder postoperative physiotherapy and early mobilization. Digital anesthesia of the lower limb appears to be effective for postoperative pain control in this setting, and it has been shown that the lumbar plexus blockade provide high quality analgesia as the femoral nerve supplies the anterior hip joint capsule as well as the proximal femur, the quadriceps, iliacus, and the pectineus muscle. A prospective study demonstrated that 3-in-1 nerve block could achieve a success rate of 81% block of the femoral nerve 96% of lateral femoral cutaneous nerve, and 4% of the obturator nerve. These three nerves can also be blocked together by fascia iliaca compartment block because the fascia iliaca compartment contains these nerves within the potential space. Aim and objective to compare the analgesic efficacy of USG guided fascia iliaca compartment block and 3-in-1 nerve block after hemiarthroplasty, to assess the duration of analgesia, to assess the additional analgesic requirement, to assess the incidence of any adverse effect. Study design: it is a prospective randomized and controlled study. Material and method: after getting approval from institutional ethics committee, the study was conducted in the Department of Anesthesiology, Shamsha Medical College and Associated Hospital, Rewa, Madhya Pradesh, from January 2020 to December 2020 on 90 patients posted for hip hemiarthroplasty under subarachnoid block. Inclusion criteria: patient age 50 to 75 years, of either sex, undergoing hip hemiarthroplasty of ASA grade 1 and 2. Exclusion criteria: significant disease like asthma, diabetes, hypertension, and cardiovascular disease, patient refusal, allergic to local anesthetic, infection over injection site, coagulopathy, psychological disorder like mental illness and dementia. Patient fulfilling the selection criteria were randomized using a computer-based randomization software in 3 groups of each depending on the block given. Group 1 received USG guided fascia iliaca compartment block with 30 ml of 0.25% ropivacaine at the end of the surgery. Group 2 received USG guided 3-in-1 nerve block with 30 ml of 0.25% ropivacaine at the end of the surgery. Group C control not receive either of the blocks. A detailed history of all selected patient was taken. A thorough pre-anesthetic evaluation, including the airway, back of the patient, and site of the block, was performed. Patients were explained about the entire procedure. Informed consent and video consent were taken. They were educated about the visual analog scale. Thereafter, they were shifted to the operation theatre. Intravenous line was secured. Mortar were attached, and baseline parameter was heart rate, systolic and diastolic blood pressure, mean arterial blood pressure, SpO2, ECG tracing were recorded. Subarachnoid block with injection bupivacaine 0.5% heavy, 2.5 ml at L3, L4 interspinous space via 25 gauge Winky spinal needle in sitting position was given to all patients. Standard hemodynamic monitoring was done. Fascia iliaca compartment block or 3-in-1 nerve block was performed under real-time USG guidance with high frequency ultrasound probe, mind rate DC 30 at the end of the surgery in group 1 and group 2 respectively. Group FICB. The goal was to place the needle tip under the fascia iliaca, approximately at the lateral third of the line, connecting anterior superior iliac spine to the pubic tubercle. It is our fascia iliaca. It shows the infiltration of local anesthetic. It is our fascia iliaca. It shows the infiltration of local anesthetic under the fascia iliaca under the iliopsoas muscle. Group 2, 3-in-1 femoral nerve block. In 3-in-1 nerve block, we have to infiltrate the local anesthetic just near to femoral nerve. After completion of the surgical procedure and block, the patient were transferred to post-operative anesthesia care unit. Pain severity was assessed using a visual analog scale, which was recorded at 0, 2, 4, 6, 8, 12, 18, 20, and 24 hours after block. When VAS score equal to or more than 4 or the patient first demand for analgesia, injection tramadol 100 mg IV was given as rescue analgesic. The duration of the analgesia and the total tramadol consumption in the first 24 hours were noted. Patient satisfaction score was assessed using a 5-point scale. It says highly satisfied, satisfied, neither satisfied, not dissatisfied, dissatisfied, highly dissatisfied. The study was completed 24 hours after block placement. Statistical analysis: all the measurement data were presented as mean plus or minus standard deviation, and statistical processing was performed using SPSS software. The categorical data analyzed by using chi-square test, while the quantitative data by one-way ANOVA and student t-test. The data with the p-value less than 0.5 was considered as statistically significant. Results: demographic parameter. In our study, all 3 groups have similar demographic parameter, and the duration of surgery difference between these 3 groups were statistically comparable with p-value more than 0.05. VAS score: the mean VAS score was higher in control group compared to the study group, which was statistically significant with the p-value less than 0.05, and also among the study group, FICB has low VAS score compared to 3-in-1 femoral nerve block, which has significant p-value less than 0.05. Duration of analgesia: the time to first rescue analgesia was higher in fascia iliaca compartment block. It is about 11 plus or minus 3 hours, and in group 3-in-1 femoral nerve block, it is about 10 plus or minus 3 hours. Compared to control group, it's about 4 plus or minus 1 hour, which are statistically significant with the p-value less than 0.05. Compared to 3-in-1 femoral nerve block, FSCB group has longer duration of analgesia and has statistically significant p-value. Total tramadol requirement in first 24 hours. about 226 milligram, which was statistically significant with p-value less than 0.05. Patient satisfaction score among the patients in group FICB 56.7% and in group 3-in-1 femoral nerve block 36.7% were highly satisfied, whereas patient in control group none of them were highly satisfied, which is statistically significant. Adverse effect, no adverse effects found other than nausea and vomiting, which is also treated with ondansetron. Similar results were found by LT Gerald et al. 2012, Pandya Jawar et al. 2014, Shukla et al. And 2018. Summary and conclusion: because of the aging of the population, the number of elderly patients accepting the hip surgery were increasing by the year. Regional anesthesia cannot only decrease the stress response caused by surgery and pain, but can also shorten hospital stay, reduce medical bills, and allow early post-operative rehabilitation. Peripheral nerve block using local anesthetic allow the patient to avoid the adverse effect of opiate analgesic, reduce the risk of postoperative chronic pain. With the low concentration of local anesthetic for postoperative analgesia, it is possible to selectively block the sensory nerve fibers. Preservation of motor function promotes early rehabilitation and decreases the risk of deep venous thrombosis. Peripheral nerve block is also less likely to cause postoperative cognitive dysfunction, less intraoperative blood loss, and improve blood circulation, reduce the incidence of postoperative delirium, complex regional pain syndrome, and cardiovascular complication. So we concluded that FICV and 3-in-1 nerve block recommended for postoperative analgesia after hemiarthroplasty, while FICV technique better in terms of high degree of sensory blockade of LFC nerve and improve analgesia when continuous passive motion is initiated in the early postoperative period. FICV is easy to perform, reliable, and does not threaten any vital organ. These are my references. Thank you.
Shall we move on to the next one in that case?
Hello everyone, I am Dr. Ipshita Roy, postgraduate trainee from Isacon Medical College and Hospital, and my guide is Dr. Bani Hemda, Associate Professor from the same. Today my topic of discussion is comparative study between infusion dexmedetomidine, lignocaine and magnesium sulfate to assess the perioperative hemodynamic profile and requirement of postoperative analgesia in patients undergoing laparoscopic abdominal surgeries under general anesthesia and observational study. Maintaining intraoperative hemodynamics and adequate postoperative pain relief are an integral and indispensable component for a balanced anesthesia. The primary aim of our study is to observe the hemodynamic parameters intraoperatively with the administration of the test drug in patients and assessment of the alteration and stability of hemodynamic profile in either groups, and to evaluate and compare the effectiveness of the test drug in reducing the analgesic requirements postoperatively. It is a time frame prospective observational study which was performed in Isacon Medical College and Hospital, and the study population was selected to be the eligible candidates of ASA grade 1 and grade 2 who are undergoing elective laparoscopic surgery under general anesthesia fulfilling the inclusion criteria, which was ASA physical status 1 and 2, patients of age 18 to 60 years, and those who are scheduled for elective laparoscopic surgeries under general anesthesia. All patients who have uncontrolled comorbidities were excluded from the study. Sample size was found to be 33, so we decided to take 35 patients in each group, namely Group M for magnesium sulfate, Group D for dexmedetomidine, and Group L for lignocaine, making up to a total number of patients as 105 who were randomly selected. These patients were taken in the operation theatre, and injection magnesium sulfate was given at an infusion of 30 mg per kg over 15 minutes as a bolus dose, followed by a maintenance of 15 mg per kg per hour. In case of lignocaine, a bolus dose of 1.5 mg per kg was given over 2 to 4 minutes, followed by a maintenance of 2 mg per kg per hour, and injection dexmedetomidine was given at a bolus of 1 microgram per kg over 10 minutes, followed by a 0.5 microgram per kg per hour. These patients were monitored according to the ASA standard monitoring and were induced under standard protocol and ventilated. After extubation, the test drug infusions were stopped and the adverse effects, if any, were managed. Pain scores at rest were evaluated using a VAS scale, and the VAS score were recorded at emergence from anesthesia at 30 minutes, 4 hours, 12 hours, and 24 hours after the surgery. And rescue analgesics were given accordingly. The parameter studies were heart rate, mean arterial pressure, which were recorded intraoperatively throughout the surgery. The total dose of rescue analgesics were given in post-operative 24 hours, and VAS codes were studied and statistically analyzed using SPSS version 24. Regarding the results and statistical analysis, demographic data were analyzed and comparable data were shown among the three groups. Regarding the MAP during pneumoperitoneum, it was seen that dexmet was found to keep a lower normal baseline MAP throughout the surgery, so it was found to be superior than the other drugs. Regarding the MAP during pneumoperitoneum, it was shown that surge of hemodynamics was maximally prevented by dexmedetomidine, followed by lignocaine, followed by Maxalf. In dexmed, the MAP was 87.7 compared to the baseline of 94, and in lignocaine it was 96 compared to the baseline, which is 100, but Maxalf showed no change. In case of heart rate, it was seen post-test drug bolus dose, there was maximal decrease in magnesium sulfate and dexmedetomidine group, but there was no change in the lignocaine, which was the same as the baseline heart rate. But magnesium sulfate showed a drop of 67 from 79, and dexmed showed 75 drop from 79. Regarding the post-induction, there was a significant fall in heart rate across all groups, with magnesium sulfate showing a maximal drop of 63 from 79 baseline. In post-intubation, it was seen lignocaine and magnesium group has proven to be more superior in stability of heart rate. Heart rate during pneumoperitoneum. Initially, dexmed was unable to prevent the surge, but throughout the surgery, it was able to maintain a stable heart rate, whereas lignocaine and magnesium sulfate showed a rising trend of heart rate during the entire period of the pneumoperitoneum. The VAS score was always lower in dexmed group than the other two, which was around 3 to 3.5 in dexmed, and the total number of patients receiving rescue analgesia was significantly lower in dexmed, which is around 6.5 compared to the lignocaine and Maxal, which was around 14.75 and 18.25. Now, the discussion post-pneumoperitoneum, the surge of MAP was maximally prevented by dexmedetomidine, followed by lignocaine and magnesium sulfate. Throughout the surgery, dexmedetomidine was found to be the better drug than the other two in maintaining a stable MAP near to the baseline. There was a significant decrease in heart rate post-test drug bolus dose, which was most in magnesium sulfate and dexmedetomidine group, and there was no change in lignocaine group. Post-induction, there was a significant fall in heart rate across the groups, magnesium sulfate showing the maximal decline. And after intubation, lignocaine and magnesium sulfate has proven to be superior in maintaining the stability of heart rate. During pneumoperitoneum, initially dexmedetomidine was unable to prevent surge, but throughout the surgery, it was able to maintain a stable heart rate, whereas lignocaine and magnesium sulfate showed a rising trend of heart rate during the entire period of pneumoperitoneum. VAS score was always lower in dexmedetomidine group than the other two. The number of patients receiving rescue analgesia was significantly higher in lignocaine and magnesium sulfate than dexmedetomidine. Comparison with the previous literatures, it was shown that dexmedetomidine and magnesium sulfate have shown comparable results, and dexmedetomidine has been more effective than magnesium sulfate in another study, and my study has been in accordance with the previous ones. My study is limited by a small sample size and absence of control group, and so I conclude that dexmedetomidine was found to be more effective to maintain hemodynamic stability throughout the perioperative period and also has superior post-operative analgesic property than the other two studied drugs. Magnesium sulfate and lignocaine has comparable results and were found to be more effective to prevent post-intubation surge than dexmedetomidine. These are my references. Thank you.
I think this was a very well planned study that way, and yeah, Dr. Anshul, if you have any other comments.
Yeah, you have planned it very well, and Budli, I can see that you have made better conclusions. Okay, so if we can proceed to the next one, and that's all.
If I'm not wrong, this was the last one. Is that correct?
Okay.
Dilip, if you are around. I don't think there are any more speakers. I think that's it.
Okay, all done.
Yes, sir. Uh, yes, Dilip.
Okay.
Who's this?
Thank
Pradeep.
you.
Pradeep, sir. Yeah. Well, in that case, if we don't have any other, shall we just wind off? Yeah. Yeah.
Pradeep sir, can we leave now?
So I have a list of all the speakers, and I don't think there are any more left. So we're done with the speakers, I think. So on behalf of me and my on behalf of me, Dr. Anshul Jain and the entire organizing committee, I would like to thank all the speakers who have made so much of efforts in putting up all the slides and the presentation. A job well done. Thank you for the participation. Any final words, sir? Anshul?
Thanks a lot, and definitely participant have done very good, and presentations were good. Yeah. Thanks a lot.
Thank
Thanks,
you.
Isacon, for providing me this opportunity to judge over here. Thanks.
Yes. Thank you all. Bye.
Yes, so we can end now, and the next session will be resumed after 11 a.m.
Hello friends, I'm going to give some practical tips for fluid and blood transfusion in pediatric patient. We give fluids to maintain normal volemia, normal tissue perfusion, metabolic function, electrolyte, and acid-base status. Distribution of body water is different in different age groups. 80% of the newborn body weight is water. Now, if you see over here, the intracellular fluid compartment is constant. So what is changing over here is the extracellular fluid compartment. Now, in ECF also, the plasma is constant across the age group. What is changing is the interstitial fluid. As you can see over here, in the preterm babies, the total body water, extracellular water, the sodium and chloride, all are higher. The insensible water loss occurs through the skin and the respiratory tract. The preterm, the baby, small for a gestational age baby, there's increase in the total body water and extracellular water. With the prematurity, again, because of multiple reasons like increase in the ratio of the surface area to respiratory tract, thin skin, increased skin blood flow, increased skin permeability, increased total body water, and increased respiratory rate, the insensible water loss is quite high. If there's increase in the body temperature, ambient temperature, etc., then it will increase. But if you keep them in an incubator, increase ambient humidity, cover them, then it will decrease. The smaller the weight, more is the insensible water loss. The kidney function, that is renal blood flow, GFR, and maximum concentrating ability is low in the neonates. The fractional excretion of sodium is high in a premature baby. Cardiac output, which is dependent on heart rate and myocardial contractility, both are near maximum at baseline and cannot increase further with the volume overload. There's a narrower range of the cerebral blood flow autoregulation. So with hypoxia, acidosis, seizures, or decrease in the diastolic blood pressure, there's disruption. So excessive fluid can cause increase in the BP and rupture of fragile vessels, and hypovolemia can cause cerebral ischemia. The daily fluid requirement is as per the weight of the baby. More than or equal to 2.5 kg baby requires 60 ml per kg per day. But as the weight reduces by 500 grams, then the baby will further require more by 10 ml per kg per day. And per day, there is further increase in the requirement by 10 ml per kg per day to a maximum of 150 ml per kg per day. Aminoven can be given as 1 gram per kg per day and can be started on a day of life 1. The sodium, the first 12 hours is not needed, whereas after 12 to 24 hours, the sodium is needed in extremely low birth weight babies and in all by day 2. The potassium in the cord blood is high, and over 48 to 72 hours, it will settle down. So potassium is not given in the first 48 hours, and day 3-4 onwards, the potassium is added. Bicarbonate, again, it is low in a preterm baby because they have a limited tubular excretion of weak organic acids and incomplete tubular reabsorption of bicarbonate. So in a very small premature, you need to give soda bicarbonate 1 to 2 millimoles per kg per day. IV 40 milligram per kg per day, elemental calcium that comes to 4 ml per kg per day of 10% calcium gluconate, especially is required in a preterm babies. Glycogen storage and glycogenolysis are developed in the last trimester of pregnancy. So preterm newborns develop hypoglycemia in the first 24 to 48 hours of the life. So term neonates require 3 to 5 and preterm neonates 5 to 6 milligram per kg per minute. We have availability of concentrated RL ampule, and when you add 1 ampule of concentrated RL to 500 ml of water, ultimate electrolyte concentration is like a RL pint. So that means 1 ml of concentrated RL gives sodium of 3.275 millimoles. Now let's learn with example. In a 2 kg baby, day of life 1, the water requirement is 70 ml per kg per day. That means 140 ml in this baby. Aminoven 2 gram per kg per day. So that comes to 4 grams, and that is there in the 40 ml. So final composition we can give is 100 ml D10% plus 40 ml aminoven. Now this will contain glucose of 3.47 mg per kg per minute. Now if the same baby goes to day 3 life, then 90 ml per kg per day. So 180 ml per day will be required. Aminoven will give 40 ml. Sodium requirement is 3 millimoles per kg per day, and a concentrated RL gives 3 millimoles per ml. So we need to give 6 millimoles per day. So final composition we can do is 136 ml D10% plus 40 ml aminoven plus 2 ml concentrated RL plus 2 ml KCl. Now, what about intraoperative management? In a short surgery with mild tissue trauma, we can give like finger plus 5% dextrose at maintenance rate. But if it's a major surgery or a moderate to severe tumor trauma is there, then in addition to this, you require replacement of glucose-free isotopic solution. Now, coming to infants and children, there are 3 components of IV fluid therapy. One is maintenance of water and electrolytes to cover insensible urinary losses. Second is replacement of pre-existing deficits like NP or excessive losses. And third is a replacement of ongoing losses because of exposure, blood loss, and third space loss. Now, how was Holiday-Sicker formula derived? Metabolism produces heat, which has to be dissipated by insensible water loss and solute by urine. And normally, these losses are there. So 100 ml of water is required for each 100 calories of expended energy. Smaller the child, more is the metabolic demand and increased body surface area to weight ratio. So there is increased water need. And that has given rise to this daily and hourly 4-to-1 formula. So the 3 to 10 kg, 100 ml per kg per day, that comes to 4 ml per kg per hour. In a 10 to 20 kg, 1000 ml plus 50 ml per kg for each kg from 11 to 20 kg. And for more than 20 kg, 1500 ml plus 20 ml per kg for each kg more than 20 kg. So this gives rise to our commonly known as a 4 ml per kg per hour. In a 10 to 20 kg, 40 ml plus per hour plus 2 ml per kg per hour for each kg from 11 to 20 kg. And here for more than 20 kg, it is 60 ml per hour plus 1 ml per kg per hour for each kg more than 20 kg. So this famous 4-to-1 formula has come. Now considering electrolyte of human and cow's milk, 2 of potassium and chloride and 3 milliequivalent per 100 calorie per day of sodium is needed to be given. And this is met by 5% dextrose plus 0.2% saline or isolate P. But this does not include fluid deficit, third space losses, modification because of hyperthermia, or requirement by unusual metabolic demands. We need to avoid hypotonic fluid for replacement of third space losses and other deficits. Now we follow the ASA fasting guidelines, and that allows clear liquids up to 2 hours before anesthesia. So if the child is fasting for 4 to 6 hours and child is old enough without significant pre-existing disease, then there is usually no evidence of intravascular compromise. So if ASA fasting guidelines are followed and or absence of evidence of intravascular fluid deficit or hypotension in response to induction of GA is there, then there is no need to replace fasting deficit. So assessment of the current status is more important than simple calculations. Now, what is the role of preoperative fasting times? Perioperative fasting times for children should be as short as possible to prevent discomfort, dehydration, and ketoacidosis. If pre-op and post-op fasting times are short, perioperative intravenous fluid therapy should not necessarily be performed in children beyond the neonatal age who drink sufficient volumes and undergo short procedures less than 1 hour with a venous access in place. Replacement of pre-existing deficit will be required if there's something like vomiting, diarrhea, fever, or intestinal obstruction, very common in emergency surgeries. Now, rate and volume will depend on the type and indication of surgery, hemodynamic status, and coexisting problems. And most of the time, LR 10 to 20 ml per kg will suffice. If there's ongoing loss like traumatic hemorrhage, then fluid resuscitation is initiated before surgery and it is further continued intraoperatively. If surgery is not urgent, like for example in CHPFs, where you have a hyponatremic, hypochloremic, hypokalemic, metabolic alkalosis with a variable degree of dehydration, then you need to correct it. So you are going to give 20 ml per kg bolus of isotonic saline, 2 boluses if the chloride is less than 97, and 3 boluses if chloride is less than equal to 85. And a further resuscitation can be with the 5% dextrose in 0.45% saline at 1.5 times the maintenance rate, that is 6 ml per kg per hour. And unless there's a renal insufficiency, 2 to 4 milliequivalent potassium can be added per 100 ml. And we need to monitor electrolytes. Now, again, let's learn with the example. So a diagnosed case of pyloric stenosis, neonate of 3 kg with serum sodium of 125, potassium of 2.5, chloride of 86, pH of 7.5, and mild dehydration. So that means the fluid deficit is 50 ml per kg. Okay, so including maintenance, you need to give 450 ml. The sodium deficit including maintenance 36 milliequivalent, potassium deficit plus maintenance 7.8, and glucose we need to give 21.60 gram. So if this can be given with 450 ml 5% dextrose with 0.45% saline plus 4 ml of KCl over 24 hours, that will suffice. Now, third type of loss is ongoing losses and third spacing. So either it could be in the form of whole blood loss, direct evaporation in very small infants, or surgical trauma to cell membrane causes hypoxic injury, creating a capillary leak, resulting in extravasation of isotonic protein containing fluid into interstitial compartment, and thus is called as a commonly third space loss. Or it could be anesthetic induced vasodilatation, increased capacitance, and relative hypovolemia, which is called as a virtual loss. Now, these are difficult to quantify. Estimates are usually quite rough. So one has to be vigilant and prompt in action, because the smaller the child, lesser is the circulating volume and safety margin is very low. A small loss for an adult becomes very significant for a tiny infant. Now, isotonic crystalloids are used to replace third space losses. And depending on the tissue trauma, we can give 3 to 4, 5 to 7, or more than equal to 10 for mild, moderate, and severe in form of ml per kg per hour. If we give too much, then it will cause hemodilution, increased capillary pressure, whole body salt and water overload. Now, if a relatively healthy child is there, most excess will be excreted over next post-op 2 days. But if the child is impaired with a pulmonary, cardiac, or renal function, then there could be pulmonary edema, bowel swelling, laryngotracheal edema. Now, which fluid will be given? Isotonic fluid in all these children. For example, isotonic fluid, you can give sodium chloride, but it has a high chloride, so it will cause hyperchloremic acidosis. So it is better to give balanced salt solution, which can be either containing lactate, like lactated ringers, or acetated ringers, or plasma light, which contains gluconate and acetate, and stirofundin, which again causes gives acetate. Now, acetate has some advantage. Bicarbonate production will be faster, oxygen consumption and respiratory quotient will be less. It can be metabolized by all tissues. It can be metabolized even in shock. It doesn't affect this thing. It doesn't cause gluconeogenesis. So there is no hyperglycemia, and binding to calcium doesn't occur. So you can give it the blood products also. And lactate can be used as a hypoxia marker. Now, which type of fluid is not to be given? Whenever the sodium is low, hypotonic fluid is not to be given. Now, what about glucose? In neonates, severe hypoglycemia can cause permanent neurodevelopmental impairment. And even if mild hypoglycemia is there, when it is combined with the mild hypoxia or ischemia, it can cause cerebral injury in immature neonates. So neonates need glucose in the maintenance fluid. But if it's a bigger infants and children, incidence of preoperative hypoglycemia is very low and should not occur if you are following the AC fasting guideline. In fact, the stress-induced hyperglycemia plus dextrose can cause osmotic diuresis, which can lead to dehydration and electrolyte abnormalities. And in case of ischemia or hypoxia, there'll be impairment of metabolism of excess glucose. So there'll be accumulation of lactate, which will cause intracellular acidosis, cellular death, and neurological impairment. So we have to avoid hyperglycemia in neurosurgery. Glucose-containing solutions should not be used to replace intraoperative fluid losses. In a child of 6 months to 5-year-old, we can give 0.9 to 1% dextrose. In the UK, they have started making the ready-made set solution. In India, it is yet not available. And after the age of 5 years, glucose-free isotonic solutions can be given. We have to be careful if the child is less than 6 months, debilitated, malnourished, or undergoing cardiac surgery, or is having endocrinopathies, or on beta blockers, or receiving hyperalimentation, or undergoing prolonged surgical procedures, or has been given a lot of regional anesthesia, which is reducing stress. In these cases, vigilant glucose monitoring is required and higher glucose concentration may be needed. Now, European consensus statement came out in the Berlin in September 2010, which says that the solution should have a physiological osmolarity to avoid hyponatremia. It should have 1 to 2.5% instead of 5% glucose to avoid hypoglycemia, lipolysis, and hyperglycemia, and should have metabolic anions like acetate, lactate, or malate as a bicarbonate precursor to prevent hyperchloremic acidosis. Now, what about colloids? Surgery in aseptic neonates present conditions that may compromise normal endothelial glycocalyx integrity and so enhance extravasation of albumin and other colloids into interstitial space. And this will compromise lung function and wound healing. So colloids like albumin, gelatin, hydroxyethyl starch are associated with more adverse drug reactions than balanced electrolyte solution. So only thing is, in children with hypovolemia, if crystalloids are not sufficient to maintain hemodynamic stability and the blood products are either not to be given or not available, then one can use colloid intraoperatively in a restrictive approach. You can give any one of this like albumin gel or HES 130 as a 5 to 10 ml per kg, and maximum dose of 30 ml per kg of HES can be given. We need to monitor the hydration status clinically by capillary refill time, skin turgor, fontanelle, or fluid responsive like by autotransfusion maneuver like pressure on the liver. In a major surgery, one can do arterial and CVP catheterization and regular ABGs. And in case of negative trends like decrease SCVO2 or decrease basic cells or lactate increase, countermeasures should be taken early. Now, to simplify, this article came out which says that perioperative fluid of management in children, rule of 10, means background infusion of balanced isotonic electrolyte solution with 1 to 2% glucose can be given as 10 ml per kg per hour. In most of the ambulatory surgeries, this will suffice. Now, if it's a major surgery, then fluid therapy may be needed for the exposure losses, and that should be in the form of balanced salt solution 10 to 20 ml per kg. In addition, if needed, hemodynamic instability is there, volume therapy in the form of albumin, gelatin, or HES, 5 to 10 ml per kg can be given. And if there's a major blood loss, then blood and blood components, RBC, FFP, and platelets, 10 ml per kg can be given. Now, all the studies with the large sample size have shown that in children, the risk of aspiration is quite low. It's only 0.007% to 0.1%. And that too, the incidence of postoperative ventilation among those children who aspirated is further low. So what is suggested is preoperatively keep the fasting time short, clear fluids up to 1 hour pre-op. Postoperatively allow the children to eat and drink soon after the procedure. And if it's a minor procedure, you just need a background infusion of 10 ml per kg per hour of balanced salt with 1% dextrose. If it's an intermediate procedure, then in addition to this, you will need some balanced salt solution as additional fluid requirement. Plus, to maintain hemodynamic stability, you may need colloids. And if it's a supramajor procedure, then you may need the blood products if there's a critical hemodilution. Now, whenever we are giving fluids, we have to remember that there should not be any postoperative hyponatremia, because there's a large amount of arginine vasopressin secretion, either because of pre-existing condition or because of neuroendocrine activation by stress. And further, if we don't monitor and if there is delay in recognition, and majority of the time because the ongoing losses are replaced with hypotonic instead of isotonic fluid, the person develops hyponatremia. And in the child, because they have a relatively large brain to intracranial volume ratio, relatively small CSF volume and hence buffer capacity, immaturity of sodium potassium ATPase pump, high amount of brain intracellular sodium concentration, and plus the child will not develop the headache, nausea, etc. And so it will not get recognized, and it will get recognized directly as a respiratory arrest. The hyponatremia is very common. And all of us must remember there's something difference between osmolarity and tonicity. Now, osmolarity, even a 5% dextrose is almost isoosmolar. In vitro osmolarity is 286 milliosmol per liter. But tonicity is a total concentration of solutes that exert osmotic forces across a membrane in vivo. So 5% dextrose, when you give, the dextrose will get rapidly metabolized. So what will be remaining is the water, and in vivo tonicity of this is 0. So we need to remember, we cannot give hyponatremic solutions. We have to give isotonic fluids. Now, can we give 0.9% saline? It will cause hyponatremia, edema, hypertension, chloride-induced acute kidney injury. So we need to give LR. But LR is not containing any glucose. So in the post-operative period, we may need to add dextrose 5 to 10%. Now, at what rate it has to be given? It is given at a half rate as a maintenance compared to what we were giving intraoperatively. So instead of 4 to 1, this will become 2 1.5. Now, if the child does not or cannot tolerate orals after 6 to 12 hours, then we need to give 5% dextrose with half strength saline at a rate of holy disregard, that is 4:1 formula. We need to have a serial monitoring of serum electrolytes once daily. Now, if at all hyponatremia occurs, then we need to give treatment with bolus injection of 2 ml per kg of 3% NaCl slowly. The bolus can be repeated once or twice. The purpose is to eliminate the symptoms or raise the concentration of serum sodium by 5 to 6 milliequivalent per liter in 1 or 2 hours. Check the plasma. Stop 3% NaCl therapy. Once the child is free of symptoms, awake, alert, response to commands, and there is a resolution of headache or nausea. And the serum sodium, there's a sharp rise, 10 milliequivalent per liter in first 5 hours. After hyponatremia symptoms have resolved, ensure that the plasma sodium does not increase by more than 12 millimoles per liter, because otherwise it will cause pontine myelinolysis. Now, what are the indications of red blood cells? Mainly to increase oxygen carrying capacity or to dilute concentration of abnormal hemoglobin moieties in patients with sickle cell disease or thalassemia. And a transfusion trigger for patients less than 4 months old are more liberal, because these children have a limited ability to produce erythropoietin or increase cardiac output or release oxygen to the tissues. So if you see the neonates, again, the transfusion trigger will vary depending on whether the baby is off oxygen or on oxygen CPAP or baby is on a mechanical ventilation. So it can range anyway, and depending on the age, number of hours of life. So depending on that, it can vary from 7.5 to 8.5 in a baby who's off oxygen in a day 8 to 14, compared to a ventilated baby in the first 24 hours, that will be 12 gram%. Okay. Now coming to children less than 4 months of age, whenever there is a hemoglobin less than 7 gram% with low red tick count and signs of anemia, or if there's acute blood loss of more than 15 to 20% total body volume, or intraoperative blood loss of more than 15%, then we need to replace with the blood. If hemoglobin is less than 10 gram% and the child is on a CPAP or mechanical ventilation with airway pressure less than 6 or FiO2 less than 35, then you need to give. If the child is requiring higher CPAP pressures or higher FiO2, then we have to start transfusion even at hemoglobin of 12. And if the child is having a congenital cyanotic heart disease, CCF or ECMO, then even at 15, we need to start giving RBCs. Children with more than or equal to 4 months of age, it will be slightly varying. Here, again, the 7 gram is the target, or 15% of total body volume loss is a target. But instead of less than 4 months, when we are giving at 10 gram%, here we can wait up to 8 gram%. Or children with the severe cardiopulmonary disease or on ECMO, there we were giving at 15 gram%, here we have to give at a 13 gram%. And plus the children like beta thalassemia, red cell aplasia, they will require the transfusion. Circulating blood volume will differ. In a child, it will be 70, whereas in a preterm baby, it will be 90 to 100 ml per kg. All of us know how to calculate the maximum allowable blood loss, that is EBV into hematocrit initial minus hematocrit target divided by hematocrit initial. And how much Paxil you will give, that will be desired hematocrit minus observed hematocrit divided by the Paxil hematocrit multiplied by the estimated blood volume. Okay, pre-transfusion test in a neonates, it is very important to test the mother sample as well as the neonatal sample. Now, when we need to give fresh frozen plasma as a replacement of the coagulation factors in a bleeding patient or one who's about to undergo invasive procedure and is having a coagulopathy, or whenever specific factor concentrates are not available, or PT-INR is more than 1.5, PTT more than 1.5 in a bleeding patient or one who's undergoing invasive procedure, or during therapeutic plasma exchange or as a reversal of warfarin. But please do not give FFP as a routine prophylaxis against peri or intraventricular hemorrhage in preterm neonate, or as a volume replacement solution, or just to correct abnormalities of the clotting screen. Then what about platelets? Platelets less than 30,000, consider transfusion. Platelets between 30 to 49,000 if the baby is in the first week of life or less than 1 kg weight, or prior grade 3 intraventricular hemorrhage is there in the last 48 to 72 hours, or there is concomitant coagulopathy, or it's a critically ill or septic, or during invasive procedures. Platelet count with 50 to 90,000 if the baby is having a bleeding, and platelet of 1 lakh per cubic millimeter if the baby is undergoing neurosurgery. What about cryoprecipitate? It contains factor 8, von Willebrand factor, factor 13, and fibrinogen. Dose is 1 unit per 5 to 10 kg baby weight, and it is indicated whenever fibrinogen is less than 150 milligram percent with microvascular bleeding, or massive transfusion with fibrinogen concentration less than 150 milligram percent in active bleeding, and deficiency of fibrinogen, dysfibrinogenemia, or fibrinogenemia, etc. Now, when we call it as a massive blood loss more than 1 EBV in 24 hours, or blood loss of 50% EBV within 3 hours, or transfusion at a rate of 10% of total blood volume every 10 minutes. Now, these are likely during trauma, liver transplant, cardiac surgery, major spinal surgery, cranial vault surgery, neurosurgical procedures like arteriovenous malformation, vein of Galen. Now, we have to remember that we have to early recognize, educate whole team, do active resuscitation and control bleeding, seek specialist assistance, give O negative blood group till the specific red cells are available, and it should be ml per kg body weight calculation, anticipate and treat coagulopathy and thrombocytopenia, give tranexamic acid, avoid hypothermia, hypocalcemia, acidosis, and hyperkalemia. A ratio of at least 1 FFP per 2 RBCs initially, and if required, 1 FFP, 1 RBC, 1 platelet, 1 cryoprecipitate can be given. Platelet and cryoprecipitate must be considered if active bleeding persists after initial resuscitation. So appropriate allocates, for example, RBC 20 ml per kg, FFP 20 ml per kg, platelets 15 to 20 ml per kg, cryoprecipitate 10 ml per kg can be given. And our aim should be to maintain hemoglobin of 8, fibrinogen more than 150 milligram percent, PT ratio less than 1.5, and platelet count more than 75,000. Calcium needed to be given. Calcium gluconate can be given 15 to 30 milligram per kg whenever the rapid transfusion of FFP or whole blood is there at a rate more than 1 ml per kg per minute. Acidosis can be improved with soda bicarb. Hyperkalemia needs to be treated. So in conclusions, neonates have a high insensible losses. So reduce insensible water loss rather than giving more fluids. 0.9 to 1% dextrose is sufficient in majority except neonates. The replacement of ongoing losses should be with the isotonic fluid. Be vigilant to detect post-op hyponatremia. Avoid coagulopathy, acidosis, and hypothermia in massive blood loss. Thank you.
Namaskar, everybody. Let me on the outset, first of all, thank the organizing committee, the scientific committee, to having invited me to address this August gathering today in the conference, and a very special note of thanks to present this talk on the topic of anesthetic management of neonatal emergencies. How do I do? Now, let me begin my talk. Newborns undergo emergency operations, which are really difficult, which can pose difficult challenge for anesthesiologists, which can be really life-threatening and can be accompanied by multiple organ system failure However, an efficient recognition and prompt management of neonatal illness can be life-saving. Little bit I'll talk about the anatomy. A cricoid cartilage is the narrowest portion of larynx in neonates. A 3.5 millimeter size internal diameter endotracheal tube can be the correct size for full-term neonates. However, for smaller preterm neonates, 2.5 to 3 millimeter internal diameter endotracheal tube can be appropriate and appropriate for the smaller or preterm neonates. However, commonly used laryngoscope blades in neonates are Miller size 0 and 1 and these Sipples blades. Face mask size 000 or 00 will be the correct ones, and laryngeal mask airways is 0 size can be appropriate. Infants operate close to the closing volume during tidal breathing, so more rapid anesthetic gas uptake occurs and rapid desaturation therefore happens during apnea. Further continuing on anatomy, it is very important because volume replacement and maintenance of heart rate is essential for maintenance of blood pressure in newborns. So volume replacement in neonates is very, very important. Little I'll talk about pharmacology. Immature renal tubular function in neonates decreases clearance of some drugs, for example, morphine and other opioids. Immature liver function causes decrease by transformation of many drugs, especially opioids and local anesthetics. Immaturity of blood-brain barrier causes high cerebral spinal fluid opioid levels in the newborns. So drug doses need to be very carefully calculated before commencing anesthesia. Risk of intraventricular hemorrhage, IVH in neonates increases manifold because of various reasons of immaturity of blood and blood vessels, hypoxia, hypercarbia, fluctuations in blood pressure, venous pressure, and pain also increases risk of IVH. This is the list of pharmacology of drugs dose and their doses which can be used in the neonates. However, because of paucity of time, I cannot really go into details. Pharmacology further continued. Remifentanil is ultra short acting opioid. It can be useful for as a because of its volatile sparing effects. Neonates are at the risk of post-operative apnea, and remifentanil more used in neonates where extubation is planned immediately after completion of surgery. Fentanyl is most commonly used in the dosage of 1 to 2 micrograms per kg. Sufentanil is uncommonly used, same dosage. Clearance of alfentanil in preterm neonates is markedly reduced, so not very common drug. And volume of distribution is much more than the older infants as compared to neonates. So not many studies done on alfentanil and sufentanil. Newborns require high doses of succinylcholine, that is 2 to 4 milligram per kg. That is 2 milligram per kg. However, mivacurium and cystatricurium are more predictable and because of the shorter duration of action and devoid of any side effects in normothermic neonates and devoid of any cardiovascular side effects also. But rocuronium and vecuronium can have long duration of actions. Now coming to local anesthetic agents, use of bupivacaine for caudal epidural anesthesia is very common, but it has been seen that there is a rapid rise of blood levels even up to 48 hours from the time of administration of bupivacaine as compared to higher infants, as compared to older infants of bupivacaine. The level keeps on rising of bupivacaine in neonates even up to 48 hours. So, but it has been seen that lidocaine is safer to use because of its safer blood levels and easily measured blood levels. Chloroprocaine has greater safety in the newborns. Ropivacaine and levobupivacaine also used in neonates and in the dosage of 1 milligram per kg with the duration of 50 to 70 to 90 minutes. This is the chart depicting the usual doses of local anesthetics for spinal anesthesia. With additives, clonidine, fentanyl, and morphine can also be used. Sevoflurane, now let us talk about the inhalational agent. Sevoflurane is preferred because of less effects on hemodynamics compared with other inhalational agents. Time of emergence of sevoflurane is significantly faster as compared to isoflurane and desflurane in neonates. Beneficial in neonatal surgeries in where planned extubation is required, nitrous oxide is contraindicated in many neonatal surgical emergencies. Propofol is used 2 to 3 milligram per kg. Moderate to severe hypotension and hypoxia it can cause. Ketamine, however, IV ketamine can be useful induction agent in compromised hemodynamically critically ill neonates. Fentanyl, which has got minimum cardiovascular side effects, is used in critically ill neonates 1 to 2 microgram per kg for abdominal and thoracic surgery. Remifentanil is very short-acting drug, useful if extubation is planned. Dextromethorphan, if neonate needs to be kept sedated, spontaneous breathing, awake intubation, and decrease. But however, it decreases heart rate and blood pressure. Now, little bit about PSC, pre-anesthetic evaluation. Detailed history and physical examination is very important before taking the patient for surgery. Gestational age, significant events at birth, asphyxia, meconium aspiration, Apgar score, ventilatory support. These all points have to be noted in the PSC chart before taking up the doing the PSC before taking up the patient for surgery. And physical examination, one has to see, the anesthesiologist has to see the hydration status and coexisting disease, which are very important. Important laboratory examination can be recent hematocrit, glucose and calcium before surgery. Neonates are more at a risk of hypoglycemia and dehydration. Further continuing with PSC, appropriate fasting time for neonates can be 6 hours for formula milk, 4 hours for breast milk, and 2 hours for water or clear fluids. A thorough discussion with parents is very important, and a planned conduct of anesthesia has to be chalked out. Further, continuing with planned conduct of anesthesia is pain relief, different modalities, post-operative monitoring, blood transfusion if required, intraoperatively, and invasive monitoring can also be part of the total plan of anesthesia. Intraoperative management, however, we have to plan whether the child has to be shifted to HD or pediatrics intensive care unit. Neonates, which can be extremely susceptible to hypothermia, can end up into pulmonary hypotension because of severe pulmonary vasoconstriction, delayed drug metabolism, hypoxia, and apnea. These can be the further lead to life-threatening complications in neonates. So normothermia is very, very important. Care during transport and intraoperative period in a neutral thermal environment, into a warm operating room, that is very important. Transport the neonate in a heated module, always remember. Intraoperative management further continued. The operation theater environment needs to be warmed. However, we have to warm the humidified inspired gases. Antiseptic solution should be warm. For intraoperative irrigation, blood and intravenous fluid all should be warm. Heated child has to be kept on heated mattress, radiant warmer, and along with the bear hugger. Bear hugger, the child needs to be covered with. Heated hot air circulation under the drapes, and with the help of microprocessor control device, alone system, which reheats and cools the recirculated water contained in a garment covering the neonate, which can be effective in maintaining perioperative normothermia. Optimal monitoring can be done with precordial stethoscope, pulse oximeter, capnograph, non-invasive blood pressure of the neonate, ECG, the basic monitors required. Monitoring urine output is very important. 5 French gauge feeding tube can be used for monitoring urine output. Advised mostly for major surgeries, intraarterial catheter IEAC is useful in critically ill neonates, and CVP line, which 3 French gauge in right internal jugular vein can be used for monitoring. However, a 24 gauge or 22 gauge IV intravenous line or the largest possible catheter inserted peripherally is also very important. Additional airway monitoring and neuromuscular function monitoring can be used. This is the chart for fluid management in neonates. Fluid consideration and maintenance fluid is in neonates is more or less like adults, only hypotonic glucose solution, dextrose 5% or dextrose 10% with water or 0.2% normal saline. Replacement of insensible third space, however, needs to be done. Small volume blood loss or isotonic fluid needs to be administered separately to prevent excessive fluid and glucose administration. Run both maintenance fluid at the rate of 4 ml per kg per hour and operative fluid intraoperative for insensible and blood loss. Fluid replacement needs to be at the rate of 3 to 10 ml per kg per hour, mainly on infusion pumps for ease of calculation. Blood glucose measurement is essential during emergency neonatal surgery. Hypoglycemia is defined if the blood glucose level is less than 45 milligram per deciliter in the first 3 days of life and thereafter 75 milligrams per deciliter. So we have to be very careful to prevent the neonate going into hypoglycemia. Response to fluid therapy is monitored by variations in heart rate, blood pressure, and central venous pressure. Pain relief, which can be a very important modality in the total neonatal emergency surgeries, are mainly because the goal is early extubation. If we have to extubate the child early, then pain relief comes into picture more so. And also to prevent barotrauma, because prolonged intubation after surgeries like emergency surgeries like tracheoesophageal fistula or congenital diaphragmatic hernias, etc. This is the local anesthetic bolus doses of bupivacaine 0.1% or to levobupivacaine 0.1 to 5% in neonates with an infusion rate of 0.25% for brachial plexus nerve blocks, etc. for long surgeries in neonates. A little bit about caudal anesthesia. Most valuable adjunct to general anesthesia in neonates, epidural catheter provides optimal analgesia. Tip of the catheter lies in the center of dermatomes affected by surgery. It is safe with safe blood levels of bupivacaine. After a bolus injection of 1.5 to 2 milligram per kg of 0.25% of bupivacaine, continuous infusion of 0.2 milligram per kg per hour can be used. However, lidocaine, which is much more safety profile, up to, in a dose of 1 milligram per kg, or chloroprocaine 10 to 15 milligram per kg can be used. However, nowadays ultrasound guided nerve blocks are becoming more and more popular. Post-operative. Some neonatal procedures require post-operative ventilation in ICU, or many neonatal cases return to neonatal unit or high dependency units, HDUs. Immediate post-operative extubation is very much warranted, is very much required in the neonatal HDU or in the post-operative care unit. Only it is possible if the child is awake and with full strength, hip flexion and arm lifting he or she is doing, then only we plan for extubation in the immediate post-operative period. Low likelihood of airway obstruction, however, occurs in neonates with normal airway anatomy. The child should be normothermic, blood pressure and volume status should be normal, with regular respiratory pattern with adequate minute ventilation. Only then we plan in the for extubation in the immediate post-operative period. Risk of post-anesthetic apnea (PAA) is very high in premature neonates with the gestation week less than 37, with the gestation period of less than 37 weeks, and irrespective of the any anesthetic techniques. However, the neonate, more so especially the premature or sick neonates, can land into post-anesthetic apnea. However, more so it can be predisposed if the neonate is hypothermic, hypoglycemic, hypoxic, or septic, or is having a bit of sepsis, or if the neonate is hypocalcemia, which happens more so in neonates undergoing emergency surgeries. However, post-apnea mattress or transthoracic impedance can help the anesthesiologist or the neonatologist or the anesthesiologist know about that the child has gone into apnea. The post-operative monitors can be oxygen saturation monitor, heart rate, blood pressure monitor, temperature, blood glucose, CVP monitor, urine output, and observation of stoma or wound drainage, which can be very important in the post-operative period. However, surgical procedures and general condition of the neonates will tell us whether to check the electrolytes maybe possible, if possible, check the electrolytes daily. Some children are put on total parenteral nutrition (TPN), which can be required in some units, abdominal surgery. However, the neonates who undergo major abdominal surgery with no feeding since birth are considered taken as full stomach, require volume loading of 10 to 20 ml per kg of ringer lactate solution, and but a pre-oxygenation of 1 to 3 minutes before induction is very important. Now I'll come to specific diseases. Tracheoesophageal fistula or esophageal atresia, commonest congenital malformation in 1 in 3,000 to 1 in 4,500 live births. Commonly TEF is of 5 types, A to E, but most commonest is C type. Diagnosed in delivery room where suction catheter cannot pass from mouth to stomach. Premature infants are 20 to 30%. The incidence of congenital heart disease is accompanied in esophageal atresia or TE, tracheoesophageal fistula. Echocardiography and X-ray chest are very important. This is the type C TEF. Infants having a pool of secretions in a pouch. The secretions collect in a pouch, and these infants are kept in a semi-upright position because of obvious reasons, with drainage catheter on low pressure in the suction. Before induction, atropine 20 microgram per kg is given. Pouch is aspirated and inhalation induction performed. Avoidance of positive pressure ventilation to prevent gastric distension. Intubation is done in deep plane without muscle relaxation and very gentle positive pressure ventilation. Location of fistula is identified by auscultation. Then premature infants, we prefer awake intubation, induction with sevoflurane or isoflurane, and it can be associated with hypoventilation, hypotension, and coughing. Tube is taped at the location below the fistula but above the carina. If fistula is at carina, tube is advanced into the bronchus of lungs or non-operative side. Number of proposed methods of estimating correct endotracheal position are there. Manipulating the endotracheal tube during auscultation is one. Second is placing tracheal tube into the bronchus and withdrawing until air entry is heard bilaterally. Rotating the ETT so bevel faces interiorly away from the fistula in an attempt to occlude the fistula. A cuffed ETT provides assistance in occluding fistula. Many surgeons do rigid bronchoscopy, so care has to be taken to avoid tension pneumothorax during bronchoscopy by limiting insufflations of oxygen via the bronchoscope. However, oxygen desaturation does occur during the bronchoscopy. Let me skip all this. Bleeding into the trachea during surgical manipulations causes blockage of ET2. Suction or replacement of the tube is needed if block cannot be cleared, and a blanket arterial line is a good alternative to radial and femoral line. Arterial catheterization is advisable for arterial blood gases in patients with unstable hemodynamics. Fentanyl is used for intraoperative as a continuous infusion for postoperative analgesia. Paracetamol rectally can be given. Caudal catheter can be advanced to T6 to T7 to supplement the general anesthesia. Provides excellent postoperative analgesia. However, most infants are extubated if awake. Infants less than 2,000 grams require post-operative mechanical ventilation. Endoscopic surgical procedures for TEF are attractive alternatives to open procedure. Use of procelaryngeal mask airway allows drainage of gastric fluid and air, decreases chances of unvented gastric insufflations. Now I come to omphalocele or gastroschisis. Both omphalocele is 1 in 6,000, gastroschisis is 1 in 15,000. Live births look similar. Gastroschisis is not midline and omphalocele is midline. And anesthetic maintenance, we use fentanyl and inhalation agents. Increase intra-abdominal pressure and diaphragmatic elevation reduces respiratory compliance. Extubation is inadvisable. Avoid nitric oxide. Continue. Epidural injection provides analgesia. Maintenance of body temperature is essential. Motor blockade without respiratory depression is advisable. It reduces more post-operative ventilation impairment. Isotonic fluid 10 ml per kg per hour or more in the form of colloid or albumin are helpful. Dopamine infusion is required in most of the cases. Warm irrigation fluid is also required. Little bit about pyloric stenosis. Incidence is 3 in 1,000 live births. Symptoms that appear in 2 to 6 weeks of life: severe projectile non-bilious vomiting with resultant hypochloremic dehydration, preoperative period, measurement of electrolyte imbalance, correction of hypovolemia and alkalosis to be done in the preoperative period by administration of 10 to 20 ml per kg of isotonic fluid. Goal is to lower the serum bicarbonate less than 30 milliequivalents per liter. Maintenance fluid of D5.45 normal saline at 4 ml per kg per hour to be administered. Alkalosis is also associated with hypovolemia. Orogastric tube placed, suction after IV 1.15 milligram per kg atropine. Sorry. Prior to rapid sequence intubation and cricoid pressure. Placement of 3.5 millimeter endotracheal tube or size which yields a leak of 10 to 25 centimeters of water. Nitrous oxide is avoided. Maintenance of anesthesia is by inhalation agents with fentanyl. Local infiltration technique can also be used. Postoperatively wound infiltration, rectal acetaminophen and ketorolac are very important. Blood glucose monitoring is essential. Awake intubation is safer. Oral feed may be started 4 to 6 hours of surgery. Necrotizing enterocolitis or intercellular obstruction, just 1 or 2 minutes, primarily seen in premature preterm infants less than 32 weeks and low birth weight less than 2 kg. Intercellular obstruction in manifest in 2 to 6 weeks. Incidence is 1 in 2,000, and it is because of interstitial due to congenital. Other malformations also can occur: duodenal atresia, lard band, mutations, etc. Clinical picture is abdominal distension, hypotension, coagulopathy, sepsis, dehydration, and electrolyte imbalance. These neonates are critically ill, come to operation theatre with ETT and inotrox, and with the need to give judicial fluid management at the rate of 70 ml per kg. Intercellular obstruction, patient we need to give 20 ml per kg of isotonic crystallites to combat dehydration. Rapid sequence induction with cricoid pressure is preferred in debilitated patient. Nasogastric tube is, however, essential in these patients. Ketamine at the rate of 4 ml per kg per hour and fentanyl 10 to 20 microgram per kg along with muscle relaxant can be given. Nitrous oxide is contraindicated. Blood FFP, platelet, dopamine, adrenaline in low doses is very essential. Light general anesthesia and epidural analgesia are contraindicated, but considered in intercellular obstruction. Intra-arterial catheter is advisable. Meticulous fluid management is more important. Abdominal drain percutaneous need to be done, need to be put in, and patient child needs to be shifted to ICU with IV analgesia and IV analgesics. Congenital diaphragmatic hernia, little bit. Incidence of congenital CDH is 1 in 2,500 live births. Congenital diaphragmatic hernia neonates are because of herniation of abdominal viscera into thoracic cavity, which leads to pulmonary hypoplasia due to compression by the viscera on developing lungs. To improve high frequency ventilation with extracorporeal membrane oxygenator can be done with the use of nitric oxide and pulmonary vasodilators. However, nitric oxide use is controversial. PaO2 less than 80 millimeters mercury, PaSO2 more than 40 millimeters mercury remains after therapy. The child may take 10 days before stabilization. Coming to the OT, listening to breath sounds beforehand is important. And it can cause trauma to the healthy lungs. This is the picture of CDH. An oronasogastric tube is inserted. Neonates who are not intubated before arrival are generally intubated awake with rapid sequence induction. Analgesia administered. High inflation pressure for mask ventilation is to be avoided. Propofol and fentanyl to be given. Intra-arterial catheter is recommended, and child's more so important is to avoid hypoxia, acidosis, and hypothermia. Blood loss to be taken care of. Isoflurane and sevoflurane used can be directly administered into the extracorporeal membrane circuits. Now, to conclude my today's presentation, the responsibility of treating neonates with severity of illness is challenging. However, smallest and sickest neonates can be successfully anesthetized with proper planning. Attention to minute details and adequate knowledge of newborn physiology is a must for the anesthesiologist. Thank you so much.
The topic of my talk is neonatal pain assessment and treatment. The International Association for the Study of Pain in 1979 defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage, which means an experience was required to describe the pain, which was not at all applicable for neonates. In 2020, the same definition was revised, and it was revised to an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So this terminology was removed, and due respect to the neonates and non-verbal community is provided. So this revised definition has accompanied keynotes also, and out of those 6 keynotes, 1 note is applicable to the neonates, which is the verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. Neonates depend upon others to recognize, process, and manage their pain. Neonatal pain and neonatal stress, they are interlinked. So pain itself is on a continuum of stressors ranging from handling to skin breaking procedures. Pain perception in the human fetus at the age of 6 weeks, the synapses between peripheral sensory afferents and the dorsal horn neuron in the spinal cord appears. And by 8 weeks, cutaneous sensory perceptors in the perioral area, and by 20 weeks, all cutaneous and mucous surfaces are studied with the cutaneous sensory receptors. By 16 to 18 weeks, specific hemodynamic and neuroendocrine responses to noxious stimuli is there. And by 20 weeks, thalamocortical connections are there. And after about 24 weeks, a fetus is fully mature enough to receive the pain stimulus. Peripheral nervous system, the sensitivity of the receptors, frequency of firing of receptors, and because of neuronal sprouting, the receptor field area is much increased. So in this situation, when sensitized, the receptors respond to new forms of stimulation, and they just manifest as hyperalgesia and allodynia. Central nervous system, central sensitization is much more. Formation of spontaneous impulses are more. There is increase in the magnitude of response to C fiber activity by the dorsal horn neurons, and increased intensity of response along with neuronal sprouting with increased nerve endings into the adjacent lamina, along with a decrease in the impulse threshold is there, and all of these constitute a long-term potentiation for cellular memory, for pain, which may lead to massive responses to nociceptor stimuli later on in life. So preterms have limited ability to modulate pain, as efferent excitatory pain neurotransmitters are not balanced by descending inhibitory neurotransmitters. There are long-term effects which are very harmful, and by studies they have put forward so many long-term effects because the neonatal period is a critical period of neurodevelopment due to immaturity and neuroplasticity of the vulnerable nervous system. And this plasticity is for the active neonatal stimulus, active developments. Noxious stimulus is not an active normal development. It is something abnormal. So noxious events, they have a very gross impact on the long-term effects. So there would be increased risk of neurodevelopmental impairments, including short and long-term physical and psychological disability, adverse changes in the brain development and processing, and alterations in somatosensory function that lead to pain. And there are significant long-term effects that persist into childhood and even adulthood. Why there is neglect of pain relief in neonates? So the possible reasons may be inability of neonates to express pain specifically, lack of awareness of neonates' capability to perceive pain, clinical situations wherein pain is perceived, painless routes and methods of analgesia. Then sometimes there's temptation to perform quick procedures without analgesia, thinking that the baby would not say anything, cannot complain. Then reluctance to use analgesics due to side effects, fear of inducing dependence on the opioid drugs, and health providers' knowledge and attitude. There are various responses to pain in the form of physiological, behavioral, hormonal, autonomic changes, along with body movement involvements. So these physiological and behavioral changes, most of these are, along with these autonomic changes, most of these are included in the assessment of pain. And these are incorporated in the pain assessment tools. Out of the behavioral changes, facial expression is very important, and the face is divided into three regions: the forehead, then the eye region, and below this these eyes, this is the third region. And this is a very important region for as far as the pain is concerned. So when the baby is in pain, or you can say the massive stress is there, then there is furrowing or bulging of brow. Then here it is, then eyes are tightly closed, mouth is opened, squarish, and deepened nasolabial fold. There is squaring of the chin, and tongue is taut. So pain assessment tools are there, and there are a huge number of pain assessment tools which exist, but every pain assessment tool is not validated. So it's not applicable for perfect utility. So to be considered reliable, an individual tool must be validated in the patient population, the clinical context, and the type of pain, whether it's procedural or post-operative, something like that. So no single tool can be universally recommended for use in all neonates in every situation. This is a very old neonatal facial coding system, and it is having all these behavioral variables applicable for procedural pain. It's a reliable tool. Then cries. It includes saturation of saturation as well as heart rate and blood pressure, along with facial expressions, used for post-operative pain, and it is also reliable. Then immature infant pain profile, PIP tool. This is used for acute and post-operative pain. It's valid, reliable, but this tool has been further revised further, and this revised tool is just to improve the feasibility of the assessment tool. Then comes this comfort B, and comfort neo scales. Comfort B is for post-operative pain, while comfort neo is for prolonged pain. When the neonate is having a persistent pain, say a prolonged pain after post-operative period, then it's not necessary that the baby may cry. Sometimes with the persistent pain, the baby may not cry, and particularly in critically ill patients or the baby who has undergone a major surgery, and no expression is there, baby is lying listless, that doesn't mean not feeling pain. So there this comfort neo is applicable, and because it shows facial tension, muscle tone, and there are different scoring for that, and it can be assessed that way. Then comes the NPAS, neonatal pain agitation sedation scale. It's the normal 0, and on one side manifests as sedation with -2 and -1, and on other side pain and agitation with increasing order. So it is applicable for post-operative pain, procedural pain, and ventilated babies in NICU. And this is of high consistency, and it is valid. The modified pain assessment tool, MPAT, it is applicable for post-operative pain and validated and reliable, and overall score is 20 because 10 variables are there, including this nurse's perception. In case of paralyzed neonates, the scoring is done out of 10. The various research efforts to improve the objectivity and accuracy of the assessment tools are serum or salivary cortisol measurement, neuroimaging tests, neurophysiological tests, and changes in skin conductance, but they are not in real-time entities, and as such, no golden rule is golden tool is there, and for that, whatever situation is present in a particular unit, according to the cases, according to the number of healthcare workers, the protocols regarding these choice of assessment tools can be made. There's so many painful procedures in neonates, and maybe diagnostic, therapeutic, and of course surgical, and all surgical procedures, they are painful. International Association for the Study of Pain had suggested a stepwise approach with 6 steps for neonatal analgesia almost a decade back. It was similar to WHO analgesic ladder for pain management, with increasing analgesia for the increased degree of anticipated procedural pain. So in the pain management, non-pharmacological as well as pharmacological measures are taken up. The Indian Association of Pediatric Anesthesiologists, they have come up with the advisory for pain management in neonates and pre-verbal children in 2020. They have suggested 5 steps. Step 1 for non-pharmacological interventions, and step 2 to 5 in pharmacological management. Step 2 with paracetamol, NSAIDs. Of course, NSAIDs are not given in neonates because of undesirable risk-benefit ratio. Step 3 is for topical or subcutaneous infiltration of local anesthetics. or a particular peripheral nerve blocks or neuraxial blocks. And step 4 is then addition of opioids, and step 5 is further combination of opioids and other adjuvant analgesic drugs. Various non-pharmacological approaches are non-nutritive sucking, swaddling, then sucrose therapy, KMC, breastfeeding, and in breastfeeding, higher content of tryptophan, which is a precursor of melatonin, which increases the concentration of beta endorphins, is responsible for analgesia. Then comes the pharmacological approaches. For this, an individualized multimodal pain management approach should be there. The preemptive analgesia with systemic analgesics and the central neuraxial and peripheral nerve blocks are instituted before surgical incision and continued perioperatively. And further, post-operatively also, the blocks should preferably be given under ultrasound guidance if the paraphernalia is available. And in neonates, caudal epidural route is considered as a choice because you can guide the catheter till mid-thoracic level. So treatment plans can be modified depending on the surgical procedure performed and on the perioperative hemodynamic fluctuations. We come to drugs. I'll just say that regarding acetaminophen, the volume of distribution decreases and the clearance increases from 28 weeks onward, and that's why there is a gradual decrease in the elimination half-life. So that is why the dose of this paracetamol is 12 hourly as compared to 6 to 8 hourly in prematures. Now the reactive product, if it's increased, it may lead to liver toxicity if metabolic enzyme system becomes saturated due to overdose. So one has to be very careful about the dosing of paracetamol in neonates. Regarding morphine, in the initial 7 days, the clearance decreases almost to 30%, and elimination half-life increases. Sedation, respiratory depression is of course expected. Then nurse controlled analgesia can be taken up where the facility is available. Fentanyl has low clearance and it may accumulate in neonates with the lowest postnatal and gestational age. So dose reduction is required. Otherwise, alfentanil, sufentanil, remifentanil, every opioid has been studied in, has been not to that extent that pharmacokinetics and dynamics are studied in detail, but they have been used in neonates. Regarding remifentanil, it's used in intraoperative and ventilated neonates in ICU. Tramadol is not used in neonates because clearance is reduced, and moreover, the main point is that because the metabolizing enzyme CYP2D6, which is involved with codeine also, this is genetically and developmentally regulated. So one should never disturb the normal milieu of the neonates deliberately. So if we have choice, we should go for that. Similarly with ketamine, the NMDA receptor undergoes developmental changes in distribution, structure, and function, and it helps in regulating the neuronal plasticity. So there is definitely a potential for neurotoxicity. Regarding clonidine and Daxim, Neonates are more susceptible to effects and side effects of clonidine. So the dose should be reduced because with epidural clonidine, massive respiratory depression has been noted in neonate. Regarding Dexim, the case reports of seizures or bradycardia have raised further concern of its use. Otherwise, it's being used for sedation. Regarding local anesthetics, neonates are at much higher risk of local anesthetic toxicity, and so duration of infusion should be limited to less than 36 hours. With ropivacaine, the context-sensitive half-life does not increase with the duration of infusion. Regarding EMLA, the methemoglobin reductase, the enzyme that catalyzes the reduction to hemoglobin, is also developmentally regulated, rendering neonates more susceptible to methemoglobinemia, and moreover because of fetal oxygen carrying capacity also. In 2020, the Indian Association of Pediatric Anesthesiologists, they have come up with an advisory, as I already discussed that step ladder pattern, but very important points have been recommended regarding the management of pain in preverbal and neonates. The points are that each facility caring for neonates should formulate protocols for pain management. Age-appropriate, easily understandable pain assessment tools should be used consistently before, during, and after painful procedures to monitor and achieve optimum post-operative pain relief. Multimodal approach combining pharmacological, loco-regional, and non-pharmacological therapy for post-op pain are the key to successful pain management. Regional anesthesia is an important component of multimodal analgesia, of course, with vigilant monitoring. Regarding the infusions, meticulous preparation is required and duration should not exceed 36 hours. Post-operatively, pain parameters should be documented at 15 minutes interval, and once the baby is discharged from PACU, then 4 hourly up to 48 hours in cases of major surgical procedures. And the treating physician must weigh the risk and benefit of the techniques or drugs he or she is using, because appropriate facilities to deal with side effects should be immediately available. For children on mechanical ventilation, pain assessment can be documented by nursing staff, but the attending intensivist should perform an independent assessment and plan further management. All analgesic interventions and their efficacy should be documented. And any special concern should also be documented at the time of scoring, and the team should ensure that the handover to the person in the next shift includes pain assessment and management to provide continuity of care. So to conclude, the mainstays of appropriate neonatal pain management include the physician's awareness of neonatal pain, appreciation of situations wherein pain occurs, sensitivity to the need for controlling pain, a generous measure of common sense is required. Thank you.
Good afternoon, all of you. Good evening. At the outset, I would like to thank the organizers and very specially our Talika ma'am for giving me the opportunity to share a few of my thoughts about the pediatric urology cases and anesthetic management. In the coming 20 minutes, I'll be dealing about the anesthetic management in the pediatric urology cases in the following guidelines: introduction, pre-anesthetic evaluation, optimization, different types of pediatric urology surgeries, anesthetic options, perioperative management, postoperative analgesia, and the summary. The pediatric urological surgeries, they range from a simple circumcision to more complex surgeries like a correction of X-ray for the bladder. The anesthetic techniques used vary according to the age of the child, the requirements of the surgeon, and the medical status of the patient, and the associated comorbidities. The majority of the urological cases in the pediatric age group, they're congenital in origin and therefore distinct from those in the adults. The special concentration in the children with the urological case are, they may suffer from renal insufficiency and associated comorbidities like electrolyte imbalance, anemia, hypertension, and metabolic problems, mostly metabolic acidosis. The usage of the irrigational fluid, very particularly for surgeries like PCNL, can make it more difficult to estimate the blood loss. At the same time, increase the risk of perioperative hypothermia and electrolyte disturbances. Many urological procedures are performed in the lithotomy position, so one should be very careful in keeping the limbs so that there will not be any permanent nerve injuries. Children with congenital urological abnormalities, they are subjected to different stages of surgery once more, again and again, and theoretically they're prone to go for latex allergy. The pre-anesthetic evaluation preparation are similar to other types of surgeries in this group. The pre-anesthetic assessment for the major surgeries must ensure that the implausical values and the biochemical results are within normal limits. And majority of the children with the congenital disease are associated with the cardiac abnormalities, so one should be very careful in excluding a cardiac disease. Airway assessment is very particularly stressed, particularly in syndromic children. In conditions with a high incidence of associated spinal abnormalities, imaging should be undertaken before considering the central neuroaxial block for analgesia. These are the congenital syndromes like a Vector association, Charge syndrome, DiGeorge syndrome, a brachio-otorenal syndrome, and Townes-Brocks syndrome. If you see, majority of them have got cardiac diseases, so one should be very careful about that. The common pediatric urological surgeries, as I told, range from circumcision to the most complex and sophisticated robotic pediatric urological surgeries. In our institute, the last year, though we had less in number because of COVID, still we could do 60 circumcisions, 64 hypospadias correction, 52 orthodopexy, and 22 posterior surgeries, and 15 pyeloplasty, and 2 PCNLs, and 5 nephrectomies. Except the 2 PCNL cases, all the remaining cases are done by our efficient pediatric surgeons, and the PCNL were done by urologists. The perioperative management, the fluid, the fasting guidelines as applicable for the same, the age group in this particular pediatric age group. The 6-4-2, where 6 hours for solids, 4 hours for breast milk, and 2 hours for clear fluids is also applicable here. The pre-medication, as routinely done for this age group, very particularly for the separation from the parents and the anxiety and sedation as considered. The fluid management depends upon the maintenance with holiday saga regime, but special emphasis is given here because they have got a renal problem. You are very careful about the fluid overload, associated electrolyte abnormalities, and very careful about that. Basing on that, we have to adjust the fluids. The anesthetic management usually depends upon the age of the child. A child is a very small child, you go for controlled ventilation, and a child is a bigger child, you go for spontaneous ventilation. And usually we combine J with renal anesthesia because we can render very good postoperative analgesia. But one should be very careful in the preventing hypothermia in this age group. The circumcision is one of the most common pediatric procedures. It can be done as religious purposes, or it is done for recurrent balanitis and balanitis xerotica obliterans, where the foreskin is fibrous and adherent to the underlying prepuce. If the foreskin is otherwise healthy, they can go for a dorsal slit called prepucioplasty. A ring block or Dawsoner block can be safely used. GA will be, you can go based on the age group, you can go for inhalation agent in small children, or you can IV induction in older children. When you go for older children, you can keep them as spontaneous ventilation with LMA, and younger children you go for robotic intubation. The analgesia is provided using either a penile block or a single caudal injection, but the problem with caudal injection is in day-case surgery, we can't send them out because there may be residual pulses and it will delay mobilization, where the penile block is preferred. Hypospadiasis incidence is 1:350 male births. The urinary metastasis in the undersurface of the penis, that's called hypospadiasis. Above the surface called epispadiasis, and they may busted cardi also. The surgical correction is performed usually at 6 to 18 months of age. In most cases of hypospadiasis, very simple, because the opening may be at the distal part of the penis or in the middle of the mid shaft of the penis, and the operation is straightforward and a single setting may be corrected. But in severe hypospadiasis, the metastasis is situated at the base of the penis or in the perineum, where we have to plan for a staged repair. General anesthesia is frequently combined with a regional anesthetic technique for hypospadic correction. Orotracheal intubation is preferred for younger children and undergoing prolonged procedures, very particularly when they want to have buccal graft and a complicated epispadias in where the opening is in the perineum. An LMA with spontaneous ventilation may be used in older children. For hypospadias repair, one can go for directly caudal extradural block, and it can provide post-op analgesia also. Pillar nerve block can be given only for simple cases where the opening is at the tip of the shaft of the penis or in the middle, or else in the complicated one where the opening is in the perineum, penile nerve block is not effective. Acrodepexy is done for undescended testes. Undescended testis incidence is about 1% of the full-time infants at 1 year and 5% of those born prematurely. Acrodepexy involves the surgical exploration of the inguinal region with dissection and retraction on the spermatic cord. A scrotal incision is also required to fix the testis in its normal position. When the testis is not palpable and could not be identified by ultrasound, we have to go for laparoscopic procedure, whereby you have to identify the testis and a staged procedure is done. So we can remove the testis, and or you can do acrodepexy and fix it. So anesthetic technique is, if you want to do a laparoscopy, naturally you have to control ventilation, you have to go and you have to intubate the child. If it is a superficial one where the testis is palpable, you can give a combined technique of regional along with your general anesthesia. In general anesthesia, again, based on the age of the child, you can go for a LMA and spontaneous ventilation, or you can have a controlled ventilation. The posterior urethral valves, a congenital obstruction of the posterior urethra ascribed to the valve-like leaflets. The incidence being 1 in 5,000 to 8,000 live male children. Young classified into 3 types: type 1, type 2, and type 3. Type 1 is more common, and type 3 has got a bad surgical outcome. Widening cystourethropy is the gold standard for the diagnosis of the posturethral valves. And majority of the situations, it can be diagnosed antenatally by ultrasound. The treatment is valve ablation or fulguration under general anesthesia. They usually do it at 5, 7, 12 o'clock positions. The vesicostomy is done for the low birth weight children where they cannot tolerate the fulguration technique. The testicular torsion is very important, acute scrotal pain, where whatever you be the diagnosis, you have to suspect this, because if you neglect that, the child will land in necrosis or testis or neglect, a permanent damage will occur. So whenever a child complains of scrotal pain, we have to explore surgically, and basing on the condition of the child, we may go for regional blockade, or you can go for general anesthesia. Very particularly, because of the pain and distress, they may have delayed gastric emptying, and you may have to go for rapid sequence induction. And again, the combination of acetaminophen, NSAIDs, local anesthetic infiltration, and IV fentanyl, they can provide good post-op analgesia. A caudal extradural block is also widely used for this procedure. Manipulation of testis, when the blockade is not up to the level of T10 or above, you may get a vagal response, and neutropenia and glycopene should be available. Cystoscopy is the most common diagnostic procedure. It can be a diagnostic procedure as a part of therapeutic procedure like percutaneous nephrolithotomy. So the cystoscopy in the older child, you can have a face mask, and you can have the help of your Waltler anesthetic, you can do it. Or you can, in the younger children, you have to control the ventilation, intubate the children. Most important thing is that you have to keep the child in deeper plane, because when you insert the cystoscope, it may precipitate a laryngospasm. And the percutaneous removal of the stones, the percutaneous nephrectomy PCNL, is also possible in this pediatric age group. But here they have to keep the child in prone or semi-prone, so you have to invariably intubate the child and control the ventilation. One important factor here is they use a lot of irrigation fluid, so there may be a absorption of the fluid leading to fluid overload. There will be ocular disturbances and there may be a chance of hypothermia. Prophylactic antiemetics are needed in these children. Laparoscopic urinary tract procedures are now coming in a big way. All the surgeries like this pyeloplasty, nephrectomy, partial nephrectomy are done under laparoscopy. And one should be very careful in deciding the intra-abdominal pressure. And if you allow more, there will be a problem for the child and you may get the compartment syndrome. At the same time, the limitation of the surgical procedure, the time is also very important in a younger age group. And you have to see that all the children are intubated thoroughly with a covered tube so that they can prevent aspiration. And you can have a good analgesia by providing infiltration at the ports, or you can have local installation into the retroperitoneal space. An intercostal block can be given, and IV fentanyl or IV paracetamol add together you can give. Now the robotic surgery is also coming in a big way by laparoscopic procedure. Pyeloplasty is performed to relieve the pelvic-ureteric junction obstruction that produces a partial blockage of the ureter. This causes hydronephrosis and the prolonged back pressure that may result in diminished renal function and subsequent loss of renal cortex, and the child may have to go for nephrectomy. The classical pyeloplasty is an open procedure using a subcostal incision. Now it is done under laparoscopy also. The transabdominal posterior approach is also possible. Most of these children are healthy with normal renal function and they have no alveolar disturbances. Nephrectomy or heminephrectomy is performed for a multiple dysplastic kidney, congenital renal dysplasia, severe reflex nephropathy, and severe obstructive neuropathy, and also for the tumors like Wilms tumor in this pediatric age group. But one should be very careful to confirm that the kidney is not functioning by perfusion scans, and only Wilms tumor where need not do that medical legally. So this can be performed laparoscopically, because in laparoscopy the incision does not split the muscles and it is consequently less painful. Local anesthetic infiltration combined with the simple anesthetics and oral opiates are also adequate. Open procedures are suitable for combined GA and regional technique. When you want to do for laparoscopic procedures, invariably you have to go for GA only. And an epidural catheter or ultrasound guided unilateral tab block or an opioid infusion all are considered to be adequate for the analgesia for post-operative period. Some children have underlying conditions such as spinal bifida, renal artery stenosis, polycystic disease, or chronic renal disease that significantly affect the anesthetic technique used. Important systemic considerations are anemia, hyperkalemia, fluid overload, and hypertension. The Wilms tumor usually comes around either 3 years of age. The surgical intervention is required depending on the stage of the tumor, and bleeding is a major consideration in this removal of the Wilms tumor, especially when it has extended into the inferior vena cava. So we're very careful about the bleeding, and one should be ready with the packet cells to counteract that loss. Analgesia should take into account the extensive nature of the procedure, and epidural and opioid infusion may be used. Coon-Belly syndrome, also known as Eagle-Barrett syndrome, it occurs 1 in 40,000 births and is predominant in boys about 95% of this. Bilateral cryptorchidism and dilatation of the ureters and bladder are constant features. Urethral obstruction leads to bladder distension, hydroureter, and hydronephrosis with small dysplastic kidneys. Abdominal distension leads to abdominal muscle deficiency and excessive abdominal skin. The surgical treatment is required to relieve the obstruction of the urinary tract when reflux gives rise to repeated infections and autocropexy. Because of the defective abdominal muscles, they can't have effectively cough and there will be return secretion. So one should be very careful before taking up the case for chest physiotherapy and oral antibiotics to control the infection, and the bronchodilation is needed because these people invariably require general anesthesia and they require controlled ventilation, and these children may require a post-op ventilation also. The bladder extrophy, in this, take the different types of extrophy. The classical bladder extrophy is the most common and affects 1 in 2 lakh live births. The defect of the lower abdominal wall and the anterior wall of the urinary bladder. The posterior wall of the urinary bladder appears everted, that's called extrophy, with varying degrees of pelvic diastasis. The goals of the reconstruction surgery are to achieve the closure of the bladder, obtain the urinary continence while preserving the renal function, and producing satisfactory appearance and function of the external genitalia. The surgical correction could either be a single stage one closure of the bladder and epispadias, or usually it is a planned stage repair. Multiple procedures are usually necessary, and theoretically they may land in latex allergy. The primary surgical repair requires several hours of surgery with fluid and blood loss that can be considerable in the newborn. We're very careful about that. You have to be prepared with packed cells, and if possible, you may have got to go for first present plasma also. It is recommended that adequate venous access and invasive vascular monitoring is utilized. The meticulous postoperative care is essential because the prognosis is not good in all the cases. The pediatric robotic urosurgeries are coming in a big way, and the robot-assisted pyeloplasties, ureteral reimplant, ureterostomies, appendicocystectomies creation, bladder neck reconstruction, and augmented ileocystoplasty are successfully done. But the one important thing is prolonged anesthetic exposure is a major concern in the pediatric case group. And other limiting factors are the key differences in pediatric robot surgery are the insufflation volumes and pressures are limited in children. The smaller cavities lead to decreased working space. It requires unique port placement based on child size. The limited availability of the 3mm and 5mm instruments is one important factor. Now, robotic assisted laparoscopic pyeloplasty ROLP is become very popular nowadays. So latex allergy, theoretical one, which because repeated exposure and exposure to latex, they may have a type 1 epicenter reaction with the bronchospasm and cardiovascular collapse, which may occur immediately after anesthetic exposure, or may occur 30 to 60 minutes after induction or even in the postoperative period. And delayed type 4 episensitivity may occur 6 to 48 hours after the exposure and may manifest as watery and itchy eyes. It should be taken, all precautions should be taken for anaphylactic reactions. The post-op analgesia, it depends upon the type of surgery, age of the child, and the comorbidities of the child. For minor and intermediate surgical procedures, you can go for local anesthetic infiltration, simple analgesics, ilioinguinal nerve block, or caudal analgesia. For major relaxed procedures, a multimodal analgesia using NSAIDs unless contraindicated, and acetaminophen, IV opioids, or epidural analgesia. IV opioids either as a continuous infusion or nurse or attendant control can be effective. In laparoscopic surgery, a multimodal technique involves infiltration of the port sites with local anesthetic as part of the multimodal analgesia, and that will good, very good analgesia. So this is the sensory innervation where if you want to lead a kidney surgery, level up to T10, ureter up to T11, like that. Basing on that, you can provide the block and provide post-op analgesia. The caudal epidural is useful for analgesia after intraumbilical surgeries because it can block up to T10 level. We can use levobupropion, bupropion 0.5%, or ropivacaine 0.15%. And it can be used for caudal block along with adjuvants to prolong the blockade like opioids, like fentanyl, clonidine, and dexamethasone. And in Western countries, they preferably use morphine at the dose of 33 to 50 mg per kg and clonidine 1 to 2 mg per kg. And a cheaper drug like dexamethasone can be used at 0.1 per kg. Ultrasound imaging and epidural electrical stimulation called SUI test are options to accurately position a caudal catheter. Ilioinguinal ileoepigastric nerve blocks are used for ilioinguinal herniatomies and the groin incisional orchidopexy. Pain nerve block is often used for circumcision and for minor hypospadial surgery. The point of entry is nearly just below symphysis pubis on either side of this suspension ligament. This helps to avoid the midline vessels. The needle is directed posteriorly, medially, and slightly caudally on each side until the loss of resistance, the penetration of the buccal fascia is felt. Then after aspiration, you can use the drug. So children with urological conditions may suffer from renal insufficiency and associated comorbidities, and should be very careful in diagnosing the electrolyte imbalance, anemia, hypertension, and metabolic problems, and optimize the child before taking up a surgery. The care should be taken for perioperative fluid management. Multimodal post-op analgesia is to be practiced with emphasis on caudal and peripheral nerve blocks. So adopting the right attitude can convert a negative stress into a positive one. And thank you very much for your attention. I profusely thank the organizers for giving the opportunity. Good afternoon, Anita ma'am. Dr. Anila Malde ma'am, your comments please. Unmute ma'am.
Okay, how are you?
Fine, thank you ma'am.
Yeah, I don't think chair people are around.
I think we have to wait for them.
Anyways, we did our talk. And I don't think any questions are there in the chat box also.
Respected chairpersons.
I think we are only talking and we are only audience and we are only chair people.
Yes, ma'am. Yes,
so,
yes,
yes.
yes, ma'am.
It
Yes,
looks
ma'am.
like.
Yes, ma'am.
Yeah.
So, ma'am, as per your lecture, I came to understand that you prefer only ringer lactate rather than going for this dextrose off-normosaline infusions. Even neonate also, you can go for ringer
Yes,
lactate.
yes. Neonates also, it is very much recommended that intraoperatively we give ringer lactate only. Intraoperatively for all the age groups, right from neonate to the adolescent age group, intraoperatively we do give ringer lactate. Post-operatively, yes, we have to go on to the maintenance fluid, but even in a post-operatively initial, at least 6 to 8 hours, we give the ringer lactate balanced solution along with the appropriate quantity of dextrose. If it is a neonate, we give 5% dextrose in the immediate post-operative period along with the ringer lactate. Only after 6 to 12 hours of surgery, then we go over to the real maintenance fluid, because even neonates do require isotonic fluid in the immediate post-operative period. Otherwise, they can develop hyponatremia because there's a lot of idiot secretion in the perioperative period. So because of that idiot secretion, there's a lot of fluid accumulation in the body. So if you are going to give hypotonic fluid at that particular time, the patient can develop really hyponatremia. And we have seen this kind of incidences also, because in spite of a lot of papers and lots of work, still at many places in the district hospitals and the other smaller places, people are still using the hypotonic fluid intraoperatively. So it is a big no to the hypotonic fluids intraoperatively.
And what about isolate P, ma'am? We also stopped using isolate P
isolate
because
P
of the
is
high
not,
potassium content. We stopped using it.
No, it is not a question of high potassium units, sir. It is the potassium quantity is appropriate in isolate P. What is problem in the isolate P? It is containing sodium as only 26 milliequivalent per liter. So intraoperatively, it is not at all recommended. You have a ringer lactate which is having 131 milliequivalent per liter, and isolate P is having only 26 milliequivalent per liter. So it is not at all sufficient. It is to be used only in the post-operative period. Now, most of the places, even this isolate P is not even getting manufactured in many of the places.
Yes,
even we have stopped getting in our schedule also in our Municipal Corporation of Greater Mumbai hospitals. Instead of that, we make appropriate solutions, either using the glucose with half-strength saline, or as I mentioned in my paper, means in my presentation, if it is a neonate, we prepare with the help of concentrated ringer lactate. So individualized approach is very much needed.
So once again, thank the organizers for giving us the opportunity to share a few of our thoughts about this pediatric anesthesia. I think chairpersons are not coming, ma'am, so we have to thank them and quit. I think so.
I think so. I mean, we have to thank each other.
Yes, ma'am.
Probably. And close the session because there are no questions in the chat box.
Only the tech team is watching us.
Tech team also is not declaring the closing of session.
Regarding this pain measurement, ma'am, Dr. Anita Malik, ma'am, you have wonderfully covered this particular neonatal scores.
Yeah.
Practically, it is difficult for us to monitor all the things, ma'am.
Exactly. You know, when you have to give a presentation, you have to collect the recent data and all of those things which are to be there. Because recently in 25, in the up-to-date, there's an article for this neonatal pain management by Dr. KJS Anand, who, you know, has got so many papers in neonatal pain. So he is basically in pediatrics, neonatologist. So he has developed the protocol, and in his words, it's really very difficult to achieve the actual pain scores through the scoring system. You can go roughly, you can pick up one like we picked up and pass, right? But you cannot go every time with that.
Yes,
so it's mild pain, moderate pain, or something like that. And because we are more concerned about anesthesia, so our babies are already having pain for post-operative. Most of it is covered for NICU procedural pains and other things. But yes, definitely. But now IPA has also declared that we should come up for that particular unit some pain assessment tool which is applicable and feasible in that atmosphere. And nurses, and most of the times we are not having proper number of nurses. So residents have to do all those things. So some easy way, but actually the babies should not be neglected. The main thing is this. So what
it is not always the face of the baby, it is the babe. The face attendance is important there. Whenever a small cry comes, they become panicky and ask us to give some more drug.
Yeah, that's there. But advances have, you know, so much that, and because of these regional anesthesia and drugs coming up, but because neonate is an entity where all the developmental things, structures, the different pharmacokinetic dynamics, all is going around. So everybody is very cautious about that. You cannot give that evidence-based. It takes time. But yes.
It was a wonderful presentation, ma'am. You covered very well. An excellent presentation regarding the neonatal pain assessment. Ma'am, my last question regarding the tracheous fistula. Do you practice awake intubation?
No. If you are asking me or you are asking Dr. Suvida?
Dr. Suvida, ma'am.
Yeah, she mentioned that awake intubation is done in prematures. It's
not practice, but nowadays I think, ma'am.
No, we don't practice. I don't even practice spontaneous ventilation till thoracotomy. Like in Mumbai, all of us are practicing for the tracheoesophageal fistula. We do give muscle relaxant and we do give gentle ventilation. Because in any case, even if you try to take the baby under with the sevoflurane and maintain with sevoflurane anesthesia, the neonatal physiology as such it is such that you need to ventilate the baby. You cannot, till they approach the fistula, you cannot just keep them on a spontaneous ventilation. So if you are going to anyway ventilate the baby with the gentle ventilations, you might as well give a muscle relaxant and do unhurried proper intubation. So that is one thing. In fact, I wanted to have a comment on that because many times she mentioned that she does rapid sequence induction with the cricoid pressure. In the neonates, cricoid pressure, at least we are not practicing cricoid pressure. And I think majority of the centers all over the world are not practicing cricoid pressure in the neonates. Secondly, rapid sequence induction is not tolerated by neonate at all. So we do need to give a modified rapid sequence induction. Now, after this article by Newhost came out, we are openly now telling also everybody that we do give the non-depolarizing muscle relaxant. Most of the time we are using atracurium
Yes, ma'am.
as the muscle relaxant. So we do give atracurium as a muscle relaxant. We ventilate gently for 3 minutes and then we are intubating. So because in any case you are going to ventilate the baby, neonates, especially the TEF babies who are preterm babies, are not at all going to tolerate your spontaneous ventilation and a sevofluorine induced depression, because you are going to take under deep plane of anesthesia for laryngoscopy. So that's not done now. I mean, we all do controlled rapid sequence induction for
unmute.
all the
Ma'am,
cases.
unmute
Ma'am,
yourself.
unmute.
Dr. Suvida, unmute.
Okay, okay. No, actually, this was an old school of thought, which I mentioned both. Awake intubation was previously an old school of thought, and then later, now I mentioned it clearly. And nowadays, nobody does awake intubation. It is with sevoflurane and gentle IPPV with fentanyl, of course. I mentioned in the previous slide that for
Yes, ma'am. Yes, ma'am.
fistula, both I mentioned. The previous school of thought is faded now. Awake intubation with IPPV is no more into practice. We don't practice awake intubations because
In fact, it's strongly discouraged, because
Dr.
the
Suvida.
babies may get intracranial hemorrhage.
Because
So
of the immature cerebral vessels, intracranial hemorrhage.
Documented.
The incidence is rapidly rises with awake intubation. So neonates, nobody does awake intubation. This was in an old school of thought. I mentioned that in the slide.
Dr. Suvida, it was a very nice presentation. You covered so much in a very short time.
Short time, ma'am.
But
There is a
thing,
big thing.
yeah,
Big
the thing was because on the top of that it was that premature. So simultaneously at the same time you should have mentioned that it was an old thought. It is just like that communication.
Yes,
Previously it was, yes. Nowadays nobody does awake intubations.
No, once that gap is there, it grows up. So it there and then only you. Particularly those controversial things or debatable topics, there and then only in the favor of that one should. I mean, this is my just suggestion.
I had mentioned, madam, but because lots
time constant is there.
Time 20 minutes there.
Exactly.
I had mentioned that with sevoflurane and with fentanyl and gentle IPPV, we induce the child and we intubate after that. Not
but that gap was there. The gap was there. That's the main thing. Yeah. No, it was wonderful presentation. And Dr. Anila, your presentation was wonderful.
Very good.
And Dr. Babu, Euro is because we are also going for extrophy blood.
Yes, ma'am. Yes, ma'am.
Pediatric surgeon is internationally renowned surgeon.
Yes, ma'am.
And yes, definitely. Though it appears that it's urology, but it's really something which you have to take care of. Yeah.
Very challenging.
Sir, are you doing any pediatric renal transplants?
No, ma'am.
Okay. Recently, we had one case even for cystoscopy, because they did a little longer time cystoscopy. So neonate developed, pulmonary edema at the end. So we have to be very careful even for cystoscopies.
Yes, ma'am. Yes.
And after that, edema was resolved or the neonate died, madam?
No. It was very much resolved, but the baby required, 3 to 4 days ventilatory support, and then did well.
Pulmonary edema can be resolved. It's not a modality, especially in
is it because of fluid overload, ma'am? Because irrigation fluid, they go on giving it. Is the one for that?
That is the reason.
That might be one common culprit.
Because in a sister, see, normally in a bigger child, the pulmonary edema will get easily resolved. You will just give a few doses of Lasix and few hours of ventilation.
but the neonate, it's a quite altered physiology. So it does take time, for pulmonary edema to get resolved.
Yes,
So cystoscopy also we have to be careful, though it appears a very small procedure in a neonate,
yes, ma'am. Yes, ma'am.
can cause the problems.
Yeah, definitely.
Anyway, I think rather than chatting among ourselves, we can leave the thing.
Yes, ma'am. Very nice to associate with you, ma'am. Thank you very much once again.
Okay, bye.
Bye. Thank you,
Bye.
ma'am.
Thank you.
Thank you. Thank you, ma'am.
चलो चले
Hello. Sir, we can start the session. Hello.
To all of you. At the outset, I would like to thank the organizers for giving me an opportunity to speak at this esteemed platform. Now, trauma, we all know, is one of the major causes of increased morbidity and mortality, especially in the first 4 decades of a life. The death due to trauma is often said to have a trimodal distribution, with immediate deaths occurring within the first few minutes, early deaths occurring within the first few hours, mainly due to hemorrhage, and late deaths occurring in days to weeks. So the first hour, also known as the golden hour, is considered often to be a critical period during which definitive resuscitation must be initiated in order to decrease morbidity and mortality and improve survival. In recent times, the concept has moved on from the golden hour to the platinum 10 minutes, which actually places a time constraint on the pre-hospital care of seriously injured patients by the first responders. This is based on the concept that no patient should have more than 10 minutes of scene time stabilization. Thus, the preference is now given to the scoop and run approach of pre-hospital care rather than stay and play. Thus, the immediate and early management of trauma patients includes both the pre-hospital preparation as well as the in-hospital preparation. The initial assessment and management priorities in trauma victims include the sequential management of airway, breathing, circulation, and disability. This ABCD or primary survey should be repeated frequently and whenever a patient's status changes. And during the survey, it is important to prioritize the rapid assessment and treatment of life-threatening airway and breathing problems ahead of the circulatory issues. Now, the rapid assessment and management of the airway is of utmost priority. And whenever a patient's airway integrity is doubtful, it is imperative that we establish a definitive airway early. Now, while assessing and managing a patient's airway, great care needs to be taken to prevent any excessive movements at the cervical spine. According to the current ATLS guidelines, the use of spinal immobilization has been de-emphasized in favor of an emphasis on restriction of spinal motion, and the rapid sequence intubation has now been replaced by drug-assisted intubation as a broad term that describes and emphasizes the use of drugs to assist intubation in trauma patients. The use of video laryngoscopy has also been greatly highlighted. Now, during the early management of trauma patients, the determining which patients require imaging to evaluate the spine injury can be challenging. So the Canadian C-spine rule and the nexus criteria need to be used as decision to aid in this decision-making process. These are said to have excellent predictive value for excluding patients identified at low risk of having cervical spine injury. So the use of these rules may help decrease unnecessary radiological testing, and in cases of anesthesia and airway management, they may facilitate easier intubation because cervical spine restriction can be discontinued safely in many patients. Following airway management, immediate identification and management of injuries that impair ventilation takes a priority. These include managing tension pneumothorax, massive pneumothorax, open pneumothorax, and tracheal or bronchial injuries. Of these, the tension pneumothorax is particularly lethal and has been implicated in almost 5% of major trauma patients. Traditionally, needle thoracocentesis for the emergency management of tension pneumothorax has been performed by inserting a large bone needle or cannula into the second intercostal space in the mid-clavicular line. However, this recent meta-analysis compared 3 anatomic locations where needle thoracostomy could be done in cases of tension pneumothorax. These included the second intercostal space in the mid-clavicular line, the fourth or the fifth intercostal space in either the mid-axillary line or the interior axillary line. And the authors found that the mean chest wall thickness as well as the mean failure rate was minimum when the needle thoracocentesis was performed in the fourth, fifth intercostal space in the interior axillary line. This recent cadaveric study has also shown that following any movement, the needle in the second intercostal space was more likely to become dislodged as compared to that in the fourth or the fifth intercostal space. Thus, the authors concluded that the fifth intercostal space in the interior axillary line was a more stable and reliable location for needle thoracocentesis. So following this, the ATLS guidelines now recommend using the fourth, fifth intercostal space instead of the second intercostal space for needle thoracocentesis in adults. However, in children, it should continue to be performed in the second intercostal space. Next, we need to identify shock and identify and treat the sources of hemorrhage, with great emphasis being placed on the judicious use of crystalloids and early use of blood and blood products so as to prevent the development of the lethal triad of coagulopathy, acidosis, and hypothermia. Now, following trauma, we all know that hemorrhage is one of the most common causes of shock. Now, the recent ATLS classification of hypovolemic shock has been amended. It now includes a category of pulse pressure and base deficit because both of these have been shown to correlate highly with the degree of hypovolemia due to hemorrhage. And it is also important to keep in mind that trends and not absolute values are important for estimating blood loss and transfusion requirements. We need to identify and treat the sources of hemorrhage, the most common of these being the one which is externally visible, which is on the floor. And plus, there are 4 more sources of internal blood loss. These include the chest cavity, the abdomen, the pelvis, and the retroperitoneum, and the long bones and soft tissues. Within the chest, massive pneumothorax needs to be excluded. This is defined as rapid accumulation of more than 1.5 liters of blood or 1/3 or more of the patient's blood volume in the chest cavity. The chest in these cases needs to be decompressed and the blood volume restored. An urgent thoracotomy is indicated if there is an immediate return of 1.5 liters or more of blood, or there is a continuing blood loss of 200 ml per hour for 2 to 4 hours. Then recent reports have suggested the successful use of pre-peritoneal pelvic packing in patients with hemodynamic instability following pelvic fractures. So this has led to the inclusion of this pre-peritoneal packing in the management of hemorrhage algorithm following pelvic fractures, in addition to angioembolization and laparotomy. There are a number of external devices that have come into use for pre-hospital hemorrhage control. These include the junctional emergency treatment tool and the combat-ready clamps, which are actually external devices that can be used for controlling hemorrhage, like tourniquets in places where the standard tourniquets cannot be applied, like the thigh, the groin, etc. In addition, this extat and rescue foam are techniques for controlling hemorrhage, especially pre-hospital hemorrhage, wherein we inject self-expanding sponges and foams into the bleeding cavities so that they rapidly expand and compress the bleeding sites, thus controlling hemorrhage. Now, in patients who continue to bleed despite all measures and they continue to exsanguinate, this resuscitative thoracotomy with aortic cross clamping is another technique which has come into play, and it provides temporary hemostasis. But it is important to remember that this is an invasive technique and thoracotomy itself is associated with increased morbidity. So resuscitative endovascular balloon occlusion of aorta, or REBOA, it is an emergency endovascular occlusion technique which is minimally invasive and acts as a temporizing measure to reduce non-compressible abdominal and pelvic hemorrhage. So this can be used in emergency. This technique can be used in emergency situation as it allows time for definitive surgical or endovascular management. As compared to resuscitative thoracotomy and aortic cross clamping, REBOA is easier to perform. It is less invasive and it is faster. In this, we gain access into the common femoral artery, and an endovascular balloon catheter is placed into the aorta at a predetermined place. Following a balloon inflation, the aortic occlusion occurs, resulting in reduced downstream hemorrhage. Another important emphasis in early management of trauma is on the judicious use of crystalloids, because it has been found that infusion of large amount of crystalloids greatly increases mortality following trauma, because crystalloids tend to displace the already formed clots, lead to hyperchloremic acidosis, dilute coagulation factors, and lead to interstitial edema. Thus, the current ATLS guidelines recommend using no more than 1 liter of crystalloids during early resuscitation and no more than 20 ml per kg of isotonic solution in children. And it is to be remembered that the aggressive and continued volume resuscitation is not a substitute for a definitive control of hemorrhage. So as there is no place for infusion of large volume of crystalloid fluids in early resuscitation, it is recommended that early resuscitation should be done with blood and blood products in increased plasma to packed RBC and platelet to packed RBC ratios. In 2013, this PROMETH study group, they performed a prospective cohort study demonstrating that higher plasma to packed RBC and platelet to packed RBC ratios, they conferred survival benefits in the first 6 hours. Patients with ratios less than 1:2 were 3 to 4 times more likely to die than those with ratios of 1:1. Following this, in 2015, this proper study group, they performed a large multicentric randomized trial comparing ratios of plasma, platelets, and RBCs in a 1:1:1 and 1:1:2 ratio. The authors found that patients administered products in 1:1:1 ratio, though did not have significant difference in mortality at 24 to 30 hours. However, more patients in this group achieved hemostasis and fewer experienced death due to exsanguination by 24 hours. Now, during early trauma, or following traumatic hemorrhage, fibrinogen is one of the key procoagulant factor required for stable clot formation. It decreases rapidly and significantly, and this is one of the first coagulation factor which falls below critical levels during massive bleeding. It has been found that patients with fibrinogen concentrations less than 1 grams per liter are at a greater odd of dying than those having normal fibrinogen concentration. And recent studies and reviews have defined the importance of fibrinogen supplementation, as this supplementation improves outcomes for following traumatic hemorrhage by improving clot strength and reducing blood loss. Now, cryoprecipitate is considered to be one of the important sources of fibrinogen, and following this MATTERS-2 study, it was found that cryoprecipitate administration may independently add to survival benefits following massive blood loss in trauma victims. So since low fibrinogen concentrations in traumatic hemorrhage are associated with poorer outcomes, cryoprecipitate, which is the standard source of fibrinogen administration, is often given in later stages of transfusion therapy. So in order to determine whether it was possible to administer cryoprecipitate within 90 minutes of admission to hospital, this randomized feasibility trial was conducted in 2015. This is also known as the CRYOSTAT-1 trial. And the authors found that early fibrinogen supplementation using cryoprecipitate is feasible in trauma patients. So following this study, it was recommended that there was a need for a definitive RCT to determine whether this early fibrinogen supplementation actually had any benefit in terms of long-term clinical outcomes. So following this, and in order to answer this research question, this CRYOSTAT-2 study is currently underway. It is a large multicentric randomized control trial running in major trauma centers in England and in 8 international centers. And the results of this CRYOSTAT-2 study are still awaited. Then in addition to cryoprecipitate, fibrinogen concentrate is another important source of fibrinogen. And there have been a number of studies in the past comparing whether fibrinogen concentrate or cryoprecipitate is a better source of fibrinogen in cases of hypofibrinogenemia. However, none of these studies have come to a definitive conclusion, and there is no definitive data to suggest that one of them is a better source than the other. So it is now recommended that regardless of what product we have, whether it's a cryoprecipitate or fibrinogen, what is important is a targeted treatment of acquired hypofibrinogenemia following traumatic hemorrhage. So the current European guidelines now recommend treatment with fibrinogen concentrate or cryoprecipitate if major bleeding is accompanied by hypofibrinogenemia. So in spite of the widespread use of component therapy, there is an ongoing debate of whether it should be replaced by fresh whole blood transfusion, because fresh whole blood is an attractive transfusion product as it contains all the components which are required for coagulation, and the lost blood is replaced by a single transfusion product. So its use has been found beneficial in emergency military settings, and in a recent systemic review and a meta-analysis, the transfusion of whole blood was compared with component therapy, and it was found that whole blood transfusion was not associated with the 24-hour on in-hospital mortality. However, there were important limitations in this meta-analysis as most of the studies were quite heterogeneous. So the authors recommended that additional studies are needed to determine the effectiveness of whole blood. Thus, while the use of fresh whole blood in trauma is promising, at present time, the role of whole blood is primarily as a transfusion product when complete component therapy is unavailable. In addition to the judicious use of crystalloids and early use of blood components, there is a large body of evidence to support the use of antifibrinolytic therapy for prevention of blood loss. So this CRASH-2 trial, which was a large randomized controlled trial across 40 countries, studied the administration of tranexamic acid in adult bleeding trauma patients. And following this trial, it was recommended that tranexamic acid should now be administered within 3 hours at a loading dose of 1 gram over 10 minutes, followed by an infusion of 1 gram over 8 hours. Now, although the judicious use of crystalloids and early use of balanced blood and blood products and antifibrinolytics has assisted in a decreasing mortality by preventing the lethal triad of acidosis, coagulopathy, and hypothermia. However, it is now believed that the lethal triad may be leaving out one other crucial factor that interacts with these other 3 factors and can be detrimental to the patient, and this is hypocalcemia. Because in addition to bleeding itself, the administration of blood products during early resuscitation greatly exacerbates hypocalcemia. And as the serum calcium levels drop, coagulopathy occurs, which can lead to continued hemorrhage. And it has also been found that patients with severe hypocalcemia have an increased morbidity and mortality than those with normal calcium levels. So there is now enough evidence to suggest the importance of early management of hypocalcemia in trauma patients than it was previously believed. So it is now increasingly believed that instead of the lethal triad, the target should be to prevent the lethal diamond, including hypothermia, acidosis, coagulopathy, and hypocalcemia. Now, in early trauma resuscitation, a great emphasis is now being placed on damage control resuscitation, which involves all the entities which we have discussed till now, including early airway management, judicious use of crystalloids, transfusion of blood and blood products in a balanced ratio of 1:1:1, early use of antifibrinolytics, and hypotensive resuscitation. By hypotensive resuscitation, we mean using judiciously our crystalloids and not over-transfusing crystalloids so as to keep the blood pressure in a lower range. Because if the blood pressure increases, it may dislodge the clots leading to secondary hemorrhages. Now, damage control surgery is another component of a damage control resuscitation, and this surgical damage control actually minimizes the amount of time and initial procedures which are done in the operating room to only critical interventions. It includes controlling major hemorrhage containing contamination and applying temporary closure devices such as abdominal packing, external fixators, use of hemostatic agents, endovascular stenting, etc. The main goal is to minimize time in the operating room, limiting further bleeding and heat loss so as to allow time for the patient to be resuscitated in an intensive care unit as to correct the physiological and metabolic derangements before a planned return to the operating room. So on the basis of all of these concepts in the early management of trauma patients, the European guidelines have suggested management bundles for early management so as to have a more protocolized approach to trauma patients. These bundles include the pre-hospital bundle, which places a great emphasis on minimizing the pre-hospital time and early transfer to an adequate trauma specialty center. Then the intra-hospital bundle, which places great emphasis on damage control, resuscitation, and damage control surgery. Then we have the coagulation bundle, which places emphasis on judicious use of crystalloids, use of balanced blood products and antifibrinolytics so as to prevent the lethal diamond of acidosis, hypothermia, hypocalcemia, and coagulopathy. To conclude, early management of trauma is a well-defined protocol which needs to be methodically followed, and our understanding of the pathophysiology of resuscitation and trauma continues to evolve and change. The effective care of these seriously injured patients requires the skills of clinicians of several clinical specialties, and it is to be remembered that these tasks should be carried out in parallel rather than sequentially, and it is important to remember that the management plan may change on a minute-by-minute basis as the clinical state of the patient evolves. Thank you for your patient hearing.
Thank you, Dr. Nidhi, for an excellent talk on management of trauma. I think you have covered all aspects very well, and you have taken us through the latest changes in the protocols also, like the lethal diamond instead of the lethal triangle, that or the triad that we used to talk about, and the other treatment modalities. Tranexamic acid also, yes, is a very important part of management, and we're also using it here, and of course the component therapy, early component therapy. So thank you very much. If there are any questions, are we having them at the end of the session, or are we having them after every speaker? If the organizers could tell us. Are there any questions for Dr. Nidhi? Okay, then we could go on with the next speaker. Thank you. Thank you once again, Dr. Nidhi.
Thank you so much, ma'am.
Can we have the introductory slide of our next speaker, Dr. Sandeep Diwan?
Hello, ma'am. Hello. Hello.
Yes, you're audible. Who is this?
Ma'am, I am from technical team. Ma'am, जो speaker है संदीप दीवान मैम, उनकी कोई वीडियो और ना ही सीवी हमें रिसीव है, तो मैम शायद वो लाइव दें.
All right, then he can introduce himself.
Next.
Yeah, then he can introduce himself.
The next slide, Ella. तो नेक्स्ट स्पीकर का ले लो.
Speaker are live.
Okay.
Sir, we have no video.
इनका recorded है क्या? Because I don't see his
No,
name
ma'am.
here
No,
amongst
ma'am.
the.
No, ma'am. No, ma'am.
Well, is he with us? Dr. Sandeep Diwan, is he with us?
Ma'am. No, ma'am.
Then can we have the next speaker then?
Ma'am, next speaker is Syed Mohit. Dr. Syed Mohit.
Okay.
Ma'am, we have not received any video.
Hello, ma'am.
Next speaker.
Ma'am, as we not receive any audio or video from that doctor side, so we can continue our session after 5 p.m.
You mean to say there is no other speaker who has joined for this
Yes, ma'am.
session?
Yes, ma'am.
Okay, then we end the session here. We don't know if they're going to join after 5 p.m.
Yes. So it's the end of session.
Nidhi has done such a good job that we don't need any more speakers in this session. Yeah, Nidhi.
Seems like that, ma'am.
Yes, including your platinum 10 minutes and everything. You've given us a very good
Good
overview.
afternoon, I'm Dr. Arvind Arya from
Yeah, hi,
Delhi.
Dr. Arvind and Dr. Surinder. Good
She
afternoon.
was having very beautiful presentation. We can have some discussion here only right now.
They say well begun is half done, and Nidhi has done well begun is all done.
Yes. Yes. Yes, Dr. Arvind, कुछ discussion आप करना चाह रहे हैं?
Actually, ma'am, I'm the chairperson for next actually session actually on the.
I see. Okay. कोई बात नहीं. इस session में भी आप participate कर सकते हैं. We have time. We have ample time.
Actually, there is some problem actually. Why the people have not been there? Either they have submitted their presentations or not. I really don't know.
No, but then the organizers should have known and contacted and.
Actually, I don't know. Actually, earlier that was our topic was in Hall H. Now it is Hall B or Hall
Yeah,
D. I really don't
it
know.
has been shifted.
Earlier, then, if there are no questions, no other speakers, I think Dr. Surinder, should we close the session?
I think there's no other way.
Anna? Okay. So thank you very much for this very nice session and short and brief and crisp, but very well done, Nidhi. Thank you so
Thank you
much.
so much, ma'am.
Yeah,
Thank
it
you,
was
ma'am.
Thank you.
Thank you, ma'am.
all said and done. It was a full of knowledge session, whatever.
Yeah, and she's
Thank you
given
so
us all the latest updates too, which
Yeah,
is very
perfect.
good. Yeah.
Thank you so much. Thank you, ma'am. Thank you, sir.
Thank you, Dr. Devi.
Hello, ma'am.
Thank you.
Thank you all,
Good evening.
and thank you, organizers.
Yeah, thank you.
Ma'am, Dr. Sandeep Diwan sir going live with us.
Pardon?
Dr. Sandeep Diwan sir.
Has he joined?
He going to join.
Himanshi, what are you trying to say? Is he joining? You
Yes,
want us to
ma'am.
wait? All right, we'll wait.
Important and interesting announcement. We have a virtual program of songs, instrumentation, and regional languages. We have participants from all over India. There are a selected contestants by respected judges with a period of time 5 to 6:30 p.m. Today only. We will give award. Do attend and relish. Important and interesting announcement. Tonight we have an All India singing competition of ISA Union with live orchestra. તાજેતરનો there are 12 judges. There are two Garba also. At the end, we will give awards. Do attend and release. All air tonight 8:30 p.m. onwards.
Himanshi?
Dr. Arvind, what is the next session on?
Ma'am, next session is on the medico-legal aspect and bioethics. Actually,
Okay.
Dr. Arun
Okay,
Mehra
okay.
will be the speaker. There are 4 speakers in that.
Yeah, but they haven't come so far. ना उनका time अब बाद में होगा ना?
5. That is from 5 to
हाँ,
6:30.
इसीलिए they aren't here. Otherwise, we could have had them first.
नहीं surely ma'am. अभी तो कुछ लग नहीं रहा है. And ये
So Himanshi, is Dr. Sandeep Devan joining us or not? Can you please find out? And there were 3 speakers in this session, right? Himanshi,
Yes, ma'am.
who was the third speaker in the session?
Dr. Syed Mohit from Aligarh.
Acha, Dr. Saeed Mohit, he's not joining? Okay, not even virtually?
No, ma'am.
Then Sandeep Devan se पूछिए, is he joining?
Yes, ma'am. Ma'am, give me a
हाँ.
few minutes.
Okay.
Hello, Pratibha ma'am. Pratibha ma'am. Hello. Hello, Dr. Pratibha ma'am. Ma'am, can you hear me? Hello, ma'am. Nikki, ma'am.
Yes, Himanshi.
Ma'am, we are not able to join speaker.
So I think we should, close the session here. Yeah?
Yeah, ma'am.
Because we have already waited for about 25 minutes. Huh?
Yes, ma'am.
Yeah. I think we can close the session. Thank you very much, everybody. And you can go on with your next program.
Thank you, ma'am.
I just have 5 minutes.
Dr. Sadhna from next session is here.
Okay.
In the hall edge.
Great.
Would the organizer like her to now go ahead or wait?
Next session is of medical legal. This trauma is going on. This is trauma session going on. After that, it is medical legal.
Yeah. Dr. Nikki, I think we call it a day and call the session off.
Yes. We waited enough, I think.
Okay.
So we'll close the session and we leave it to the organizers how to manage further.
Okay.
And what they want to do in this half an hour that is left of this session.
Okay.
Okay.
हाँ जी हाँ.
ठीक है जी.
Okay.
Okay. Have a good evening, everyone.
Yeah.
Thank you so much.
Okay. Thank you all.
Good evening, ma'am. Good evening, all. Thank you.
Technical team, Himanshi.
Yes, ma'am.
Himanshi, I'm Dr. Arvind from Delhi. Actually, I am the chairperson for next session. Is it on medical, legal, and bioethics actually?
Yes, sir.
We are having 4 presentations in that. We will start at 5 o'clock sharp. We are having recorded already, or they will be live.
Sorry, sir. I can't hear your voice.
Hello.
Wait, 2 minutes, sir. Hello, sir. Can you hear me?
Hello, Himanshi.
Yes, sir.
I just want to know the next 4 speakers, they have recorded their speeches or their talks, or it will be live?
Sir, we receive only 1 or 2 videos.
Okay. So you have the video of Dr. Arun Mehra?
I think we have.
Okay, we will start at 5 p.m. sharp. Okay.
Okay.
So I will be there. Na? It's Hall H right now.
Hello, sir.
Respected chairpersons and my dear delegates, a very good afternoon to all of you. At the outset, I must congratulate the organizers for organizing such a mega event. And I bring greetings from my university and my institution. I'll be speaking on emergency airway management. Now, emergency airway management could be outside the hospital, it could be inside the hospital. And inside the hospital could be in the emergency and accident unit, as in the resuscitation group, emergency operation theater, intensive care unit, and even in the elective operation theater as well. So what did NAP4 reveal? If you see, the most of the important, catastrophic event took place which was airway related, and 50 to 60 times more major events in emergency department and in intensive care unit, and 61% mortality as compared to 14% mortality in anesthesia was in the ICU, emergency department and ICU. And out of 38 deaths, 18 deaths were in the ICU, which were all preventable. Now, this was primarily because of poor airway assessment, failure to have backup plan, and ultimately having a poor outcome. And this was again because of unable to use awake fiber optic intubation when it was needed, because there was no expertise there available. And in difficult intubation, multiple attempts was taken, which really further deteriorated the airway conditions and ultimately led to a catastrophic event. And most importantly, one of the most important backup plan are supraglottics, which was inappropriately used. So there was a review article, Approach to an Advanced Emergency Airway Management in Adults, where RSI, rapid sequence intubation, was the most frequent used and successful means of intubating trachea. And it was employed in around 80 to 85% of all patients who required intubation in emergency departments. And the rest of the people were primarily the patients who had cardiac arrest, where they went for crash intubation. And most events in the emergency, most complications were again because of rapid sequence intubation. And rapid sequence outside the operation theater also, they said that it needs the equal equipment and equally supporting staff, which is needed in operation theater as well. And at the same time, it also includes that capnography was one of the most important monitor, which should be used after intubation. So there was in the Ocean study, what it revealed was that out of 34,303 patients, which was a single center study, and around 28% were critically ill non-traumatic patients who received out of hospital airway management. And out of these, 10.7% patients, the airway was inserted, which was outside the hospital. They needed to be changed in the resuscitation room because of esophageal intubation, and at the same time because they were intubated with, they were put a laryngeal tube which would need to be intubated, replaced by the definitive airway. And 25.6% of these patients out of hospital, they needed immediately intubation inside the resuscitation room. And in the first pass, and the overall success rate was 71% and 100% respectively. And they went for multiple attempts were needed in 29% patient. And most importantly, the complication rate was around 43%, which was alarming. So safe airway management, we need an airway evaluation, identify the difficult airway, assess the other clinical factors which are there, especially the morbid status of this patient, selection of likely most successful plan of action, at the same time have an alternative plan or a backup plan. What are the problems we have in emergency airway management? These patients are full stomach, their altered level of consciousness, deteriorating the airway, they have a hemodynamically unstable or cardiorespiratory physiology is not optimal, and abnormal distorted upper airway anatomy, no time for pre-assessment or make a plan according to the assessment, and they are supposed to be considered always a difficult airway or anticipated difficult airway, and these patients are being dealt by at times an inexperienced assistant, and you have at times inadequate and inappropriate equipment available at the time of intubation. So the fallout of this, the complications which see is if you see that these patients have difficult intubation or because of multiple attempts, around 20% of these patients, and severe hypoxia, around 26% patients, hypotension in 25% patients, and at the same time, esophageal intubation, 11% patients, aspiration in 6%, almost 6% patients, and even cardiac arrest patient, is seen in around 3% of patients. These are the complications because of the factors which we see, multifactorial reasons. Now, the three pillars of airway management in these patients would be that we need to maintain the patient's airway or airflow integrity, patency of the airway, protection of the airway, protection of the airway from aspiration, and assurance of oxygenation and ventilation to these patients. So to assess the patency of these patients, naturally we can have clinical findings that patients having inspiratory stridor, patients has drooling, hoarseness of voice, and paradoxical chest movement and tracheal tug. These are the findings which we can have clinical findings. Protection, obviously we need to see whether the patient's having airway, blood in the airway, or there is a pus in the upper airway, or persistent patient is vomiting, and there is loss of airway reflexes. Now, these are the conditions when we need to be very, very cautious and maintain the patient's airway. Now, the oxygenation and ventilation, again, we see that the patient is central cyanosis. Now, these are all clinical findings, obtundation of the and diaphoresis, and most importantly, rapid shallow respirations along with accessory muscles are walking, and retractions of the abdomen and abdominal paradoxical respiration. Now, these are the conditions which can clinically guide you or clinically warn you to go for an airway maintenance. And obviously, the indications are accordingly that we need to have patency for relief of that. We need to have relief of obstruction, protection from aspiration, prevention from hypoxia and hypercapnic respiratory failure, pulmonary access for pulmonary toilet, and at the same time, patients are in shock. These are the indications where we need to have, that is the 5 Ps where we need to have a definitive airway. Now, what are the issues in airway assessment in these patients? Now, we know that these patients have a very high incidence of, predicted difficult airway, around 20% of these patients, which is contrary to the other operative room difficult airway. And even if they seem to have a normal airway, which can become difficult because of resuscitation with fluids, that's especially in burn patients, and capillary leak, along with long non-invasive ventilation can further cause a difficult airway. Now, physiological difficulty take precedence over the anatomy. That means the patient can have, in addition to the anatomical difficulty, physiological difficulty as well, which is because the patient is hemodynamically unstable because it's hypoxemic, and often to assess have a full assessment of airway is impractical, and because the patients are obtunded, uncooperative, and hypoxemic patients. So naturally, time is very crucial, and we don't have that much time to go for an airway assessment and have a backup plan. At times we are in a hurry. So that is something which is warning. We should be alarmed, and we should not be in a hurry in such situations. So at the same time, even if you have gone for a thorough assessment, they have a low positive and predictive and specificity value. So a prediction of difficult airway has 4 dimensions. That is the difficulty of bag mask ventilation, difficulty in tracheal intubation, difficulty in supraglottic airway devices insertion, and difficulty in surgical airway. These are all the mnemonics which we have: Mons, Lemon, SMART, and RODS. And that is available in any books where you can find it out. Now, this is one method of predicting difficulty, especially in emergency situations where Makocha scoring system where there are 12 points, and Malampati 3 to 4 gives you 5 points. Obstructive sleep apnea, their cervical spine movement limited. Now, these are more practical than the other method of assessment. And if the patient has a Makocha score of more than 2, you should always keep in mind, you should always have a senior consultant along with you who will be able to, because they become anticipated difficult airway. And the sensitivity of this 73%, which is quite high. So prediction of the physiological difficult airway in emergencies, again, as we said, physiological reserve becomes very less, especially at the time of, in these patients, and at the time of intubation, they are further deteriorated and they can cause catastrophic events. So naturally, we need to always distinguish between a difficult anatomical difficulty and a physiological difficulty, because when we see that if it is an anatomical difficulty, obviously we know that the gold standard is awake intubation. But in those situations where the patients are having physiological difficulty as well, then awake intubation could be catastrophic and further deteriorate the conditions. So naturally, the commonest physiological difficulties are hypoxemic and hypotension, which with a shock index of 0.9 increases the risk of cardiac arrest around fourfold. So now we have to be very cautious and identify physiological difficulty as well. So what are the techniques which we have to maintain an airway in these patients? Primarily, it is the basic airway management, where we have just the supplemental of oxygen along with head to chin lift, along with the Goodell's airway and the nasopharyngeal airway. I will not be dealing in detail with that but I will be talking more on advanced techniques. So here the techniques could be bag mask ventilation, endotracheal intubation, because you need to have a definitive airway, otherwise there's always a chance of aspiration. So rapid sequence intubation is the technique of choice. It could be delayed sequence intubation at times because of the cooperativeness of the patient, and alternative techniques could be insertion of supraglottic airway device and surgical airway. Now, always be prepared that these patients could have a difficult airway even after going for an assessment. So backup plan along a difficult airway cart should always be available during intubation. And since these patients are critically ill and always predicted difficult way, always you have to be, you should always anticipate difficult, and then you should always have more than one operator. So you should always have more than 2 operators, which reduces the incidence of complications during intubation, and the risk is reduced by fourfold. And even when we talk about COVID, we need to have 4 airway operator. That is more important in COVID patients. Now, what is the rationale of using volume expansion before intubation? Now, this is something which is very important, because we see that right after, of course, we don't have any evidence which gives you, concrete evidence on that. But it is very logical to think that if you give some amount of fluid before you go for inducing on these patients, probably it will prevent the hypovolemic shock which the patient can sustain. But you have to be very cautious that the patient should not have a cardiogenic pulmonary edema. And at the same time, because you're, after inducing these patients, you're blocking the sympathetic response that can further exaggerate the hemodynamic responses. And the mechanical ventilation right after intubation can further cause a fall in the cardiac output. Now, these are the conditions where probably it becomes justified to give some amount of fluid before you start these patients. And you can also start vasopressors if need be in these patients. Now, pre-oxygenation is very important, and there are a lot of studies which have been documented in pre-oxygenation. Probably the normal pre-oxygenation which we do is not very effective in these patients. So it's always, and because they have the FRC is reduced, reservoir is very less, and they can go for rapid desaturation right after inducing this patient. So naturally, 3-minute non-invasive positive pressure ventilation could be an appropriate situation in this patient, especially at a rate of 5 to 15 centimeter of PEEP, inspiratory pressure with a PEEP of 5 centimeter. And you can also go for high flow nasal cannula oxygenation at the rate of 70 liters per minute. Actually, these maneuvers, they reduce the sound fraction, and they cause also recruitment of the collapsed alveoli. So naturally, what happens is your apnea time increases. And we know that apneic ventricular oxygenation is primarily because only 20 ml of carbon dioxide is being excreted, whereas around more than that oxygen is being diffused. So naturally, there's a negative pressure which is created inside the alveoli, which causes the air from the mouth or atmosphere to rush in, or if you're giving a high flow oxygen, which is around 70 liters per minute, and that increases the pressure about 100 millimeter mercury, and the patient can be maintained for at least more than 100 minutes in this patient. So apnea times primarily increases because the reservoir increases. Even you can go for Thrive, where which creates a CPAP of around 7 centimeter of water in these patients. So the technique of choice is always a rapid sequence intubation, where modified rapid sequence intubation with a cricoid pressure could be an appropriate technique of choice in emergency situations. But certain group of patients cannot be adequately pre-oxygenated with this, so they can lead to desaturation. So these patients always, as we said, that we need to pre-oxygenate this patient. Now, delayed sequence intubation is a condition where certain patients who are uncooperative. Now, these patients needs to be sedated with some amount of ketamine, which can make them patients bit cooperative, and then you can go for the intubation in these patients. Now, they are also known as ketamine sequence intubation at times. Now, what are the inducing agents which we have? There are a lot of studies which say that propofol could be detrimental in these patients, but the studies which have there are studies which say that ketamine and etomidate could be a good choice in these patients, but propofol is also not a bad choice in these patients, and with a better outcome in critically ill patients. So ketamine obviously is and etomidate is a good choice, but propofol at times is also a very good choice. But there are a lot of controversies in this, and especially etomidate, which has been in the limelight for saying that it's not a good choice at times. So there are other review articles which says that especially in hemodynamically unstable patients, ketamine is a very good choice in these patients. And these are especially if you see the KEEP-PACE trial, where they said ketamine and propofol, which is a combination of ketofol, could be a good choice in these patients. So you can give a combination of ketamine along with propofol. So inducing agents could be a good choice in these patients. Now, cricoid pressure, what on cricoid pressure? Now, there are a lot of studies, there were a lot of controversies in cricoid pressure, and the bottom line is that if the patient is, because we know that because of cricoid pressure, the laryngeal view is obtunded, the patients, whether the patient really has aspiration, it is doubtful, but it causes even the insertion of supraglottic airway device, and visualization of larynx becomes difficult. So removal of cricoid pressure will be an immediate consideration if there is any difficulty either intubating or ventilating this patient. So naturally, cricoid pressure is advisable, but at the same time, you can remove it or partially release it when the patient has difficulty in visualization of the vocal cord. A role of video laryngoscope, it's a lot of studies are there where they say that video laryngoscopes are good in an elective situation and in intensive care unit also, but they're limited data, and especially in critically in patients in emergency department, emergency airway management. So, but what we have seen that it really improved the ease of visualization, ease of intubation, and reduce the airway trauma and reduced failures. So this is the first pass first pass with video laryngoscope is always better as far as the study says, and especially in Macocha score 3, it is always advisable to have a video laryngoscope guided intubation, but you should always use a Macintosh blade. There are, as I said, there are a lot of controversies on video laryngoscope as well, especially there are systematic, review and meta-analysis on randomized control trial, and the conclusion is that does not improve intubation outcomes in emergency and in critical ill patients. But again, there are certain studies which say that obviously it does good. So use of a supraglottic airway device in an emergency situation. So naturally, the first generation is always not used because we know that there are a lot of chances of aspiration. So first generation, at the same time, ventilation becomes difficult. So second generation is the choice and recommended, especially when there is a chance of risk of aspiration. It should be readily available, especially when you are managing an emergency airway. But you should not use more than 2 attempts, especially only if the patient is more than 95% saturated. And if you see that you're giving cricoid pressure at the time of insertion, it is always advisable that you remove the cricoid pressure, because otherwise the lodgement of the placement of the supraglottic airway device becomes difficult. And always replace this with a definitive airway, especially underguided with a bronchoscopic view. So extraglottic devices, as I said, there are studies. They can be primary airway devices, such as during cardiopulmonary arrest and resuscitation, or even rescue devices or failed airways. And iGel is one device. And again, there are other supraglottic airway devices which are very much in use in emergency airway. So the role of surgical airway in emergency, obviously, especially what NAP4 has revealed, that high failure rate, especially in a situations where we need a surgical airway. So it is always advisable to have a very good practice and practice and practice. And this high failure, it is primarily because of you are not being able to identify the cricothyroid membrane at the time of emergency. So it is always advisable that you preempt and then you always identify before you go for a intubation, especially when you think that these patients could land up into difficult airway. And USG could be a very good guide, a method of identifying. The best technique is the scalpel bougie technique, tube technique, and always you need to maintain a definitive airway right after you are overcoming with the crisis. So tube conformation, is it must? Yes, it is must. What the data has revealed, that you have to use, you must always confirm your placement of tube after you intubate with the capnograph, because at times what NAP4 has revealed, that because you could not identify the patients were esophageally intubated, so the patients succumbed to hypoxia. So and auscultation and observation of chest movement is not a very good sign in identifying. So naturally, you must know that what is a normal tracing and what is an abnormal tracing. So what is the importance of intubation bundle? JBR has come up with this intubation bundle where they gave around 10 points, 10 parameters, and which is around 4 parameters for pre-intubation, 2 parameters for per intubation, and 6 and another 6 parameters for post-intubation. Actually, these 2 parameters, the recruitment and maintenance of intubation, has been brought by Dijong, whereas the rest 10 parameters have been brought by JBR, which they said that it increases it reduces the chance of complication and improves the intubation rate. Along with it, it prevents a lot of complication. So that is what the 10-point rule says. Now, tracheal intubation, a bit on COVID, 2 slides on COVID. I'd like to say that it needs to be in rapid but not hurried. It has to be elective intubation, though emergency, COVID is an emergency technique. Number of attempts should be reduced as much as possible. And we should have a well-designed guideline and a checklist while we are intubating these patients. And what we have seen, that these are, we know that first pass success rate in critical ill patients less than 80%, and tracheal intubation more than 2 attempts are always catastrophic. And operator should be most experienced person in the team, and you can always have an airway response team who's going to intubate this patient. But always keep in mind that the most experienced person should be the airway operator. So what about the aerosol box? A lot of controversies are there, but it does not do any good, but it in fact it causes a lot of complications and prolongs the intubation time. A bit of influence on human factor. Always remember that there should be an error. There might be an error of judgment. So there should not be any blaming, naming, and shaming in these patients. You should always fix up the responsibility, and you should have a clear idea about everyone's role. And designation is not at all important. What is important is should accept their mistakes, and training on simulators is always a better choice, especially to overcome these patients problems. So what is the whenever you are in crisis, always go for an established guidelines. In IDA we have the anticipated difficult airway in adult patients and intubation in critically ill patients in intensive care unit. You always remember that landing is an equally important as taking off. So naturally, what NAP4 has found out that the mortality rate is around more than 5%, especially when you are extubating these patients, and around 13% more complicated, you get complications you see. But keep in mind that extubation is always in a controlled environment. So fulfill all the criteria which has led to an intubation, and especially when you are in doubt, always extubate these patients in airway under the cover of an airway exchange catheter. So to summarize and recommend, emergency airway management is always a different ball game with typical challenges related to airway management, and especially always remember that they are anticipated difficult intubation, difficult mask ventilation, and difficult supraglottic airway device along with surgical airway. So physiological assessment should be always take precedence of an anatomical assessment, and pre-oxygenation and hemodynamic stability should always be done before you intubate this patient. Especially most experienced person should always intubate these patients. And video laryngoscope is an additional aid where second generation supraglottic airway device could be an alternate backup plan. And surgical airway, if you need to resort, you should go in critically in crisis situations. And COVID really has made us learn a lot of things. Follow the established guidelines whenever in crisis. So thank you so much and wish you all the best.
Thank you, sir. Now we are starting our next session. I would like to invite Chairperson Dr. Arvind Arya, Dr. Praveen Kumar Devapalli, Dr. Jitendra Patel for the topic Medical Legal and Bioethics.
Good afternoon, all. Thank you, Chair Organization. Hello, Himanshi.
Yes, sir.
It's audible.
Yes, Dr. Arvind, we can hear you. We can hear you.
Okay. Okay. Good afternoon, Dr. Arun Mehra. Actually, we are having this session. It's a great session. We are having so much concerns about the biomedical ethics and bioethics and medical legal aspect of the anesthesia and critical care. These we are having very difficult timings for last 2 years. We have faced the different phases of the COVID, and we have seen this many issues coming to us. So we are having other chairpersons with me. Manshi?
Yes, sir.
So I'm inviting first Dr. Arun Mehra, and he will be speaking on the medical legal aspect in COVID and post-COVID surgical patients. Dr. Arun Mehra. Can we have the slides of Dr. Arun Mehra, please?
Yes, sir.
Mansi, do we have the presentation of Dr. Arun Mehra right now?
Yes, sir. Please give us 2 minutes, sir.
Hello, friends. It's a pleasure to be here, and I must thank the organizers for giving me the chance to speak on this very new topic and very important topic in today's context, and a topic that is very important to me. because I am very passionate about medical ethics. So I'll be speaking to you today about medical legal aspects in COVID and post-COVID surgical patients. Basically, what are the legal issues and the ethical issues involved in patients who have COVID and yet need surgery. I'd first of all like to make clear that I'm not going to go into all of the standard stuff that we have all studied during the MBBS curriculum about consent and all those things which are taught to us regarding the MCI, or rather the NMC rules on ethics, professional ethics and professional behavior. We all know that. My emphasis here is on the special issues related to a pandemic. We all know we have been through a very unusual situation during the last 1.5 years. Surgeries had ground to a halt for a long time, except for emergency surgeries. What all are we to consider in this? What are the legal and ethical principles involved? So I'll start with just a very brief mention about the principles of bioethics as enunciated in the Universal Declaration of Bioethics and Human Rights, which is again not to be confused with the Universal Declaration of Human Rights 1948. What I'm talking about is the Universal Declaration on Bioethics and Human Rights 2005. Now, the 4 basic principles involved in bioethics or in medical ethics are autonomy, beneficence, non-maleficence, justice. You all know the meanings of these words. I'm not going to go into them. And of course, they are related with similar issues like human dignity. Autonomy is a part of human dignity. Consent is also a part of autonomy. Privacy and confidentiality. These are very important. Non-discrimination, non-stigmatization. We must remember that none of the rules have changed during the pandemic. What has really changed is the context in which they are applied now. Until we get back to normal times, hopefully we are returning to better times now, these changes will persist. The only thing that really changed during the pandemic was that the Epidemic Act, which is a very old act, was activated during the different waves of the pandemic, and the other laws and ethics remained unchanged as they always had been, but we have to look at the context now. Now, what were some of the new challenges in COVID times? Before we go to the legal and ethical aspects, I'll just like to make a brief mention of this. For surgery and for anesthesia, the systems were overwhelmed. In fact, the systems in all ways were overwhelmed, and especially anesthesiologists were under a lot of stress because they had to look after OTs as well as ICUs and critical care. The system as a whole was overwhelmed. So let's not just say for anesthesia and for surgery. And we had a very limited understanding of this disease, especially in the initial stages. Even now, we cannot say we have fully understood it, but our knowledge about it is definitely much better than what it was, say, in the March of 2020 or during the first wave. Now, one very important issue was the care needs of the most vulnerable of the population. The vulnerable group is again covered under bioethics, and it's a very important thing. Then there were issues about which tests were the most useful and thus justified. This was related to distributive justice and to the judicious use of very limited resources, because when the system gets overwhelmed, the resources just don't match the requirements. And as I mentioned, distributive justice. So these were related to anesthesia and surgery. General issues were longer working hours and thus corresponding increased exposure to the virus for doctors and other healthcare workers, with the risk of illness and even death. And of course, fatigue and moral distress. Moral distress means where you enter into a situation which hurts your psyche. For example, you see patients dying in front of you. You have 2 patients, you have only 1 ventilator, both need it. Now, you may take a decision based on some criteria which have been handed down to you, but you will spend years, maybe the rest of your life, in guilt. Could you have done something better? And then, of course, costs have spiraled out of control. And then the legal and ethical issues which I'm focusing on have to do with potential legal and professional risks also. Unfortunately, there is always a risk that we will have litigation against doctors because people will start making claims once things return to normal. Now, how to choose which surgeries? There is no clear-cut way of choosing. What we must remember is that legally, you should be able to justify what you are doing, and ethically also you should be able to justify it, because it depends on the circumstances in each case. You have to reach a decision based on merit. Now, emergency surgeries, yes, first of all, we must remember that elective surgeries were and almost entirely postponed. They had come to a virtual standstill during the first wave and again during the second wave. But there are situations where you had to do certain kinds of either emergency surgeries or essential surgeries. Essential surgeries could be like cancer surgeries, coronary artery bypass surgery, and such things. Now, when are you legally justified? When are you ethically justified in doing these? This requires a lot of consideration. Indications for emergency surgery remain the same during the pandemic as before, but a balance between timely treatment of the patient. What I want to really emphasize is that there is no real difference between the earlier situation, normal times, but as far as going ahead with the surgeries is concerned, when you talk of emergency surgeries and essential surgeries like cancer surgeries, for example. But the added angle here is protection of the patient, protection of healthcare workers, protection of other patients from this patient. I said the protection of the patient also because this patient who is COVID positive is more vulnerable. There are greater chances of developing different kinds of reactions and things. Bleeding and all kinds of things can take place, coagulation, all kinds of problems can take place. Even cardiac problems can take place. We know that this virus has behaved in a very strange way, and it's virtually impossible to know beforehand how it will behave in any particular patient. So surgery should be taken up only if it's an emergency surgery or an essential surgery. And how do you define an essential surgery? That which cannot, I'll not define emergency, you all know that, but other essential surgeries are those that cannot be reasonably delayed more than 8 weeks. That is the definition we have been taking, without significant harm to the patient or progression of the disease or of the disability. In this, there are various kinds of things here, even liver transplants and things. Cancer is one of the best known among these. Now, it's not always easy to determine what these are. Though it may seem easy, deciding is difficult even in simple conditions. And the example I have given here is, for example, you have a patient who has polylithiasis. Now, there can be repeated acute attacks of cholecystitis. It can lead to obstructive jaundice, cholangitis, and even pancreatitis. But how do you know when the patient presents to you for the first time what direction this will take? It's impossible to foretell. This makes it very difficult to really determine whether it's an essential surgery or not. There are areas where it is more clear-cut. Again, I'll go back to the example I'm giving again and again about surgeries involving malignancies. Hence, a clear cut of demarcation of essential, semi-essential, and not essential is not always possible. And as I mentioned here, each case has to be judged on its own merit. Now, in the case of a COVID positive patient, if the surgery is essential, measures must be taken to reduce the risk to the staff, the complications to the patient, and as I said, the complications to other patients also, which means basically isolation of this patient. Review of how do you review, or how do you, rather I'll use the word decide. At times it can be very confusing, so a review committee can be set up in the hospital. Not that people are so free at this time, everybody is overstretched, but this becomes a very important aspect to take decisions which are legally and ethically justifiable, although people are stretched for time. So it can be, a committee can be set up to make policies and take real-time decisions and initiate and communicate all planning for such patients. Basically, what we are trying to say here is that a committee comprising experts, doctors from various specialities, of course the surgeons and the anesthesiologists, but other doctors also who are involved in the care, and probably legal representatives and financial aspect and so many other things have to be considered. All this has to be taken into account in order to excuse me, in order to decide which surgery to proceed with, because later on you might find it hard to justify going ahead or not going ahead. So it becomes a case of shared responsibility also. And when you have various kinds of inputs, it's always better because you've considered it from legal angles and from social angles and from so many other angles. Now, consent in a COVID positive patient. Conventionally informed consent, you all know what an informed consent is. You have to explain what are the risks, what are the benefits, what is the likely outcome, and very importantly, what are the alternative options. And you have to compare the risks and benefits of the different options also. And one thing which people very often miss is the risk of not undergoing any treatment at all. But in a COVID patient, you have, in your consent, you have to take the additional issues of basically the COVID-related complications that can arise to the patient himself. And of course, you have to take consent for those. And at the beginning of the pandemic, we were not even aware of many of these. So if the patient can sign it, if the patient is conscious, then he should get it done. The patient is not in a condition to sign or to understand, then of course the next of kin have to do it. Now there are some additional important points in consent in such a patient. What have I mentioned? There is a lack of complete information. I have repeated that several times. And then the changing day-to-day working of the hospital conditions also. In a COVID patient, you cannot really allow the attendants to go and meet the patient, and that will add to the psychological problems of the patients. And then there is the issue of altered outcomes because of shortage of resources, not only the patient's own pathology, but shortage of resources also, which is a very unfortunate thing, but it's a reality we have had here. Legally and ethically important protocols in COVID positive patients. First of all, preoperatively, the lab testing and the workup. If they are delayed, you all know RT-PCR has to be done, and usually it's 3 days. Some hospitals say 7 days. Whatever time you give its validity, but you may have to repeat it. Then anesthesia, surgery, and nursing checklists need to be revised for COVID patients. Optimum precautions should be taken. PPE and other precautions are all there. Intraoperatively, you have your standard time out, but here you have to take the extra precautions, and timeout has to include those. Then post-operatively, of course, you have to have a bed ready in the ICU, depending on the patient, whether you like to extubate the patient or not. And in the post-discharge period, I'd just like to mention here that monitoring here, unfortunately at times junior staff are left in the ICUs and all that. You can't afford that in this situation. Then your legal responsibility in the case of a COVID positive patient continues even after discharge. And so a proper follow-up protocol should be prepared and given in writing, and you may have to help the patient really arrange it. Now, we talk so much about the legal responsibilities of doctors, but let's remember that the patient too has legal responsibilities, should provide us correct information, should seek information from the doctor, follow all the instructions, accept the results. Because in India, there is a tendency where people start blaming doctors if the results are not up to their expectations. Then we come to additional legal issues in COVID patients undergoing surgery. Non-COVID patients have to be protected. So you have to have separate designated COVID OTs and pathways for segregation personnel. That means your healthcare workers have to be protected. PPE, decontamination, hand hygiene, biomedical waste handling and all that. And then your staff has to be screened regularly and disinfection protocols have to be there. All these are legal requirements. So basically, what conclusions can we draw? The guiding principles are our legal and ethical duty is to provide timely surgical care in urgent and emergent surgeries. Emergent surgeries and urgent surgeries, or we can just say emergency and essential surgery, while optimizing the resources and preserving the health of the caregivers. Mind you, legally you are responsible for the health of your staff. And surgery should be performed. If delaying surgery is likely to prolong hospital stay, I've already touched upon that. Surgical patients who have undergone medical management, but it has failed, there you are legally fully justified in going for surgery. All this has to be documented. I did not mention documentation throughout this presentation, but yes, I'll again emphasize communication, communication, communication. And regarding documentation, please remember 4 points which are legally very important and which will save you in any situation. Communication, documentation, then communication of documentation. You inform the patient or the attendants that you have written it all down, and then documentation of communication. This should be a major takeaway from what I'm speaking right now. And then, of course, the decisions have to be made in the context of available institutional resources. So legally speaking, there are many angles, but remember, there is no substitute for common sense. And if you take your actions according to what is in the best interest of the patient and you have documented it correctly, then nobody can really touch you. Unfortunately, some patients might harass you, but you're at no real legal risk of conviction or anything. Basically, what you have to do should be justifiable. And yes, that depends largely on common sense and on your experience. And of course, you have to follow whatever is given in the standard textbooks and in the standard practice. So there is no substitute for common sense, both medically and legally, which means that you have to take decisions on the merit of the situation. And at the same time, you also have to document everything. And I'll end with a quote which I think we have all read. I don't remember, was it in Hutchison or was it in Bailey? Somewhere we've read it many times. A wise physician of COVID patients. And if whatever you do is done in good faith, and you have documented why you are doing it, and you have obtained consent, then you are legally safe. Now, as I said, I have basically dealt here with the special issues that have come up, the legal and ethical issues that have come up with COVID, rather than going on and on about the legal and ethical issues which you already know about. So I hope I have been able to re-emphasize what you already know about it, so that you can remember that this is what is legally and ethically required in a surgical patient who is COVID positive. Thank you so much. I hand it back now.
Thank you, Dr. Arun Mehra. You have nicely presented about the medical legal aspect and bioethics we have seen during the period of COVID actually, and we have seen how much the problems during taking the consent when the attendants were not available. We have seen how the distribution of the medical equipments to be given who is need and required the most. These are the various some issues we have discussed, and you have also discussed this very beautifully. May I have another chairperson along with me, Manshi? Himanshi, technical team.
Yes, sir.
Can we have an introduction of the next speaker, please? Dr. Sadhama. The topic is on how to prevent medication errors. Do we have some introductory slide for the speaker? Do we have some introductory?
medical legal importance. A small mistake made by us can cost as well as us as well as the patient. So one has to be very cautious in using any drug. My topic for presentation is how to prevent medication error. Definition. Any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of healthcare professional, patient or consumer. It may occur at any time from the prescription to the consumption of the medicines by the patient. We have to use the 5R rule. Right drug, right route, right time, right dose, and the right patient. Now, coming to the classification of medication errors, it could be an omission error which occurs when a prescribed dose is not administered as ordered. A wrong dose error occurs when a dose is either above or below the correct dose. An extra dose error can occur when a patient receives more doses than were actually prescribed by the prescriber. A wrong dosage form error occurs when the dose is not administered to the patient by the route intended by the prescriber, and a wrong time error occurs when the drug is not being given at the correct time. Now, coming to the types of errors, it could be a prescribing error, dispensing error, documentation error, and the dispensing error, which could be 39%, 38%, 12%, and 11%. The prescribing errors include incorrect drug selection for patients, errors in quantity and indication, prescribing contraindicated drug methods for error reduction, electronic prescribing reduces errors due to illegible handwriting, computerized physician order entry system eliminates need to transcription orders by nursing staff. Can anybody read this? This is a prescribing error which can occur, and I have not been able to read. I don't think anybody is able to read all this. On the contrary, one can go through the prescribed format on a computerized manner. One can read it very well, when to start the dose, how much doses are to be given, what is the exact dose, what is the route of administration. Coming to the dispensing error, as you can see, if you cannot read, there could always be a dispensing error, as nobody is able to read. How can the chemist be able to do his job? He won't be able to read, he will not be able to give the prescribed drug as well. Methods for error reduction could be ensuring a safe dispensing procedure, separating drugs with similar name or appearance, unit dose medication dispensing, automated medication dispensing system, and a barcode medication for dispensing and administration. Now we have from this chart, you can make out they are in various colors. You can make out the blue one, the drug which has been given do not cause any harm. That is in category A. The circumstances or events that have the capacity to cause error. The orange one is there is error, but there is no harm. Category B, an error occurred, but the error did not reach the patient. An error of omission does reach the patient. Category C, an error occurred that reached the patient but did not cause patient any harm. Category D is an error occurred that reached the patient and required monitoring to confirm that it resulted in no harm to the patient and or required intervention to prescribe harm, preclude the harm. The yellow one has the drug reached to the patient, there is an error of medication and there is a harm to the patient as well. Category E, an error occurred that may have contributed to or resulted in temporary harm to the patient and required intervention. Category F, an error occurred that may have contributed to or resulted in temporary harm to the patient and required initial or prolonged hospitalization. Category G, an error occurred that may have contributed to or resulted in permanent patient harm. Category H, an error occurred that required intervention necessary to sustain life. Now the green one is there is an error and there is a death of the patient. Category I, an error occurred that may have contributed to the contributed to or resulted in the death of patient. What are the consequences of drug error? Death is uncommon, but what happens if atracurium is given instead of midazolam? Cefuroxime is given instead of thiopentone. Metoclopramide is given instead of succinylcholine. Bupivacaine is given intravenously instead of epidurally. Fentanyl is given intrathecally instead of intravenously. And loss of expected effect and possible physical or psychological harm to the patient. Now coming to the administration error. It includes discrepancy between the drug received by patient and the drug therapy intended by the prescriber. Methods of error reduction, checking patient's identity, ensuring dosage calculations are cross-checked independently by another healthcare professional before drug is administered, ensuring medication given at correct time, minimizing the interruptions during drug rounds. Look alike, sound alike. Existence of confusing drug names is one of the most common causes of medication errors. Contributing factors include illegible handwriting, incomplete knowledge of drug names, newly available products, similar packaging or labeling, similar strength dosage forms, frequency of administration. Strategies to prevent errors by LAS drugs. Use of novel dosage, delivery to distinguished products with similar names, print generic and brand names on unit dose packaging when possible, use of tall man lettering to emphasize the spelling of drug names in medication storage areas. Tall man lettering uses a combination of lower and uppercase letters to highlight the differences between look-alike, sound-alike medicine names like amlodipine or amlodipine, comedine, covacil, ancutine, oroxin, and like this, Essilor or Velcade. Another way of preventing the drug errors could be by color coding of the ampules or giving a particular color to a particular group of drugs. Like we have the muscle agents in red, pink color, or the muscle relaxants in red, and induction agents in yellow, and so many other things like opioids in blue and the antiphylologs or anticholinergic drugs in green. This is another way of doing the things, but this may again cause, because most of them are ambulatory bottles, but still there is the same drug which is in different color coding by different companies. So either we have to go with the generic names or we have to see the color coding of the drugs. Like you can see, midazolam and heparin are in the same color labels. Again, midazolam in two different colors, rocuronium in two different colors, and heparin in two different colors. So this can all cause the drug error, because if you go by color coding, again you may be mistaken. If you go by labeling, you may be mistaken for drug administration. Coming to the steps to prevent medication errors, the targeted physician education on optimal medication use, inclusion of clinical pharmacists in decision-making activities, computerized order entry by prescriber and medication checking, standardized processes and equipment, avoid use of unknown abbreviations and symbols, double-check patients having allergies before prescribing. Preparing the medicine in well-lighted rooms, check the expiry date of the drug before administration, medication reconciliation, standardized ordering and administration, training, education, and organizational intervention. The six-step approach by WHO for good prescribing: evaluate and clearly define patient's problem, specify therapeutic objectives, select appropriate drug therapy, initiate therapy with appropriate details, give information, instructions, and details, and evaluate therapy regularly. Avoiding medical errors. Take your time Don't allow yourself to be rushed. Concentrate on what you are doing. Avoid distractions. Work with one student at a time. Check the identity of the student and the medication 3 times before administering it. Lock the medication immediately. Before going to the hierarchy of risk reduction strategies, I would like to see when you are logging the medication given, you should simultaneously, if there is a medication error occurs or any adverse reaction of the medicine occurs, you should immediately register it with the pharmacovigilance department. The hierarchy of risk reduction strategies are high leverage strategies, that is drawing out the hazards. Medium leverage strategies need periodic updating and reinforcement, and low leverage strategies aim to prevent human performance. There is system reliability and there is reliability and there is human reliability. In system reliability, higher leverage are forcing functions, barriers and safe automation and computerization. They are most effective, hardest to implement. Medium leverage, standardization protocols, redundancies, warnings, alerts, reminders, and checklists. Low leverages are rules and policies, educational programs, available information, suggestions to be more careful, least effective, easiest to implement. Coming to the preventing medication errors, what are the key strategies for all these things? What are we studying all the time that you should prevent this, you should do this, you should do this? We have to have a standardized preparation and concentrations of the drugs and infusions. Avoid boxes and ampoules of different drugs which look alike. Label the syringes. Test care with predisposing factors. Organization and tidiness of workspaces, human factors such as fatigue and haste, check drugs during preparation and before administration with 2 people, high-tech solutions, barcode systems and computerized prescribing should be there. The recommendations for preventing the drug errors are tailor your prescribing for each patient, generate names wherever appropriate, learn and practice through thorough medication history taking, know which medications are high risk and take precautions, be very familiar with the medication you prescribe and or dispense, use memory aids, remember the 5 R's when prescribing and administering, communicate clearly, develop checking habits, encourage patients to be actively involved in the process, report and learn from medication errors. Thank you for your patient listening, and again I thank the organizers for giving me this opportunity. Thank you so much.
So this was a very beautiful presentations of the medication errors. We have seen the problems because of the look alike, sound alike drugs. We have seen the complications if humans have given atracurium in place of the atropine. Voveron has been given in the place of the vacronium and vice versa. We have seen many cases when in the intrathecally rather than giving the bupivacaine, neostigmine, and tranexamic because they are also 5 ml ampules they have been given. So see, we have seen so many errors because of them. We have seen the complications. This is a big issue, and we should make a protocol, and we should always check twice before giving the medications. So we move on to the next topic, and this topic is a very huge challenge for the anesthesiologist. It is a death on the table. If we have the cardiac arrest on the OT itself, then we can have a lot of problems. So to speak on this, next speaker is Dr. Srinivasan Valu, and he will be speaking on this topic, that is death on the table.
Good evening, all. At the outset, I thank the organizers of Isacon 2021 for giving me this opportunity. I'm going to talk on table death, the aftermath. I bring greetings from Vijayanagara Institute of Medical Sciences, Bellary. Most of us, the anesthetist, will be facing an intraoperative death during the course of our careers. And our training centers mainly on prevention, diagnosis, and management of such adverse events during perioperative period. However, when death on table does occur, our current training doesn't adequately prepare us to deal with the consequences of on-table death in our professional and personal lives. An intraoperative death can be traumatic and stressful to the entire theatre team. Death on the table can occur in between the extremes of two scenarios. On one extreme, a moribund patient undergoing life-saving surgery with an informed high or grave risk consent. Here, on-table death will be accepted without much surprise and without much adverse consequences. On the other extreme, a patient without significant comorbid conditions undergoing low-risk procedure with or without a normal informed consent. And here, the news of death will be taken with a surprise, grief, blame, violence, and with lot of medical legal consequences. Death on the table not only affects the patient life or their attenders, it also adversely affects a second victim. And second, who is second victim? Second victim of healthcare workers who becomes victimized as a result of patient-related traumatic event and experiences post-traumatic stress after a catastrophic event. And they may have multitude of both the physical and psychosocial symptoms. Second victim include initial symptoms of acute stress reaction, which might last for days to weeks and is associated with shock, tachycardia, hypertension, depressive symptoms, social withdrawal, and agitation, compounded by feelings of shame, guilt, and self-doubt. And long-term symptoms are indistinguishable from post-traumatic stress disorder. And this is associated with flashbacks, avoidance of associated situations, hyperarousal, sleep disturbances, and deterioration of individual competence and subsequent team performance, prolonged personal suffering and leaving their profession. And in extreme cases, it can result in tragic suicide. Association of Anesthetists of Great Britain and Ireland has formulated to deal with such intraoperative death catastrophes. These include first, record keeping. All entries should be made contemporaneously wherever possible, which is difficult during a critical incident to keep track of time. And it is better to delegate a team member of the theatre to keep a record of events such as medical records, anesthetic charts, and personal notes. Digital records and physical copies should be saved and produced whenever asked. Who should be the anesthetist involved during the facing of on-table death? If the primary anesthetist is a non-consultant grade clinician, then the responsible consultant should attend, and he should seek the help of a colleague to assist during the aftermath. Many anesthetists may feel their ability to deliver safe anesthesia is compromised after an intraoperative death, with feelings of guilt, anxiety, and even fatigue. And individual's response is variable, and a blanket ban on clinical activity is inappropriate. So we should assess individual needs and provide support. Breaking bad news is another extreme difficult procedure. This should be done in person, and a relative of the deceased should be asked to bring another person for emotional support. And a team approach is vital, with a senior member of the anesthesia, surgical, and nursing team responsible for the patient present during the conversation. While breaking bad news, we should ensure privacy and uninterrupted time and basic amenities. And this news has to be delivered clearly in a straightforward and honest way. We should also provide emotional support to the relative, and apologizing, starting the conversation with sorry to inform you, or sorry we could not save your relative's life, is not an admission of blame. And we should allow time for the information to be absorbed by the relative. Where facts are uncertain, speculation should be avoided. Usually shock, denial, and anger are all natural grief reactions, and we should be prepared to deal with this. All questions should be answered honestly and compassionately, with factual reassurances and time provision for further questions. Relatives may want to see the body, and we have to arrange for this in a quiet area. Second interview may be necessary, as questions often arise after time has been allowed for the news to sink in. This also should be answered openly and as compassionately as possible. Supporting the family emotionally, facilitating a bereavement space, protecting patients' dignity, and providing spiritual support are all important. Subsequently, consultant not involved in the case should take responsibility for checking the patient and equipment. Where suspicion of equipment failure or malfunction is present, or in case of an anesthesia-related death, all anesthetic equipment, drugs, syringes, and ampoules should be kept undisturbed until a formal examination can be undertaken. The patient's regular physician and the police should also be informed, and department-based support programs in the form of morbidity and mortality meeting and debriefing of adverse outcomes will be very useful. And employers should consider the psychological needs of the personnel after a traumatic event in the workplace and provide them with social and emotional support. Core elements of debriefing include description of the salient points of the experience which had an impact on how the incident unfolded. Analyze the actions and thoughts of individuals during the incident, and we should apply the learning points from the incident into practice. This helps in closing the performance gap in an individual's expertise. Critical incident stress management was devised to assist emergency medical services in the USA. The aim was to avoid the development of abnormal stress response and to identify those who may need further counseling. This includes diffusing, which is an informal group debriefing session, which is undertaken immediately after the incident. This is led by an experienced person and will often take the form of an open discussion about the event. This session decreases the tension and help individuals gain control of their emotions. It will also highlight key points for further critical incident stress briefing, which is a way of identifying those in need of further counseling. Critical incident stress debriefing is a group session done 1 to 10 days after the event, again led by a trained individual. And the aim is to facilitate early help seeking, identify those with an acute stress reaction, enable early recovery. And the session include to know the facts. The group is asked to describe what happened, what an individual's thoughts were during the incident, what emotions individuals have towards the event, and allowing the venting of thoughts and feelings. The group is also asked to report any stress symptoms during the event, in the first few days afterwards, and any continuing symptoms they may have. They should also be provided with stress reduction information. Simulation-based training for the acquisition of knowledge, skills, behaviors, and communication skills with breaking bad news to deal with the intraoperative death allows practice and prepares us. And this simulation is still in its infancy. High quality in situ stimulations, high quality in situ simulations, that is a scenario run in OT where the team actually work with a multidisciplinary theater team, all in their normal working roles, observed and debriefed in real time by theater staff of all disciplines, has reported to be useful. So few of the medical legal issues. What is negligence? Negligence is the breach of a duty caused by omission to do something which a reasonable person would do, or doing something which a prudent and reasonable person would not do. It has many manifestations. It may be active or passive negligence, collateral, comparative, concurrent, and willful or reckless negligence. In case of death occurring during the course of anesthesia and surgery, there is a usual tendency on the part of the relatives to accuse towards the doctor. So it is best to report the issue to the police so that the death believed to be caused or contributed to us by any of these procedures may be adequately investigated. Failure of empathy and communication often act as a precipitating factor for negligence suits. Hence, informed consent of the patient or the relative with particular regard to physical status of the patient and associated disabilities must be obtained and properly documented. And documentation of pre-anesthetic evaluation, assessment of the patient, and preoperative record of the events are all of vital importance and can be a tool for retrospective analysis of the information. Sometimes court often seeks expert evidence during the medical legal proceedings of untable death. Duty of the expert is to express an independent opinion rather than representing the interest of a professional colleague. Experts should consider certain issues during the medical legal proceedings. These include where the disease or injury was in an advanced stage and a heroic effort was made in the hope of saving the life of the patient, there must have been some foreseeable chance of success or even mitigation of symptoms. So we should undertake procedures only when there is hope of some success. where the death is attributed solely or partly to a disease other than for which the intervention had been carried out, there must have been a careful preoperative evaluation considering risk-benefit ratio and appropriate modification of the operating procedure taking to account of contributing disease. Issues of negligence may creep up when some occult disease contributing to death remains undetected, and a doctor of reasonable skill and competence could have diagnosed the same under similar conditions. Where death is attributed to some unusually difficult surgical procedure, as may happen inadvertently from a true accident, from some anatomical abnormality or failure of equipment, examination and advice by the concerned expert assumes utmost importance. Injury to some large blood vessel, leaving of some pack, swab, instrument in the body may directly be covered under the concept of error or incompetence. Appropriating the relative contribution between the anesthetist and the surgeon is extremely difficult. Each one is responsible for the negligent acts of oneself and not of the other. But this has some exception where one may become liable for the wrongful acts of the other when one observes or should have observed wrongful act, for example, of surgeon, and permits him to do the procedure unheeded without inviting his attention. So what are the medical legal consequences once the medical negligence is proved? It can take the form of criminal liability, monetary liability, or disciplinary action. Criminal liability can be fastened to the provisions of the IPC code 1860, which are general in nature and do not provide specifically for medical negligence. For instance, Section 304A of IPC, which deals with the death of a person by any rash or negligent act and leads to imprisonment up to 2 years, is used to deal with both the cases of accidents caused due to rash and negligent motor vehicle driving and also medical negligence leading to the death of a patient. Civil liability, that is monetary compensation, can be fastened under the general law by pursuing a remedy before appropriate civil court, consumer forums, or permanent law adalats. Disciplinary action could be in the form of imposition of penalties. Professional misconduct by medical practitioner is governed by the Indian Medical Council, that is presently National Medical Council. This is governed by IMC, Professional Conduct, Etiquette and Ethics Regulation 2002, made under IMC Act 1956. So National Medical Council and the appropriate state medical councils are empowered to take disciplinary action whereby the name of the practitioner could be removed forever or be suspended. These are the quotes from few of the judgments given after medical legal proceedings of medical negligence. An error in diagnosis or treatment is not negligence, provided proper care and skill had been exercised by the medical practitioner to the best of his ability and in good faith. A mistaken diagnosis is not a negligent diagnosis. It has been firmly established that a medical practitioner should not be held negligent simply because one of the risks inherent in an operation of that kind occurs, or because he has failed to warn the patient of every risk involved in a proposed course of treatment. In another case, the court ruled that when death of the patient occurred within the four walls of the operation theatre where the patient's relatives had no access whatsoever, the onus lies on the doctors in the operation theatre to explain the events that had happened. It is the duty of the doctors to prove or rule out the cause of death for which they are allegedly held responsible. In one case, the court observed there is an increasing tendency on part of the litigants to indulge in speculative and vexatious litigation and adventurism, which the fora seem to readily oblige. We think such a tendency need to be curbed. However, in another case, the Delhi High Court decreed that to express grievances strongly against a professional doesn't amount to defamation by any stretch of imagination. Differences of opinion on the basis of which the plaintiff alleged negligence on part of the defendants doesn't amount to defamation. Filing a case or raising a bona fide controversy regarding the treatment given doesn't constitute defamation. So, to summarize, majority of us are likely to face an intraoperative death during our career, and this can be extremely difficult to manage. Practical support in terms of guidelines, debriefing strategies, simulation education may be of considerable value. Individual and team-based support to understand and learn from the catastrophes should be a priority. And preventive strategies against allegations of medical negligence include attention to various aspects such as reasonable skill and care at each and every step by healthcare professional involved in the management of these cases, understanding the significance of informed consent and also the rights of the patient, appreciating the importance of adequate and complete documentation of all the processes involved in providing healthcare to the patient, which might be tools for the retrospective investigation of the patient. These are few of my references. Thank you for the patience here.
Thank you, Dr. Srinivas. It was a great presentation regarding if we have the cardiac arrest on the table. Actually, we have seen in so many years that there may be very different causes for the cardiac arrest on the table. They may be because of the pre-existing medical illness, maybe because of the errors we do, because of the medications, because of the equipment failures. There are some anesthetic causes and also the surgical causes. But first and foremost is to help the call for the help. Should be a duty of the anesthetist who is involved in the case should help and should call for the help of senior peoples around in the city or the nearby and the ISA. They should contact them because a help in such a scenario from both ISA and as well as IMA team can be very fruitful. And we have seen the most of the litigations which have gone to the court are because of the 3-4 things. One is when the PAC is not done in a good way. Secondly, if the consent is not proper and it is not documented, then the safety checklist is not there, and the notes, interpretive notes and death notes and summary has not been summarized. In case it has been said to the patient that cardiac has been done and then patient has to be transferred to the ICU or nearby other hospital or a tertiary care center, then the utmost care should be taken by the doctor itself to transfer the patient actually. And lastly, the important is to talk to the attendant of the patient, actually the relatives. Empathy with the patient's relative is a great way. If the anesthesiologist itself and along with the surgical team, they can have a good session with them, it solves the problems before going to the court. These are much of reviews. We can have a discussion later at the end of the fourth talk. And we have last talk in the session. And this is about the consent for the anesthesia and ICU procedures. Recent update by Dr. Pratibha. Can we have a presentations from Dr. Pratibha? Dr. Pratibha is a HOD anesthesiology in Jahangir Hospital, Pune. She is having more than 38 years of experience. She is executive committee, the member of Society of Anesthesiologists in Pune, and she is a past president of ISA Pune. She is postgraduate teacher DNB anesthesiology since June 1997. She is a LLB, so she is certified from the law also. She has a certificate from Oxford, UK for healthcare communications, and she has been a lot of honors and publications also. So over to you, Madam Dr. Mrs. Pratibha Kane for her presentation.
Good evening. I thank the organizers of Isacon Ahmedabad for this invitation to present my topic, Consent for Anesthesia and ICU Procedures, the recent updates as in the recent case law. consent is a permission. Consent in healthcare has undergone a drastic evolution. Consent was not required in the Hippocrates era. All procedures were drawn with trust and faith in the doctor's decision. In 1914, a lady called Mary had agreed to examination of a fibroid in her abdomen, but categorically did not want it removed. While under anesthesia, the surgeon removed the fibroid. There was some complication in the post-op period. She sued the hospital and she won. Judge Benjamin Cardozo deliberated that every person of adult years and sound mind has the right to determine what shall be done with his own body. A surgeon who performs an operation without his patient's consent commits an assault for which he is liable in damages. This landmark judgment has made a paradigm shift to the patient autonomy and patient rights, which are now enforceable by law. In the Indian law, there is no definition of consent except in the Indian Contract Act of 1872. Section 13 says that two or more persons are said to be in consent when they agree upon the same thing in the same sense. The emphasis is on bilateral agreement, and it can only be made by a competent patient, and it should be given voluntarily. Now, consent should afford us some degree of protection that the patient has accepted the risk. Unfortunately, consent has become a potential minefield of legal liability, and it is not surprising that in our Indian courts, 2/3 of the verdict against doctors are for an invalid consent. This is according to the data from the Institute of Law and Medicine in Mumbai. So any litigation for negligence, the court may not really find negligence, but a flaw in consent is easy to find. The consent is scrutinized in two specific ways. Is there a consent? And is the consent valid, appropriate, and proper? The consequences of an inappropriate consent are dire. It is a criminal offense of assault and criminal force. It is a criminal offense under the MTP Act, PCPNDT Act, Transplantation of Human Organs Act, and in subjects of clinical trials. We must have a written informed consent. It is not having a consent is misconduct, and the National Medical Council or the State Medical Council can suspend or revoke our license to practice. Under the Consumer Protection Act, lack of consent is a deficiency of service and negligence, and we are liable for compensation. Just 2 days ago, the Maharashtra State Commission has awarded 29 lakhs to a patient for not informing her the risks of lap hysterectomy. So it is time to take anesthesia consent seriously. A formal written anesthesia consent is mandatory, as the risk of anesthesia for the patient are over and above the risk of surgery. And all-encompassing consent is not valid anymore. And obtaining this consent is a process, not an act of getting signatures on documents. This process needs to start at the time of the pre-anesthesia consultation, when the plan of anesthesia is to be finalized. The essentials of a legally appropriate consent in planned anesthesia procedures in non-emergency situations are: the patient must be competent to consent. The patient must be given enough information and time to make an informed choice, that is education. Patient must be given opportunity to discuss his doubts, fears, and concerns about the procedure, that is counseling. The patient must voluntarily come to an agreement about the plan. And the last is the consent or refusal must be properly documented and authenticated. This is in accordance with our main case law of Samira Kohli versus Dr. Prabha Manchanda, where consent has been discussed at length. First, let us go into the detail. The patient must be competent. That means the patient must be an adult of more than 18 years, of sound mind, not unconscious, and not under the effect of alcohol or drugs. Incompetent patients need a proxy consent from parents, guardians, and near relatives. If there is a competent patient, take his signature first. In this case, a 70-year-old man went for a colonoscopy and had complications and died. In a suit for negligence, it was found that only the daughter had signed the consent form and not the competent patient, and 5 lakhs has been awarded for an invalid consent. The consent needs to be free and voluntary, and for that, the patient needs information. The patient charter, drafted by the Ministry of Health and Family Welfare in 2018, gives the patient the right to information and the right to informed consent. It is the doctor's duty to provide this information. Now, the next part is the most important aspect of consent, that is counseling, giving information and education. So in this part, we are supposed to inform the patient about the proposed plan for anesthesia, whether it is a GA, a spinal or regional or peripheral blocks. Any options if available. If the patient is anxious and does not want a regional block or wants a general anesthesia only. Benefits of each intervention need to be discussed. Other interventions like central lines, arterial line, all post-op pain relief procedures like epidural, caudal, post-op plan for ICU stay or ventilation in high-risk patients, plan for blood or blood products need to be mentioned in our consent. The blood and blood products need a separate consent explaining the risk of HIV. If a team is going to look after the patient perioperatively, that also must be mentioned. We cannot go beyond the terms of our consent, even in the patient's interest, except in an emergency situation, as stated in the Samira Kohli judgment. Disclosure of risk is very, very important. Risks not told or not informed is one of the most common causes for the consent to be held invalid. Now, there is a dilemma on how much to tell. So what Samira Kohli judgment says is that we need what is called as a real consent, and the common risk must be told. For example, the risk of PDPH after spinal anesthesia must be told, but cortical venous thrombosis need not be explained. The remote risks need not be explained, which may frighten or confuse the patient. At the same time, if you want to make the consent more patient-centric, their questions or doubts must be addressed. The risk related to comorbidities must also be mentioned. Diabetes, hypertension, asthma, obesity, and frailty. These are patient factors which add to anesthesia risk. These work in our favor when complications take place, so they must be mentioned. Now, the risks that have been explained must be documented in the consent form. The more risks disclosed, the safer you are. Other special disclosures can be made in good faith, and the courts take a positive inference from these disclosures. In this first Rano Devi case, it was informed to the relatives that the blood bank is not available on the premises, and the verdict went in favor of the doctor. In the Bijoy Sinha Roy case, a high-risk patient was done in a hospital which did not have a backup of an ICU and a ventilator, and the verdict has gone against the doctor. In the next case, that is Sri Sambhunath Das, the doctor was not available for post-op care and some complications happened, and the doctor has been fined 50,000 for not mentioning this in the consent. Sri Chitra Institute has been fined ₹1,00,000 for telecasting a procedure without a specific consent from the patient. Our consent form is actually the evidence of the agreement for the final plan for anesthesia. The forms must not be fully printed, and they must have blank spaces for the name of the patient, name of the anesthetist, name of the procedure, basically individualization. The consent forms must be in the patient's language, or it is better to use an interpreter. The number of the interpreter, telephone number, must be mentioned if we are using one. The risk explained must be filled in detail in the consent form. I'm saying this over and over again because it is very important. Now, overwriting and erasures in the consent form were held to be were held that the consent is invalid in this Padmavati versus Dr. M. Vijayendra case in 2010, and a compensation of 2,03,000 rupees has been awarded for an invalid consent. The consent or refusal has to be documented, and interestingly, the patient can retract his consent even on the table. Finally, the authentication with signatures of the competent patient and the anesthetist is to be done. The date and time of this signing of this agreement must be noted, and this signature is usually held valid for 24 hours. Witnesses are optional for signatures. It is more for our protection. So someone from our staff who can be traced can be a witness. In this very interesting case of Mrs. Indu Sharma versus Indraprasth Apollo Hospitals, a cerebral palsy child was born after a very prolonged labor. The gynecologist defended by saying that there was no consent, but the doctors could not produce a signed refusal for LSES, and 1,10,00,000 lakhs has been awarded as compensation for negligence and not having a documented refusal. Let us look at consent in special situations. In an emergency, consent is not required to save life and limb, to stabilize the patient, and to prevent deterioration. The Supreme Court has very clearly said that human life is more important than legal formalities. Consent in an emergency, we must not wait for relatives to sign if an emergency surgery is required. There is no consent of the relatives required to transfer a patient to a higher center for better care to save life. In the ICU, consent from relatives is not required to intubate and ventilate in an emergency. As soon as the relatives are available, one can update them on the situation. In this interesting case of Shashikant Sharma versus Dr. Mohanlal Sidwani, the doctors did not inform the relatives that the patient was brain dead. And the courts have held that keeping a brain dead patient on a ventilator without an express written consent is deficiency of service. and compensation has been awarded. Consent for euthanasia, active or passive, in 1996, assisted suicide and euthanasia has been held unlawful in India. This position remains, except that in Aruna Shanbag versus Union of India in 2011, passive euthanasia has been allowed in exceptional cases under the strict monitoring of court. In 2018, passive euthanasia is legally permitted using the best interest of the patient principle that has to be applied. A decision to be taken by a panel of doctors and informed to the relatives. You have to give them a cooling period, maximum of 15 days, and then approach the courts. Removing life support to an incompetent patient, only the High Court can grant permission under Section 12. Application to the Chief Justice will form a bench of 2 lawyers plus a medical board of a neurologist, psychiatrist, and physician, and this decision to be conveyed to the relatives to hear their side. DNR consents are very, very important. DNR consents must be preceded by a counseling by a senior consultant. All information about the present condition of the patient must be mentioned in the DNR consents. The reasons for the DNR must be clearly mentioned, and the consequences of DNR must be clearly documented. In this interesting case, the Apollo Specialty Hospital, Chennai, were awarded a fine of 20 lakh rupees for doing a DNR without consent. This was overturned by the National Commission because the DNR consent, a very detailed DNR consent, was produced by the Apollo Hospital. Advanced medical directives or wishes of the patient need to be added in the consent, but there is a caution about these directives because it may be made by a suicidal tendency person or may be written in depression. In case of any doubt, one just acts in the interest of the patient. Consent from relatives is not required for post-mortem. In fact, if the consent is not obtained, then it may be held as deficiency of service. A patient in labor is not going to be able to receive information about epidural anesthesia. So information must be given to all parturients visiting antenatal clinic starting from the 7th month onwards. Dr. Ketan Parekh has done a wonderful job of printing these booklets, and one can use these very, very effectively. So this well-informed patient just has to sign on the consent form if she needs painless labor. Consent for MTP and sterilization is important. A girl less than 18 cannot sign for her MTP. Parents and guardian need to sign. A woman more than 18 years can consent to terminate her can consent to terminate her pregnancy. Even her husband's signature is not required. In sterilization procedures of tubectomy and vasectomy, spouse's signature is mandatory. For consent in children, any child less than 18 years needs one parent's signature for surgery, to consent for surgery. In the Indian Penal Code, section 89 and 90, the consenting age is mentioned as 12 years. So it is advisable to take an assent of an adolescent patient more than 12 years and less than 18 years, along with patient's signature, after giving them information which is age specific to allay anxiety. Death on table consent is considered bad in law because no person should have to sign his life away. A high-risk consent mentioning critical risks like cardiac arrest, cardiac failure, respiratory failure, need for ICU and ventilation is usually enough. The details of the risk or the possibility of death can be discussed with the next of kin. Video consent is the best evidence of a consent taken and the counseling related to risk done. Before starting the recording, the consent, it's why it is going to be done, and its recording and its use we have to take a consent from the patient. The consent must state the purpose of the video, what it is going to be used for, like a medico-legal purpose. The script should be ready with some preparation on the FAQs, and the infrastructure to record and save this consent must be available. Patient privacy and confidentiality must be ensured. Better to have the patient's relatives in the video. There are some confounding judgments on consent which have come out recently. In 2010, there was this case of Vinod Khanna versus R.G. Stone Urology Hospital, where no consent was found, but the judgment had an obiter dicta which said that it has been observed that the practice of using pre-printed consent forms which can fit into any procedure and later on filling the gaps is procedural arbitrariness and amounts to unfair trade practice and has imposed a cost of 10 lakhs on the hospital to be paid into the consumer legal aid account. Now, does that mean that pre-printed consent forms are banned? No, for the time being, there's a stay order on this by the Supreme Court, and we continue to use pre-printed consent forms till some new directive comes. Another confounding judgment is Dr. Harish Kumar Khurana versus Joginder Singh. Here, a patient undergoes 2 surgeries in the same hospital, same surgeon, and the same anesthesiologist. The first surgery was uneventful. During the second surgery, while giving anesthesia, the patient had a cardiac arrest and died. A suit was filed in the Supreme Court for an invalid consent for the second surgery, as only the husband had signed and the patient had not signed this consent. Shockingly, it has been held by the apex court that it is an appropriate consent. So this is totally in opposition to the stand taken in other cases by the same court. So please do not take this as a precedent and continue to take patients' consent, competent patients' consent for every surgery. Now, to achieve a high quality patient-centric consent in planned procedures, what we need really is a consent interview at the time of pre-anesthesia consultation. We have to factor in time for the pre-anesthesia consultations, followed by an informed consent interview. Consent should only be taken after counseling and discussion, and it's advisable to do it 2 to 3 days prior to the date of surgery to facilitate an unhurried, uncoerced decision and to allow time to obtain more information if required and to review decisions taken. In France, there is a law which says that planned procedures cannot be done without a pre-surgery consent, which has to be more than 2 days prior to the date of surgery. Documentations of the points of discussion or even a video recording of all consent interviews, I feel, is now going to become necessary. Daycare and late admissions must have a prior interview in a pre-assessment anesthesia clinic. We can use technology. We can do video consultations and use interactive computers, educational videos to improve understanding. Let me conclude by saying that a valid consent is a very valuable thing for our medico-legal survival. And we must pay attention to a few Ds. That dialogue is more important than the details, because cleverly drafted printed consents will not have any value if the patient or the relatives say that they were not allowed to take time to read it or that they did not understand what was written. So documentation of the details of the dialogue and the discussion make consent into a formidable defense, a true shield from litigation. Thank you.
A very detailed and informative talk by Ben. Can we have all the panelists and all other people, all the speakers here? Dr. Srinivas, sorry, I could not have your introduction slide there. Please introduce yourself.
Yeah, I am Dr. Srinivaslu. I am professor at Vijayanagara Institute of Medical Sciences, Ballari. And I was ex-president of ISA Karnataka chapter.
Great, thank you, sir.
I'm Dr. Sadhana. I'm Dr. Sadhana in name of that Himanshi, because I'm using her computer. I'm Dr. Sadhana Samvatsarkar, Dean and Professor Medical LNCT Medical College, Indore.
Thank you, ma'am. Dr. Arun Mehra is also there with us. He's a senior anesthesiologist in Delhi. He has done MBA from famous Faculty of Management, FMS Delhi University. He has done certificate in bioethics and human rights from UNESCO, and he is a faculty member for the Indian programs in bioethics. We also welcome to Dr. Arun Mehra. Are you here?
Yes, thank you, Dr. Arvind. Thank you.
And myself, I will introduce myself also. I am Dr. Arvind Arya.
I will give Dr. Arvind's introduction. Dr. Arvind is the head of the Department of Neuroanesthesia at the Institute of Human Behavior and Allied Sciences in Delhi, which, apart from psychiatry, covers neurosurgery and many other aspects. And he is also an LLB, LLM, and an MBA.
So, thank you, Dr. Arun Mehra, for
should we conclude it here?
Madam, we can have one or two questions between us, actually. Fine. Can we ask?
We are already late, basically.
Okay. Dr. Prithiva Kare ma'am, actually, we have a lot of discussions about the informed consent. Actually, now we follow everything according to the Samira Kohli versus Dr. Prithiva Manchanda. Actually, they have written beautifully, and they have described the difference between the real consent and the informed consent. Can you have some emphasis about the informed consent, how they are different from the real consent?
Well, informed consent is what they practice in the US, that every risk has to be informed to every patient. So it's a standard procedure that they do not want to take any chances. Only thing, our education does not allow this. Ideally, it's really very good for all of us if we could just discuss all the risks. But our education of our patients and the fact that they may just refuse surgery, if you hear, in fact, this was very well seen with the vaccination. Initially, our COVID vaccination came with a consent form.
Yeah.
But patients, even doctors, when they read that consent form, they said, we don't want the vaccination. Because if you have an informed consent, we would feel that, all these things are going to happen to us. So they had to withdraw that informed consent. So the courts are also, I think, they are not really putting their mind to, their decisions.
because we cannot, it's absolutely a mission impossible to take a fully informed consent. Patient and the surgeons will just drop you if you start explaining everything to the patients. Even our risks, we have to talk very, very, kind of guardedly about the risks, because the surgeons otherwise are very upset. So we have a different problem. In the US, there is no, it is a mandatory requirement. So there is no debate on that.
Madam, one
Actually,
more
ma'am, the
question.
crux of the Samira Kohli case was actually, ma'am, one should not have the blanket consent for every procedure. One, secondly, I think the important thing was that the specific consent. In this case, that when you are going for some procedure, you can't go for another procedure in the same patient again.
So basically, what we need to understand from this, that all our central lines are post-op. So many times we don't take any separate consent for our epidural, because we say it's in the interest of the patient. But any complications happens about that, the court is going to say, was a consent taken for epidural, or was it consent taken for the central line, which all has their own complications.
Madam, one more thing. During this COVID era, we used to ask the patient that patient is getting bad. We want to intubate the patient and put him on controlled ventilation. Many of the patients were not giving the consent. What many? 99% of the patients were not giving consent, thinking that once the patient goes on to the complete ventilatory support, patient will not recover. They used to ask us how many patients have survived by putting them on the ventilator. So we could not intubate many patients, and we could not give them a chance to survive also.
At that point, I feel that means I don't know what the policy of the hospital is, but in an emergency, I feel that if you feel that you can save, you should.
Yes.
During COVID scenario, ma'am, we have seen many times, because attendant were not allowed to come to the ICUs into the emergencies, and the real problems were the two things.
And there was a lot of suspicion. There was a lot of suspicion. I mean, every person felt that my patient has not been treated properly.
Yeah.
Because the outcomes were so erratic that they could
there
not.
were also the issues of the distributive justice. Dr. Arun Mehra, can you focus about these? Can you elaborate in a one or two sentences about the distributive justice we have seen during the period of COVID?
Sorry, about what justice, Dr. Arvind?
Distributive justice. We have seen a lot of problems. We are having lack of the beds, lack of the ventilators, lack of medical equipments, PPEs during this period.
Yes, Dr. Arvind. Distributive justice is a very difficult thing in this kind of situation, where the demand far outstrips the resources that are available. And basically, this is something that we have been discussing again and again in our bioethics groups, because on the one hand, we talk of equality and equity, but it also brings in the question of the utilitarian principle, where to save the many, you may have to, for the maximum benefit of the many, what do you really have to do? And that is where the issue of giving a preferential treatment to doctors and to other healthcare workers comes in, because they are the ones who, if they are saved, they will be saving the others also. So it becomes a Bahujan Hitai, Bahujan Sukhai kind of situation. But there have been objections to that, this actually goes to violating another principle of bioethics, which is non-discrimination. So basically, and the third problem that arises here is that having to take such decisions has resulted in a moral injury for doctors. They may have their set guidelines made by the government or by the higher authorities, but even following them, if you have got two patients and you give preference to one over the other, you carry a guilt for the rest of your life. So, but still, I'll say that the guidelines are a must, because one of my friends who is an anesthesiologist in Aberdeen in Scotland was telling me that out there they don't even consider for ventilation. I mean, this was at the height of the first and the second waves. They don't even consider a person about 65 or 70 for ventilation, which again will cause moral injury to the doctor. But it's based more on a more utilitarian is a very polite word to use because that is the word we use in this particular context. But a more brute word would be looking at in a brutal manner what is practical.
Dr. Srinivas, there is one question for you actually. I have faced twice and twice the big problem actually, and I discussed many in the East Delhi anesthesia forum. I stay in East Delhi actually. There are few cases which happened, and if there is a problem for the freelancing practitioners actually, if they face some cardiac arrest on the table, really they don't know what they have to do actually. So you can tell in one or two lines what actually they should follow.
Is a question for me, no?
Yes, sir, Dr. Srinivas.
Yeah, whenever there is cardiac arrest, we should follow the protocol first. And if you can send the message to the attenders that you can update the patient about the situation, actual situation, that patient is in a serious state, we are trying to save him. That should be informed to the patient attenders. Somebody can go out and inform them. Meanwhile, we should continue with the arrest. As Dr. Pratibha told, in the interest of the patient, we have to do the resuscitation protocol to save the patient's life. That's important.
Here I would quote one example. Actually, we had a patient of splenic injury. He had twice cardiac arrest before he could induce. Surgeon was also saying that we don't conduct the case now. But then it was me who insisted on the surgeon that you should operate this patient. And luckily that patient was saved. He went home. Twice he had an arrest.
Yeah, this blunt injury abdomen, many times it will pose a problem. Patient will be in hypotension, they are trying to resist.
Exactly, but it had happened before induction only. First we resuscitated the patient.
Yeah.
Then after a few minutes when we were about to induce, taking all the consent from the relatives and all, informing everything to the relatives also were this thing, yes, we should go ahead with the surgery part. But the surgeon
here
was
the resuscitation part and surgery should go simultaneously.
Exactly. No, but it happened like that we could say resuscitate the patient, and then again he went into arrest. That time surgeon said, I don't want to operate. Then it was the anesthetist. He told also, if this patient goes alive, it would be on your name that you have resuscitated the patient and patient is going home. And ultimately that patient went home.
Yeah, that's good.
Dr. Srinivas, actually, I have studied for last 5-year cases in Delhi Medical Council, the cardiac arrest on the tables actually, and we have found the most have gone just because of two reasons. One, when the patient transferred to the other hospitals or to the ICUs were not proper, it was not taken due care. I have seen that there were no notes of anesthesiologist or a surgeon being transfer of the patient. Even anesthesiologist, they should go along with the patient to transfer to the other patient. One. Secondly, there was not a proper the consent, and also secondly the notes were not proper. The documentation is the biggest thing. Only the court sees your documentation. That is the only thing. And Dr. Shadna, there is one question for you. Actually, I have seen many people problems because of the look-alike and sound-alike problems. Actually, I have seen one case in my post-op when a staff gave Vacron when we asked the patient, she has to give the Boveron. Actually, it's a diclofenac. So luckily, the patient was survived because we have seen patient have the desaturations immediately. So my direct question to you is, what should be the practical guidelines one should follow in a 3 or 4 minutes to check how to prevent these errors?
One is to make the checklist, labeling the syringes very well, and another thing what we have been told was, do not trust on anybody, trust yourselves and give the drugs. That is what we.
They will
I
cause
also
many
teach
times
every
problem
time.
like atropine and atracurium. You have
Yeah.
to, it is very
Yeah,
difficult
yeah.
sometimes
Very
because
difficult.
whether you are going atropine or
And when you
atracurium.
ask somebody to fill the drugs, it always becomes a problem for you actually.
So
Because you ask.
what you follow actually in many institutes and the technicians usually load the drugs actually. In our
But many a
institute,
times
yeah.
what we say that you keep the ampoule along with the syringe as well, so that the drug errors are less then.
Actually, I also like to load the drugs myself.
Yeah. I encountered one problem. Actually, I was in the OT in the post-op. From the post-op, we got a call that patient is restless.
Yeah.
Okay, when we went there, he had given some antibiotic, but when we examined, it was Vecurol. So immediately we brought him to the OT, could intubate, and somehow could save the. What happens is usually in small nursing homes, they will prescribe the drugs to the patient, and all the drugs belonging to the patient will be with the patient only. Sometimes these accidents can happen, so better to keep all the anesthetic drugs out of anybody's reach in the ward. Better is to keep them in the OT only. Yeah.
I'll tell you, sir, in this regard, I also have had one experience. We were called to the ICU for intubating a patient for elective ventilation, to the CCU actually. So I went there with my technician. We loaded succinylcholine in order to intubate him. We were not directly, I mean, I'm talking of long ago, we were not directly intubating on vicuronium at that time. And just a minute later, I asked the sister, what about the succinylcholine I asked you to load? She said, I have given it. Fortunately, we had carried our laryngoscopes and everything, and instantly we intubated that patient. No harm came of it. But after that, I made a rule in my department that nobody will give an injection except either the anesthesiologist or the accompanying technician. That was in cardiac anesthesia, and I had a very reliable technician. There are other technicians who I will not trust for this.
Yes.
And
I think Doctor,
They're not
we should
labeled as
conclude the
well.
session. Actually, I think Dr. Mukul Kapoor sir, I am seeing him. Good evening, sir. And we can conclude this session. Actually, thank you all the speakers.
Okay,
And,
Dr. Arvind, I'll just add one last point. Dr. Pratibha Madam mentioned that later on people claim that they don't
Know about the condition.
understand the form. When I was in cardiac anesthesia, I was in that for 8 years. And apart from the surgery, anesthesia, and indemnity consents, we had a Hindi consent also. कि मुझे, I mean, Delhi has Hindi as its language. मुझे मेरी भाषा में
Most institutions
it's
now
a
have a
bilingual actually.
three.
You should
bilingual or
have your
trilingual.
local language there. So in most of the institute now we are having a bilingual consent actually.
Yeah, that should be there always.
So we should
Local
conclude
language
this
should
session, and
always be.
we are having the one panel discussions. Over to you, Dr. Mukul Kapoor sir.
Thank you very much, sir.
Okay,
Thank you,
so
Dr.
much.
Arya.
Thank you so much.
Eager to hear your
Very good
eager to
session.
hear your discussion,
Thank
sir.
you.
Yeah.
Thank you.
Bye.
Wondering where the organizers are.
Sir, actually, organizers are not there. I think you have to start. I also started my session my own actually.
On my own. Okay, on your own. So I'll have to play the recording which I have.
Nice, no problem, sir. You can carry on.
I can do that. I can do that. Not a big problem. I'll just do it.
Sir, can we start the session?
Yeah, we can. If you got the recording, I would love you to start it. Otherwise, I'm starting on my own.
Okay, sir. Okay.
You are going to run it, please? You got a recording, please? Yeah, okay, great. And this is my own, I can't introduce myself. There's some. Excuse me, whoever's in the technical side, can you please run our video rather than running this like this? That's well done. Or should I run it on my own?
Yes, sir. Yes, sir. I played. Okay.
You play the video because I have introduced people that properly, not like this.
Okay, sir. Okay, sir. Okay.
Good evening, everybody. Welcome to this panel discussion on cardiac and today we will be discussing a case of ischemic cardiomyopathy, a patient with a left ventricular ejection fraction of 30% for laparoscopic cholecystectomy. Along with me, I've got an esteemed list of panelists. The panelists are Dr. Ramesh Patel, Dr. Vijesh Venugopal, Dr. Venugopal Kulkarni, and Dr. Vinita Panigrahi. I'll introduce each one of them. Dr. Vijesh Venugopal is a professor and head of anesthesiology at KMCT Medical College, Calicut in Kerala. He is basically a cardiac anesthesiologist who has also won the COPS Award in the pain category. He has got 12 publications nationally and internationally in peer-reviewed journals. The second panelist is Dr. Ramesh Patel. Dr. Ramesh Patel is the professor of cardiac anesthesiology at UN Mehta Institute of Cardiology and Research Center. He has got 22 publications. UN Mehta Institute of Cardiology, as you know, is a premier cardiology institute of Gujarat. The third panelist is Dr. Vinita Panigrahi. She is the senior consultant and head of emergency services at the Tata Main Hospital, Jamshedpur, a very prestigious institute. She has got a lot of teaching experience, basically in the field of critical care, and she's a DNB teacher for critical care. She's also been awarded with the VG Appakutti Gold Medal for DNB anesthesia. She's got 7 national and international publications. The last panelist is Dr. Venugopal Kulkarni. Dr. Venugopal Kulkarni is the head of the Department of Anesthesiology at the Citizens Specialty Hospital, Hyderabad. His keen interest in TE has landed him with a gold medal in 2016 for TE. He has got 12 publications and is basically a cardiac anesthesiologist. So we start off with the panel discussion and we discuss the case scenario. A 64-year-old male patient is scheduled for laparoscopic cholecystectomy. The patient is a diagnosed case of ischemic cardiomyopathy and has also got diabetes mellitus. An echo of the patient was done as a routine 15 days back, which had revealed a moderate mitral regurgitation with an LV ejection fraction of 30%, but no regional wall motion anomaly was there. The patient also gives history of having a coronary angiography done about 2 years back, which showed a non-significant diffuse coronary disease, but the lesions were not did not require any intervention because they were between 40 and 50% of the vessel diameter. On eliciting history, the patient gives history of being on statin therapy and on oral antidiabetics. The patient is not at present on any vasoactive medication. He presented with biliary colic about 2 days back, which was relieved by antispasmodics prescribed by a general practitioner. He has history of multiple such episodes in the last 2 weeks. Ultrasound done showed multiple small calculi in the gallbladder. His diabetic control is reasonably good, and over the last 2 years, though it used to be irregular earlier, but for the last 2 years, his diabetic control has been very good because he was told that you've got cardiomyopathy and you better control your diabetes. He has got history of peptic ulceration and has been on proton pump inhibitors for gastric reflux disease for the last few years. Patient has no other significant history. On clinical examination, his heart rate is 90, blood pressure 104/72, a respiratory rate of 16. His BMI is 30, but he's got a normal sinus rhythm. On examination, he also shows mild pedal edema. His chest is clear. Investigation reveals a slight bit of anemia, that is, his hemoglobin is 7.5. Blood sugar is 178. His SGOT is mildly raised to 124, SGPT 118, alkaline phosphatase to 76. His creatinine is 1.7, just as borderline kidney injury. HbA1c 6.9. His pro-BNP is about 500. ECG is within normal limits. X-ray is generally clear except for mild cardiomegaly. All other investigations are essentially normal. So now that I've described the case, I would like to ask our esteemed panelists certain questions, basically to explain to the delegates how we should manage this case. My first question is directed to Dr. Kulkarni. Dr. Kulkarni, I would like to ask you, would you like to accept this case with the available data, or would you like a more comprehensive evaluation, optimization of the case before you take up the case for surgery?
So I think some more optimization, some more details are required. For example, in this patient, echo, we only have half the details. We don't know about the diastolic function of the left ventricle. We don't know about the right heart. We don't know about the whether there is any increased pulmonary artery pressure. So these data are required. And there is elevated creatinine. We need to know about what is the renal function. And we need, because the hemoglobin is less, we need further optimization on that. And we also need to see whether we can do early versus delayed cholecystectomy in this patient. With the surgeon, I would have more details. And also, like whether we can do an angiogram or a stress echo to see what is the reserve of the heart is one more thing that we can look into.
Thank you, Dr. Kulkarni. Dr. Binita wants to add something.
A few information in the form of his functional status. So what is his MET level? Whether he has had any history of orthopnea or paroxysmal nocturnal dyspnea. And does he have a hepatomegaly? Because his enzymes are slightly raised, showing a congestive hepatopathy. So whether the hepatomegaly is there or not. So I think these, and plus the BMI is on the borderline between overweight and obese. So does this patient have any symptoms of an obstructive sleep apnea? That information actually helps in planning out the intraoperative and also postoperative anesthesia. It will also help us in optimizing the patient better.
Okay. When I prepared this case scenario, I purposely kept it like this for a simple reason that the patient has got biliary colic, and the surgeon wants to say that he has to take the patient up immediately for surgery after an ERCP also. So in case that is so, there is no time more, no other time available. Now we have to take up this case for surgery. Dr. Binita, I would like to ask you, would you prefer to have a cardiac anesthetist or a cardiologist present in the OT when you are managing this case? And in case you want a cardiology or a cardiac anesthetist in the OT, for what reason would you like to have the person in the OT?
See, this patient already has cardiac risk factors. The age is there is ankle edema, and the LVEF is quite low. So we should expect rather an intraoperative myocardial ischemic episode, quite possible. So in this case, the presence of a cardiac anesthetist is very useful not only to early detect, but also to for a better monitoring and management intraoperative. So this patient would be taken up under invasive monitoring, and preferably a esophageal echocardiography also would be needed. So in these cases, analysis of the ST segment, managing the ischemia and also the hypertension, sometimes it could be refractory. So the presence of a cardiac anesthetist would be very, very safe for this patient.
Okay. I would agree with you. Yes, agree. But in case the other three panelists are cardiac anesthetists, do they feel they agree with this, or would they want something else? Anybody, any one of you, please. Dr.
Yes, sir, cardiac anesthetist and cardiologist presence will be very, very helpful because such disaster may happen on possibility of VT, VF or asystole. We have to put a temporary pacemaker. So all the things, all the complications, keep in mind for safer side, presence of cardiologist as well as cardiac anesthetist is very much helpful for the patient.
Thank you, Dr. Patel. I would disagree with you on one point only. The cardiologist. I would never allow a cardiologist in my OT. A cardiac anesthetist is very competent, and I would never allow a cardiologist. I've never allowed till date in my life any cardiologist in my OT. Anyway, so we go ahead. And my next question is directed to Dr. Vijesh. Dr. Vijesh, what is your recommendation about the level of the hospital which can deal with such a case? And what should be the level of monitoring which should be available? Supposing it has come to a nursing home, would you like to do it in a nursing home, or would you like to say that, no, this has to be done at a particular level of the hospital?
I think it would be better to do this at a tertiary care level hospital. And prevention of cardiovascular complications may be accomplished through a sound understanding of the hemodynamic and physiological consequences of laparoscopic surgery, as well as a defined operative plan that can be generated by a multidisciplinary team involving the surgeon, the anesthesiologist, as well as the cardiologist. Coming to the level of monitoring, I think in addition to the minimum mandatory monitoring of ASA standard, we should also include the hemodynamic monitoring using the arterial line, and probably also have a close monitoring of the intra-abdominal pressure and the urine output, and also a few serial ABGs can be done, and glycemia monitoring is also important in this case.
Thank you, Dr. Vijesh. I agree with you, very much agree with you. It's very important that such cases be done only at a tertiary care hospital and not be taken up by chance in a small hospital. Because these patients can always, the balance can tilt in these patients at any stage, and they may require their nephrologist to manage the post-operative renal function, or may go into low cardiac output states, and they need a lot of hemodynamic support. So it's a very important thing that they should be managed in a setup which is tuned for this, and that is a tertiary care hospital. Thank you very much. So my next question is directed towards Dr. Ramesh Patel. Dr. Ramesh Patel, the current hemoglobin level of this case is quite reasonably low. I would say not very low, but it's reasonably low. Would you like to build up the hemoglobin before you take up this case for surgery?
Yes, sir. Before taking patient in OT, I would like to optimize the hemoglobin level up to 9 to 10%, because it will very much it will be helpful in managing intraoperative hypoxia, and that will reduce the chances of ventilation perfusion mismatch. Chances of myocardial ischemia will be less. So I would like to optimize the hemoglobin up to 9.5 to 10.
Very much agree with you. Actually, this is one of the transfusion triggers recommended by the ASA. ASA says that in a patient who has got a cardiac disease but also has got symptomatology which is related to this, it is very important to have a hemoglobin around 10 at least in such patients. So you very rightly said that. And secondly, as you again pointed out, it is very important that a good hemoglobin is there, because as it is, the cardiac output is compromised, and we need better oxygen carrying capacity in the patient. That's right. So my next question is directed towards Dr. Kulkarni. Dr. Kulkarni, what do you feel are the issues for laparoscopic surgery in patients with poor cardiac function? What are the issues which are likely to happen, and what are the things you do to overcome this problem? Dr. Kulkarni, your voice is not audible now. Your mic is off. No, Dr. Kulkarni, your mic is off. Please put it on.
Yeah, fine. I mean, with laparoscopy, as we are insufflating carbon dioxide into the abdomen, the intra-abdominal pressure goes up. That causes reduction in the preload and also increase in the afterload. That puts a lot of stress on the hemodynamics, which is already stressed. So that is one of the major issues. And adding carbon dioxide will add to respiratory acidosis. That will further worsen the hemodynamics. And also you have positional issues, like we give some reverse Trendelenburg position for better visualization of the gallbladder. So we have to be careful when we are doing these things. We have to limit the intra-abdominal pressures, and we have to ensure that the carbon dioxide is in the normal range. So these adjustments we need to make. These are our main concerns.
So, Dr. Kulkarni, what about the PVR, SVR, the importance of that?
Yes, SVR goes up because afterload goes up, and then PVR also goes up because the carbon dioxide goes up, and then we are ventilating at a higher rate. So this puts, I mean, already we have a myocardial regurgitation patient, and the myocardial regurgitation worsens because SVR goes up. So yeah, I mean, we can go into, I mean, hypotension. All these things can result in cardiac output can go down.
Yes. So that's very important. So what very important to always regulate your cardiac output. So you have to sort of manipulate both the PVR as well as the SVR. You have to keep the SVR low as well as the PVR low so as to make the heart function better. So it's very important that we have to ask the surgeon not to insufflate at a very high pressure. Keep the pressures to 12 or less. That's a very important thing in this thing, so that the CO2 also doesn't build up. In case CO2 is building up, you have to hyperventilate and accordingly reduce the CO2. And in case your pressures are going up, the SVR will go up. So it is very important to regulate that. Okay, my next question is directed to Dr. Benita. Dr. Benita, would you like to tell the surgeon to rather cancel the case or do it as an open surgery? And explain your viewpoint. Why do you want to do whatever is your recommendation? Just explain that.
Laparoscopic has its own advantages. It has because of less tissue handling and less of ileus. So there are certain better wound healing. So there are certain advantages of laparoscopic surgery. Now, there are many studies and meta-analysis have been done that have compared laparoscopy with an open surgery. And they have said that there is no significant difference in the outcome. So in this case, because the patient is already a compromised patient, we would like to decrease the tissue handling and the risk of bleeding and chances of wound healing, atelectasis as much as possible. So it is better to avoid a open surgery. Now, since this patient is not very compromised, as is shown by the vitals given, he is about just borderline. So if the intraoperative hemodynamics are managed well, and if the surgeon cooperates and tries to keep the intra-abdominal pressure less than 15, then I think the laparoscopic surgery would be better for this patient.
Yes, I very much agree with you on that. The laparoscopic surgery is the only alternative, actually. Open surgery is out, and unfortunately, why I asked you this question purposely is, it was purposely asked because there are lots of our colleagues who believe that laparoscopic surgery cannot be done in such patients, and we should rather do open surgery because it's safe as far as the hemodynamics are concerned. Actually, it may be safe as far as hemodynamics are concerned, but the effects of open surgery, the effects on the pulmonary function post-operatively are very severe, and it is best avoided, and it should better to do an interventional laparoscopic surgery. Very well said, ma'am. Thank you very much. So,
and more so with a BMI of around 30. So we would do a minimally invasive surgery rather going for an open.
Okay, and my next question is directed towards Vijesh. Dr. Vijesh, can you recommend the sequence of induction, intubation in this case, and what kind of monitoring, invasive, non-invasive monitoring? When should you start the monitoring, and when should you do everything?
I would like to institute ECG, SpO2, all the minimum mandatory monitoring requirements in this patient, and I would like to take the patient up and under local anesthesia, put in and insert a 16 gauge peripheral venous line, radial arterial line, and central venous pressure monitoring. And after the radial arterial line is put, I would like to get a baseline ABG done. and would like to pre-oxygenate this patient for 3 minutes with 100% oxygen. And anesthesia, I would like to induce with accommodate. I would like to base my drugs on ideal body weight because patient is obese. So I would base my drug calculations on ideal body weight. I would like to give him midazolam 2 milligrams, fentanyl of around 2 microgram per kilogram. And I would like to use muscle relaxant rocuronium 1 milligram per kilogram, and would like to intubate him with an endotracheal tube because he's a long-standing diabetic with reflux disease. So an endotracheal tube would be the best conduit. I would like to insert the endotracheal tube, confirm it, and then secure it, and institute ETCO2 monitoring along with end-tidal anesthetic agent concentration. Also would like to monitor the peak airway pressures and would like to insert a Riles tube also in this patient because I would like to deflate the stomach not only to improve the surgical view but also to avoid gastric injury when the trocar is being inserted, and would insert a nasopharyngeal temperature probe and Foley's catheter to monitor the urine output. The patient would be ventilated using a 40-60 oxygen air mixture, and I would like to adjust his respirator rate to maintain a ETCO2 of around 35 millimeter mercury, and would like to observe the flow volume loops also. At this time, I would also like to institute or I would like to put in a TE and do a baseline monitoring of his LV function as well as the filling of the LV.
Thank you. So my next question is directed towards Dr. Ramesh Patel. Dr. Ramesh Patel, how would you like to maintain anesthesia in such a case? What are the issues during maintenance? What are the likely events which can occur during maintenance which you should be careful about?
Yes, sir. Patient is already induced with Dr. Vijay, sir. Now, I would like to maintain the anesthesia with inhalation anesthetics like sevoflurane, and with opioid and muscle relaxant intermittent, I will give bolus. And strict vigilance on hemodynamic parameter on multipara monitors. I would like to continuous watch on transesophageal echocardiography monitoring for left ventricular and diastolic diameter as well as left ventricular stress wall measurement. And of course, I have to keep watch on cardiac output and if possible, continuous cardiac output monitoring is very much helpful in intraoperative management of this patient.
So if, in case you're planning to do a continuous cardiac output monitoring, what monitor would you prefer using?
2-3 semi-invasive like direct flow track measurement or continuous cardiac output monitoring with pulmonary artery catheter insertion. So it will help in measurement of pulmonary capillary wedge pressure also. So it will be also very much helpful in titration of if any requirement of inotropes or
I would agree with you on PA catheter use, at least in this. Maybe, though I would not do, my personal view, of course, it is not, anybody has its own view. By personal views, I would not go in for so much of invasion as, because there's 30% or so ejection fraction. Maybe if required, yes, I can do something like a flow track or something. Maybe that's the maximum I would go, but not definitely not. Definitely not a PA catheter. Even flow track, I won't go in for even a flow track actually, or a Vigilio. Okay.
So, sir, you will like to insert TE or not?
TE, yes. TE definitely. TE is a very useful tool, which is definitely a very much required. And the one thing which I will worry about is in case the CO2 goes up, this patient is likely to go in for VTs and VTECs. So that is something I will be worried about, and I'll be very careful about maintaining my carbon dioxide levels in such a manner that this patient does not go in for such a thing. Okay, my next question is directed towards Dr. Kulkarni. Dr. Kulkarni, in case this patient has got develops intraoperative hypotension, how would you like to manage it?
Sir, my first step would be to give fluids so that adequate preload is there, especially with the patient with mitral regurgitation. I know the ejection fraction is less, but usually these patients are in the managed by the cardiologist in the preoperative setting, they usually are hypovolemic. So I would give some fluids, see what is the response of the fluids, and titrate the fluids appropriately. The other thing is to reduce the intra-abdominal pressure, see if there is any bleeding happening, which is like with a good surgeon, and it's not very vascular usually. So if it may not be bleeding that much, if there is a bleeding, we have to give some more volume. So these are the things that I would do, and see what is the intrathoracic pressure, because intrathoracic pressure also further reduces the venous return and can cause hypotension. So next is whether like we need to, the next option is to use some inotropes if it doesn't counter with that. And the third would be to use vasopressors, but the vasopressor is double-edged because it can worsen the MR. So I will be very careful when you're using vasopressors, and probably as a last resort, IBP, because it reduces the SVR and increases the forward flow. Yeah, I would not go to that extent, but it's a last option.
Yes. Thank you very much. Okay, Dr. Ramesh, again on you. What would you recommend as the protocol for reversal and emergence from anesthesia?
In such cases, we don't think of extubation on table. So I would like to shift the patient in high-end ICUs and will like to ventilate for 2-3 hours, and strict vigilance on hemodynamic parameters and periodic echocardiography as well as ABGs. So because after desufflation, CO2 will remain high in ABGs, so we have to keep watch on that. And strict pain management is also required, because while extubation, tachycardia is not helpful. Tachycardia is very much harmful to this patient. So I would like to watch for the patient for 3-4 hours in the ICU.
I would not, I mean, if you ask me personally, I would never ventilate such a patient. After left coli in the ICU, I would try to, I'll do a very slow, gradual extubation, ensuring that there's a washout of all the anesthetic gases, and maybe keep the patient in a semi-deep level and extubate. Because though he's obese, I would like to him to maintain his airway, of course, but I will not go to an extreme measure of ventilating for lab coli at least. But I don't know, the other panelists, if they have other views, they can always express it. Anybody wants to express something different? Dr.
Yeah, I would also, I am also in favor of extubating the patient on table. So preferably in a lighter plane of anesthesia when the patient is a little awake and able to maintain his reflexes. The reason being, if the pain has been adequately taken care of and patient is not very sedated, this obese patient, we would like to take him out in a lighter plane. And because of his BMI and also the fact that it is a laparoscopic surgery in the upper abdomen, so CPAP support for a few hours in the postoperative recovery would be helpful for him. And of course, we'll have to do a ABG monitoring to see that there is no carbon dioxide, PCO2 is not rising.
So a very good method of extubating such patients is to extubate them in semi-sitting position rather than extubating them lying down. It's very helpful in doing it. Okay, my next question, short answer, not two answers because the time is getting over. So Dr. Vinita, what would you recommend for post-operative pain relief? Anything special?
Basically, I would avoid a sedation. So a paracetamol and a light opioid, maybe tramadol would be okay. Port infiltration is a very helpful method in lap colis. It brings down the pain, but it will not reduce the pain in the right shoulder. So preferably when the surgeon is taking the trocar out, if there is a little infiltration of lidocaine in the peritoneal cavity, that's a very good modality. I think that will be good enough.
Yeah.
Patient control. Sorry.
Yeah, I agree with you very much. Actually, we don't need much of analgesia in this, except for port infiltration and maybe intraperitoneal installation of a local anesthetic. That's the best way. Why, again, I raise this question is a lot of people have a tendency thinking that the patient has cardiac problems. So we should have a very high level of analgesia. It's generally not required after cholecystectomy. Thank you. And so my last question is directed towards Dr. Vijesh. Dr. Vijesh, what would be your recommendation for post-operative care? That is the level of care, ICU, HDU, or ward?
Now, in the early post-operative period, I would like to put this patient in the ICU. especially because he's having a cardiovascular disease and he's more prone to hemodynamic changes and instabilities. So in these patients, probably the first 3 hours are very crucial because they can develop congestive heart failure. And so it's very important that we monitor for symptoms of myocardial ischemia and heart failure in the immediate postoperative period. So we should always keep a watch for the development of myocardial injury after non-cardiac surgery, MINS, which is quite common. So I would like to do even troponin measurements for this patient immediate postoperative so that I can know whether there is any issue that has cropped up. Also, we would like to give him good pain relief, as well as we should take care of the postoperative nausea and vomiting, which is very common with laparoscopic surgeries. So these are the 3 things that I would like to do. And probably after 24 hours in the ICU, I would shift him to the HDU and then later to the ward.
Thank you, Dr. Vijay. I very much again agree with you. That's how it should be, because the post-operative period is as critical as the intraoperative period, or probably more critical, because the patient is not under the active watch of an anesthesiologist. So it is very important that post-operative period has to be done with a lot of care. They should be monitored continuously. They are very prone to arrhythmias, patients with such low ejection fraction, especially the ones who tend to accumulate carbon dioxide and develop hypercarbia, who are obese. So that's very important to see. I will have to, because of constraints of time, I'll have to end this panel discussion now. But I would like to thank the eminent panelists for a wonderful discourse. I'm sure everybody would have benefited from this wonderful panel discussion. All of you were great. My compliments to all of you for giving the best advice to the delegates. Thank you very much. Thank you very much, Isacon, for giving us all an opportunity to talk to all of them. Thank you very much, and good evening.
Thank you, sir.
Yeah, thank you.
Thank you.
Thank you.
There are no questions I can see in the chat box, at least. But a few people are attending live. One is Dr. Arvind Arya. And Dr. Arvind Arya, any questions from your side?
Sir, it was a really beautiful discussion you have actually, though I am not practicing other things, I am in neuroanesthesia. My direct question is if some patient having a compromised cardiac, just patients, and they are planned for the prone position surgeries, do you have some other suggestions from the panelist, what the precaution we should have in such a case when we are having too much of the hemodynamic instability in such cases?
I think generally, Arvind, the situation is just the same, similar, almost similar. And so it does not make a difference whether the patient is prone or patient is supine. As long as, we are able to see in prone, the basic problem which you may face is that if your cushioning is not proper and the chest wall movement is not proper, the compliance may be reduced. Compliance of the lung may be reduced. Ensure that good positioning is there. Otherwise, just exactly the same precautions which we have recommended for laparoscopic surgery. If Dr. Kulkarni or Dr. Vijesh, who are also there, if they have any other opinion, they can please do it.
My another question is, sir, the use of the TE, is it mandatory for in such cases? I know it is a very good, useful tool we are having, and we are using routinely for the neuro cases also, particularly posterior fossa tumors also. But I just want to know whether it is a very useful tool in a routine cases, all the cases.
See, Arvind, again, TE is a very, very useful tool, but it should be used judiciously. Somebody should understand TE, and only then it should be used. Not just not putting a probe is not enough. But what is very important is that, such patients who've got cardiomyopathy, they have a tendency of going into failure. If something goes wrong, either the SVR goes high or CO2 goes high, or something goes wrong, they have a tendency of going to arrhythmias, into lots of problems. So TB will give you a very good idea initially that your patient is going, your ejection fractions are falling, your patient's, is developing RWMA, whatever. So it's a very useful tool in patients who are bad. Maybe 30% is a borderline type of case. But anything below 30%, definitely you should always, in a major surgery, always put a TE. It is going to give you a lot of benefit.
Thank you, sir.
Thank you.
Yeah, I think even in case of cardiac surgeries, who have been seen extensively by the cardiologist, when we put a TE, there are many times we have changed the surgeries. For example, the patient would have been posted for DVR. We have done only one valve replacement and aortic valve was not done. Or sometimes CABG plus MVR was not done. Sometimes we have done single valve surgeries, but we have done, we had to do a DVR. So, putting a TE will change your diagnosis on table. Okay, so that will help to appropriately manage the patient intraoperatively.
The thing is, there's a big requirement today of non-cardiac anesthetists also to learn the basics of TE and understand the importance of TE. It's a very useful tool if the person understands it, actually.
Yes.
Actually, Dr. Mukul sir, I'll tell you, in one hospital where I was working, I requested them that I said, look, an ECG is just not enough for any patient who is above 40 years of age. And I'm not talking of TE, of course. I'm talking about the echo that is done externally with the help of a probe. And I said, look, why don't you get an echo done, because it's a non-invasive procedure and a very less time-consuming procedure for every patient who is above 40 or at least above 50, so that you know the cardiac status, because they had problems of patients who had not really been diagnosed and who had cardiac problems for even routine surgeries. So, you know what their problem was, that the surgeon will object, why are you increasing the expenditure for the patient and this and that. And yet the fact is that again, I'm talking of non-cardiac surgeries. A non-invasive procedure like an echo goes a long way in helping you to manage that patient, even a non-cardiac patient. That is my personal experience, sir.
Yeah. Arun, I would I'll tell you what the AHA or the ASA do not recommend echo at all. They're very scientific and they do not recommend echo routinely for anybody. What I personally follow is like this. What I do is anybody above 60, I definitely get an echo done, because I'm quite sure some amount of cardiac disease is a possibility. So I always get an echo. But it all depends on the degree of surgery.
Clinical presentation.
Also degree of surgery also. If it's a major surgery, I'll get it done. If it is not a major surgery, I might avoid it. But I always get an ECG done. And ECG has even a minor change, I will get an echo done. So that is what I follow.
So yes, now I remember I had made this recommendation for all laparoscopic surgeries, not for all surgeries, sir. For all laparoscopic surgeries, whether a lap chole or whatever. Yes, now I remember.
In laparoscopic surgeries up to 60, I do not do it as a routine. Above 60, yes, more likely that I'll do it as a routine. But unless the patient has got very is symptomatic for some reason, below 60 then. I don't know, Dr. Vijesh or Kulkarni, if you have any other.
In our hospital, we have made a thing like we have devised a major surgical profile, which comes as a package. It works economically for the patient. So in that we have echo and cardiology consultation. So it makes our life easy.
Okay. I'm personally, again, my personal thing, I don't send patients to cardiologists because I'm a cardiac anesthetist. Even for non-cardiac surgery, I look at the echo or whatever myself, and I don't send them to the cardiologist at all. But of course, you may not have the comfort. Others may not have the comfort, like Dr. Mehra or Dr. So he may not have the comfort of being proficient in.
Dr. Kulkarni, sir, I'll just add one point here.
Yeah.
You say it makes your life easy, but let's also remember the ethical dimension, because just before this we were having our session on medical ethics and law, and my own field is ethics basically. The ethical dimension, definitely, apart from making our own life easier, it's also safer for the patient. So I would definitely support your practice, sir. I would definitely support it, sir.
In fact, sir, what Dr. Mukul Kapoor was telling about anesthesiologist doing echocardiography, transthoracic echo is not very difficult. One can easily learn it as a screening echo, especially. We should all be able to do, because it's a very valuable tool. Only thing is, we should be able to bill for that. Otherwise, we should not do it.
Yes, of course, that is there. I think there are no more questions. Arun, you want to say something?
Yeah, I have one question for Dr. Arvind. He's the person who has studied law. Dr. Arvind, supposing I, as an anesthesiologist or any anesthesiologist, does a transthoracic echo, and we have our findings, and we proceed according to those findings. Tomorrow, would a court say, no, you are not authorized, you should have called in a cardiologist? Because this is a very gray area, and unfortunately, there is scary litigation here. Scary litigation.
No, no, no. You can absolutely, any anesthesiologist or intensivist, they are fully allowed as per law for doing the procedure. Actually, it's about the competency actually. Are you interpreting it is rightly or wrongly? That is the main thing. Secondly, the documentation. Actually, law never says that what you can do and what you cannot do. Law says that you have to do is judiciously, and here lies the test of prudence actually. Prudence means what is good for the patient, means what is the beneficence for the patient. If you are doing that way, and for the having this echo in both in the OT and ICU, law does allow on the intensivist and anesthesiologist for this purpose. But obviously, according to PNDT, you have to inform that you are not using these tools for the purpose of PNDT Act.
Thank you. I think we should let the ISA people continue with the next session. Thank you very much.
Now, probably this is the last session, sir.
So that is why we could do it. Okay. And it was very nice interacting with all of you. And I'm sure, I don't know how many people have heard it or heard the panel discussion, but if they have, I'm sure they would have benefited from it. Thank you very much, everybody.
Thank you. Thank you, sir.
Thank you, sir.
Thank you.
Right.